But the challenge is routine complex, which is high volume, high risk, and non-routine complex, which is low volume but high risk. So the entire, and then the general competency, what we did was any nurse who gets an independent patient assignment, general competency has to be followed. Post that, and it has to be, the accountability also was said that who will assess and who will grant. And plus, it's not that once it is done and it's sorted, it has to be renewed every year. And that was based on the type of the competency that we had. For routine complex, we only selected certain competencies that will require reassessment. Non-routine, but high and highly complex, that was reviewed annually. Based on this, again, this is a standard partners model. We thought novice, advanced, beginners, competent, proficient, and expert based on objectively what is the score that they get. They can do a self-assessment and then the trainers will assess them. I'll skip this because of the scarcity of time. So this is exactly what the tool is. All these are the various wards, the type of the nurses, and their competency levels. At a glance, I would know how many nurses, based on the levels, what is the competency.
1 minute left, sir.
Sorry? Yeah, ma'am, I know. Okay. Then what is the evaluation method that we use? Whether we observed it or whether actually it was under demonstration, or it is a written test, or it is under review. On a real-time basis, we get the entire information. What is the outcome of this? The outcome is that we knew exactly the targeted recruitment that they will do, because we knew what is the skill mix that we are lacking, or when someone goes. And it also helped us, and this is actual data, and this also helped us that specific activities pre and post implementation in terms of IV cannulation or BLS or ACLS. Nurses, because it was sort of a training and assessment also, it was almost 100% prior to this. The last bit, I'm sure everyone loves this, is the patient satisfaction also for this, and it went, and this was also objectively evaluated.
Check. How did the patient satisfaction go up based on the digital competency platform?
Because a lot of times there were complaints from the patient that the nurse was not skilled. And when they're pricking, we had a double prick and all. And this also, we have an online tool which we do it for all the patients, whether outpatients or inpatients. And hence, and those are also categorized. Every day in the morning meeting, these are discussed. Any negative comments are discussed, and all departments have to present. So that's how objectively it was identified.
And how do you how do we avoid bias in this assessment?
Because there are multiple instructors, so there's not one instructor which is aligned to a nurse and all. And the reassessment also can happen. Actually, because of scarcity of time, I skipped. The nurse can do a self-assessment also. So in case she's not happy and she thinks that I'm not novice, I'm a beginner, or I'm expert, she can do her assessment again, and that will go for a training. And so there's a tool for that also.
So the rankings are given after a weighted average or something from different assessors. Is that what?
Of course. And so it could be either, not everything is either written, or it could be either observed or written, or it could be, we can ask simulation also for them. So depending on each competency, that's also defined.
How often the competencies are assessed in a year per candidate?
So it depends on whether general competency is assessed once. The non-routine complex, that is assessed, few identify. Non-routine complex, that those are routine complex, few identified annually, and non-routine complex again annually.
So the non-routine complex are more high risk.
Both are high risk.
High risk. So
Correct.
if it is non-routine and they don't practice for a year, And
So-
then we are assessing in a year how.
They'll not get assignment then for such activities then. Hence, and that's what I said. So assignment of those patient
Practicality of that, like,
Yeah.
because here in a situation where in India, the nurses are getting assigned to patients. So keeping 1 year, how it is possible? Just wanted to know about it.
Okay.
Not assessing them and not allowing them to take care of patients. And
Yeah.
already it is non-routine. So the consistency of patient, especially in private hospital or the kind of hospitals we have.
Ma'am,
it's
agreed. So in
really
case,
differs.
noted, ma'am. So in case the nursing director feels that we have less skills in IV calculation because system is giving that absolute data, then she'll go for again training for that, because there's a clinical instructor also as part of this.
Thank you, thank you.
Uh, this is a tool which has been built in collaboration with the hospital. Yeah. So it is the hospital and the software vendor. They yeah. Not really. I mean, somewhere you'll have to learn. So that's how we have built this tool.
You can tell the name.
Sorry. No, I don't think so. We have any contracted nurses coming to. Yeah, all in house.
So you can tell the name of the partner also. It's a good branding stage that we have provided. So
Okay.
if father approves of it.
Okay. It's it's Trioti Technologies.
Thank you. So I know that. So through all the people, Triotri and Rajgiri, thank you very much
Thank you.
for this wonderful presentation. Next up, we're going with the host. So the Kalinga Institute of Medical Sciences. Do we have the Kalinga Institute of Medical Sciences team over here? So development of a training module on infection control practices for interns and postgraduate students. Okay. Next, we have Apollo Learning Together from Apollo Sage Hospitals. Do we have the team here? Yes, please. So jury members, we have the team from Apollo Sage Hospitals. Apollo Learning Together is the presentation. Over to you.
We'll go to the next presentation. I think the participants, please come forward during the tea break also. Please ensure, though you have sent it by mail, please ensure that it is available before presentation. So there's some, I request Apollo Sage Hospital, post tea break, we can have your session. Please just check your this thing.
Do we have Trauma Center, IMS BHU? Yeah, Trauma Center, IMS BHU is going to do a presentation on AI-powered antimicrobial stewardship initiative at Trauma Center. Oh, they got up and went out. That's not the team then. Sorry. The timing was perfect when I called out. They got up. Yeah. So any team who's here who's got your presentation ready? Yeah. AJ Hospital and Research Center. You're good to go? Yes. Okay. So we have AJ Insights, integrated data management and business intelligence platform. They were one of our finalists last year as well, if I remember right. Yeah. So AJ Hospital and Research Center, Karnataka.
Mic test? Yeah. Yeah. First of all, I would like to thank Kaho for giving us this opportunity to present our innovation in this platform. So the name of our innovation is AJ Insights. So it is an integrated data management and business intelligence platform. So as a digital ecosystem is evolving in healthcare sector, data becomes available, but not necessarily the relevant information is accessible, or it is what I can say is it is usable. So in that case, the senior leaders or the decision makers in the hospital, they feel that pain point of having unutilized data, a low scope of integrated reports due to having multiple softwares where it is not able to integrate into one. Duplication of work, reliance on spreadsheet because some of the system is not able to give us certain data entry points. So in that case, what happens is end users rely on spreadsheets. So also the leaders expect having enhanced efficiencies, decision ecosystem, command center style monitoring system, optimized resources, AI preparation. So AJ Insights plays a bridge between the challenge and the outcome. So it is a platform that convert numbers into narratives. So this is a basic framework on how AJ Insights work. So we have hospital information management system. So this system can connect to any kind of data source. It can be SQL, NoSQL, CSV, spreadsheet. It can connect to any data source where there are scheduled automation which is written in Python language, where the script is able to extract data, transform data, and load the data into the separate instance. Now we have certain blind spots where system is not able to support certain data entry points. So in that case, we have data entry points available in the AJ Insights front end, where end users are able to enter the additional data which gives us the more information for the top level management to make some sort of decisions. So also we have cloud infrastructures where it gets connected to the BI tool, and we have dynamic interactive dashboard system where we can churn the data and try to understand more about what the data is trying to tell us. So applicability for so far what we have applied AJ Insights in stock management to ensure stock outs are minimal. For the stock check management, where it tracks and controls stock deviations. Bounce prescriptions, it tracks bounce prescriptions and avoids any sort of repetitions. Procurement planning, so it actually it helps in the supply chain management from the part of raising a purchase order to completing the GRN process. So measurable outcomes. So after implementing this, we have seen there is around 95% of account compliance rate in the stock checks. Around 1.3% anomalies were detected, and immediately it was flagged, and we were able to fix the batch mismatches, contra billing errors, and FIFO breaches. In the bounce prescription, we were able to identify 19 items between June to August, where we added that item into the formulary list. Also, we were able to generate certain insights, like around 23 companies were identified for some sort of negotiation opportunities for the vendor and rate contracts. So we were able to identify 465 items which had a high consumption level and had a negotiation with the vendors. So these are some of the interactive dashboards what we have. Also, you can see that we are able to track the rate contract. Now, doing a rate contract becomes easy, but tracking that is a challenge. So we were able to see what is the overall net sales maybe prescribed by a doctor, and what is the compliance of the rate contract sales has happened. So we were able to track those information. Most of the reports are print friendly, and you can get the printouts in a single click. So together, this module worked as a command center style monitoring system. So any anomalies gets detected in the module, right? Immediately we get a pop-up, and we are able to fix that issue on a real-time basis. So it becomes we get a proactive alerts, and it becomes a centralized control over inventory, pharmacy, and procurement workflows. So it doesn't end here. So in case in the future, if we want to integrate the system with any of the other data source, or if we want to integrate with some sort of clinical data, so we can integrate the system, churn the data, and try to get the best outcomes for any sort of data driven decision making. Yeah, thank you.
Yeah, so this is only used in the procurement as of now.
For as of now, yeah, it is integrated with the pharmacy and procurement management right now, but it is always scalable. We can connect with any sort of data source. So right now it is connected with the three different database, and we have some of the adjustment layers for managing the master data. To have that, we have an adjustment layer in the currently, but we can integrate with any number of databases.
So what are the most crucial data output that the product gives?
Uh, we know that most of the time what happens is we go with the rigid reorder levels. So one of the best part of this is it studies the data and gives us outcome saying reorder level is 100, but it is better if you set it to 175. So that becomes very easy for us to avoid any sort of stockouts happening. So, and it is not that it just goes with the rigid way. It is very dynamic. As and when new data gets added, it learns from the new data. Again, it
So
learns from
are
the
you saying that say seasonal fluctuations, let's say fever season comes, the system will automatically predict
It
to
will-
buy more drugs related to that?
Yes. So we are using moving averages and other things where it gives us the predictive analysis on what can be the consumptions for the consumption.
Yeah, thank you. Yes, very informative. Just wanted to ask you, getting information from several sources, right? Spreadsheets, etc. How do you ensure the data integrity and the validation of this tool?
Uh, Ma'am, so we have a Python script written. So first of all, first we have to know what is the expectation from the final stakeholder, what they want to see. So after that brainstorming session, we will study the data points and then come out with the best method of extracting the data and transforming the data to have the insights with us. Yes.
Thank you.
Just one line for my understanding. Can you tell me in a line what is the exact innovation out of this?
So basically, why we came out with this innovation is because sometimes what happens is a single HMIS is not able to support most of the some of the data entry points which helps us in decision making. So what happens is most of the time hospital will go for standalone softwares. Now for from the management perspective or for a leader to make some decisions, what happens is if you want to access few reports, right, you have to go to different softwares or different dashboards, have different login credentials. So in that case, this helps us in having a single platform to have like a single brain. So having a single platform to access any kind of report for decision making process. Please.
Of a framework, it looks fine.
Yes.
What you have actually here with the supply chain is what is available with most of the supply chain software. The insights that you have gained is into only the supply chain work.
For
As a framework, what you are saying is correct.
yes.
What you have achieved so far is the supply chain, which is available with any.
Yeah, but we have a legacy software with us, sir. Yeah, yeah. Well, legacy software where supply chain management was a big issue for us. So we started with that. Yes, yes.
It's a very good presentation, but I want to clarify one thing. Is it a in-house or supported by some?
No, AJ Insights, the whole framework works on in-house. So we have deployed it in a intranet. This one.
You developed
Yes,
it?
we ourselves developed.
Thank you.
Yes. Thank you.
Thank you very much, AJ Hospital and Research Center. Next, we'll have Apollo Sage Hospitals presenting Apollo Learning Together. After that, we'll have an interactive Kahoot session hosted by Dr. Rahul Deshmukh. And then we'll break for tea. During the tea break, I'd request all the participants to come and check with our gentleman. What's your name, sir? Sandeep. Mr. Sandeep, that your presentations are ready and loaded so that we'll have an action-packed post-tea session. Thank you. Over to you, Apollo Sage Hospitals.
Namaste, everyone.
Good morning, a warm welcome to all, and it is always good to put the person who's giving salary for us. So it goes out. The great legend, Dr. Pratap C. Reddy, along with Mr. Sanjeev Agarwal, they are the one who's with the giant venture. They have started a 350-bedded hospital 2.5 years ago in Bhopal. It is the first corporate hospital at Bhopal. Myself, Dr. Shivam, I'm the medical head of the hospital. Second, now we just go with, again, thanks to COVID, when we are all connected virtually, that's time we started this Apollo Learning Together. Apollo Learning Together is one of the complex mechanism what we have started by Dr. Anupam Sibal, where all our clinical governance committees, it was happening in each units, where we made it virtually so that everybody from any part of the Apollo hospitals can view and learn from this particular part. So for example, initially all the DMSs, Director of Medical Services, they used to, when they joined, they used to go to any other Apollo hospitals, which was again a cost-bearing thing. Then we came to this developing the system, and again, developing a system is always easy, how to implement and execute the thing. That comes to the next part. So what they made was, every medical director should attend this thing. It is under their care. So that's why that's how we make all our juniors who are from the quality team, other medical teams, so they will also attend with us. It is easy for me, and they made my life easy to learn from these things. So this is one of the next thing where we need to put our KRA things. I have attended these things. This is my feedback. This is so and so. I have learned so and so other things. So this is one of the things of the feedback what I am going to put from my hospital. Similarly, my hospital's meeting should be attended by any one of the hospitals from the other hospitals. Next comes this Lighthouse 2.0 dashboard, where we it also makes us our life easy, where we can see all the data related things. Clinically, there are two important things I want to make sure. Here is mortality and the SMR and the Euroscore, where we used to derive manually going to the Apache 4 and other things. Now we can directly put into my HMS MedMantra system, and directly gives me an Euroscore and the SMR score. And mortality, I will go with this one. We have a special mortality complaints things, where we have level 1 and level 2 kind of review. All the deaths, once the death is happening, within 7 days, we should finish our level 1 form. So level 1 form, it automatically takes to the level 2, where it needs a peer review, and peer review done by things, and the categories of the mortality is derived by 1 to 5 categories, of which 4 and 5 is presented to the board once in a quarter, and other categories monthly we are just doing this meeting, where it is easy for me to just take level 1 and level 2, and it gives me out the UHD number and the IP number, whatever it is going to say. And as my fellow mate said, Apollo is complex. Yes, it is complex. We are making it simple by virtually and technologically and whatever things. This is level 1 form, where it should be filled by any medical officer fills this form. Automatically, if it comes into the trigger, it goes to the level 2. The level 2 will be seen by me and other medical directors of our hospitals, and they took a review, peer review, and goes out. And this is a level 2 form again, category 1 and the categorization of the death, and along with the triggers. And any other hospital-based infections and other things has been easily carried out for this one, and it is all interlinked. We get the microbiological reports also with this, with the BPL IP numbers. And this is again with the SMR and Euroscore, with the help of this Power BI and other things. We have been issuing all the SMRs in the 24 hours data of Apache 4 and Euroscore for all CABG, and we have started for cardiac risk certification also for all the MI patients. And this is again the enhanced connected care what we have in wards, where it can the intelligence nursing for remote monitoring. Always it is in the common dashboard, is help in the nursing station. It is a three-tier things watched. One is in the nursing station, one is in the command center, the other one is but with the remote by the Hyderabad team or command team. Thank you. Yes, yes, ma'am. Yes. Yes.
Why do you think it's innovative for your unit?
But because it's a new unit, again, I'm saying it is a new unit. To get the new unit implementation for all the juniors who's going to be joined with the new, the same Apollo fellows are not going to join me. So it will be easy for me to train them. It will be easy for me to not to send them paying so much of money to send them to any other Apollo hospital and staying accommodation and other things. It will be easy for me to do that. So for my hospital, this is a technological driven thing. It is easy for me. Adoption.
It's not an innovation, but it's
It is an adoption card.
Thank
It is innovated once. Now I am adapting in my hospital. The learning together is sharing of best practices, sharing of best practices from other, how they put the template, how they describe, how they give the interactions between the consultants and other things in any mortality meeting. It is a learning for me.
Edge Hospitals.
Thank you.
Thank you very much for the great presentation. Now over to Dr. Rahul Deshmukh to engage the audience. It's kind of a breaker. You've been having all these presentations, and so we'll be having some interactive Kahoot-based quiz session. So I request all the audience to participate. Prizes are going to be distributed tomorrow during the valedictory. And in the meanwhile, the judges, though you can participate in this, you're all learned people. You can also review all your scoring. Also mention any special jury mentions, if any. As organizers, we are going to have, other than the winners, not just the winners, some of the novel ideas, we are going to have them present tomorrow during the program. It's going to be the first session post lunch. We're looking for 5 to 6 presentation. Make our jobs easier by helping us select some of the novel ideas, innovations, early technology adoptions that you would have seen. Not just the prize winners. Prize winners are separate. We'll award them. But something novel which has to be spoken out, told to the world. That's what we are trying to do through this Kahotech as well. Yeah. And for all the other participants during the tea break, you're ready, Dr.
Yep.
For all the other participants during tea break, so please do check with Mr. Sandeep and check all your presentations are in. Either your session is post-tea session or post-lunch session. Please ensure your presentations are in place. Over to you, Dr. Rahul.
Thank you.
You
Thank
can
you.
take the center stage.
No, I'll need to be here to just click on the next slide. So that's okay. No,
Sandeep would help you. You can say next.
no,
We want you on the
problem.
center stage.
Okay. Just click on that. So,
Yeah, which hospital he would say.
so I'm Dr. Rahul. I'm here just to sort of interact with you. We have seen some yawning faces around, so it's better that we have a break. But before the tea break, this will be some sort of engaging session, just to have some fun with everyone, because it has been a serious morning this morning. So the plan is to play a game of Kahoot. For that, all I need is if you can log on Kahoot.it and scan the QR. That is the easier option. You can just scan the QR code, or you will need to enter the game pin. So Kahoot.it on your browser, and then you can just scan the QR code or enter that game pin. So
Scanning. May we have all the phones up scanning the app?
it's going to be a fun quiz. It's going to be something related to healthcare IT, plus our host city, that is Bhubaneswar, plus something related to Kaho. So there are going to be questions based on these three things. Yeah, you can. Yeah.
So repeating what Dr. Rahul had said, you can go into kahoot.it and enter the game pin, or you may zoom and scan the QR code and your name would pop up.
You can enter your name or nickname, whatever you want to enter, no problem.
Yeah. But you'll be called by that name. So the choice is yours. How much you want to get embarrassed.
Okay, you can just scan the QR code also. Oh. Okay, we'll give couple of more minutes for everyone else to join. Shall we
By
start?
show of hands, anybody still trying to get in? Get in? Yeah, you're having problem? You could try Kahoot. Anybody else having problem getting in?
Kahoot.it can be another source. You can
Yeah,
just
go to
log in
kahoot.it and
and
enter the game pin
or
820498.
anybody who doesn't know how the Kahoot is played. I hope everyone knows. Basically, what will be happening is a question will be displayed on the screen. There will be options. You need to select the option on your mobile screen. You can't be selecting it here on the screen. On your mobile screen, you need to select the right, whatever you think is the right option. If it's right, you get a point for that. Another thing that happens is fastest finger first. Whoever clicks on the right option the fastest gets the highest marks. That's how it goes. All right, I think we'll start. Can you click
Start
on
now?
Start. Yep. Yeah, next one, please. Yeah, as I said, some yawning faces were already there, so it's time for move on now. Yeah, please. Which tech uses barcodes for medication safety? Your options are EMRs, BCMA, RFID tagging, CPOE. Whatever is the right option in your opinion, you can click on that. As I said, it will be related to healthcare tech, Bhubaneswar or Kaho. Can we click on the next one, please? Sandeep. So typically this is how after each question the scores will be displayed. Can we go on to the next one, please? True or false? Bhubaneswar is one of India's first planned cities. Again, yes or no, or true or false? Each question gives you around 20 seconds to enter your answer. Yeah, so it is one of the first planned cities of India. Can we move on to the next one, please? Yeah, so Senthil has taken lead, followed by Vivek and then Saurabh. Okay, next one, please. What replaced manual counting of surgical items? RFID tagging, BCMA, ADC, iPass. I know one of the basic rules says no abbreviations, but it was very difficult to fill in the full answers because there is a limit of words or limit of letters that can be entered as an option. So I had to enter abbreviations. I'm sorry for that. Okay, can we go on to the next one, please? So Senthil holds on the lead. Next one, please. When was Kaho registered as a society? 2011, 13, 15, 17. Oh, almost equal distribution. Yeah, the correct answer is 2013. By the way, this is by the chatbot on Kaho website. I don't know how many of you have used it. You can try it. It's a fantastic tool that Kaho has got now. You can ask whatever questions you have and it comes up with the answers. So please do try that one. Next one, please. Chaitanya takes over. Okay. cloud-based records reduce miscommunication risks by paper records, real-time updates, delayed sharing, or manual entries. Yeah, real-time updates. Can we move on to the next one, please? Senthil takes over again. That's good. All right, next one. How many wheels does the Konark Sun Temple have? 8, 12, 24, 32. This used to be in our schools for sure. So, yeah, it's 24 wheels. All right, next one, please. Senthil Saji Swag. Next. Which technology is commonly used for converting voice into text? Blockchain technology, 3D printing technology, ambient AI technology, cloud computing. Ambient technology or ambient AI technology. Okay, next one, please. Saji Swag Raj, Dr. Dilip, and then Senthil. All right, next one. I think we are at halfway stage now, so still there is some time to catch up. Recently, how many validated PRAMES tools were released by Kaho? 13, 21, 11, 25.
So the man who's standing on the stage was primary responsible for getting this up. You know, the Prem tools which is there in the Kaho website.
Yeah, it's 17 tools we have released. Again, these are free to download on Kaho website. Please feel free to download them. It's about the patient-reported experience measures. We can talk about it later, though. Can we move on to the next one, please? Yeah. Next one, please. Which of the following can be best used in training or for training without real patients? Blockchain, AI, virtual reality, big data analytics. Virtual reality, yes. Can we move on to the next one? So Saji, Raj, Dr. Dilip. About 300. So one quick answer and things will change. Bhubaneswar is also called as emerging capital, sports capital of India. True or false? True. The number of sports people and the facilities is fantastic. So it's being called as the sports capital of India or emerging sports capital of India. Next one, please. What is the main function of clinical decision support systems? Patient appointment bookings and communication, assisting clinicians make better decisions, collecting hospital bills, supporting the medical director in clinical governance. Yeah, assisting clinicians in making better clinical decisions. Next one, please. Which of the following is not a forum of Kaho? So Kaho has different forums. Which of them is not a part? Like OT Nurses Forum, Biomedical Engineers Forum, Pharmacist Forum, or Physiotherapist Forum? The actual answer is OT Nurses Forum. We don't have any OT Nurses Forum as of now. Okay, can we move on to the next one? Oh, some change. So Dev has taken lead now. Dev, Saji, and Raj. I think this is second last question most likely. The term digital twin in healthcare refers to which of the following? AI generated twin babies, cloning of the patient, digital medical record of a patient, or virtual replica of a patient. Virtual replica of a patient used for simulation.
Patient or equipment.
So they retains the lead. Just a matter of 100 marks between first and second. The capital of Odisha was shifted from Cuttack to Bhubaneswar. True or false? True. I think this was the last question. Can we just check? Can we have a next one, please? One more is there. Okay. So Dev retains Raj and Sajid. Which of the following is not an example of healthcare technology? EHR, BCMA, PDSA, ambient AI. Not an example of healthcare technology.
Catch.
Yeah, PDSA. All right, next one. That's it. I think that was our quiz. And can we have a round of applause for our winners? Third position goes to Vijay, Billy, and the winner is Saji.
So can we have the winners on stage for a photo opportunity with Dr. Rahul? Even Billy and VJL, please.
VJL, you are Vijay, Billy.
Dr. Vijay Lakshmi, can we have Billy? It's okay. We understand. It's a nickname. Yeah, you are here. Who's Billy? Yeah, so, yeah, please, it's okay. We'll not embarrass you. You can come up on the stage. Or anybody else who wants to claim the second place can come up on the stage. I know your name, Vivek. Okay.
All right.
Fine. Thank you. Thank you. Billy, madam or sir, please, whoever it is, please come later and give your name and details so that we can give you your prizes tomorrow. Yes.
Yeah.
Yeah. You have to give an Aadhaar card with your name as Billy.
All right. Thank you, everyone. Do we proceed with some tea or?
Yeah. So we get on with the tea break, and this is going to be for just 10 minutes. So if we can come back at 11:25 and assemble by 11:30, we'll start the proceedings. Yeah. By 11:30, we'll start the proceedings. Thank you all for the wonderful first session. Power pack sessions are in store. Piping hot tea and snacks are outside. Let's enjoy the weather.
It's on development of a training module on infection control practices for interns and postgraduate students. Yes.
Yeah, yeah.
Yes, please, you can start.
I'm professor in the Department of Microbiology, Kalinga Institute of Medical Sciences. Yes, yes, ma'am. I'm Dr. Nipa Singh, professor and infection control officer, Department of Microbiology, Kalinga Institute of Medical Sciences, the School of Medicine of KIT University. First of all, a warm welcome to you all since we are the hosts. And today I would like, my presentation is on development of a training module on infection control practices for interns and postgraduate students. Now, as we all know, the first point of contact for patients who come to the casualty emergency as well as in the ward are the interns and the postgraduate students who do the initial assessment, give the history to the consultants as well as the faculties. Due to this, infection prevention and control training is vital for them as it provides the essential knowledge and skills. Okay. So they should have the necessary skills, whereby they could safeguard both patients and healthcare workers. And as a result, it could help in reducing the HAIs and combating AMRs. Now, the objectives of the study was to determine the effectiveness of training sessions conducted on infection control practices among healthcare professionals and to assess the standards and scope for improvement of a training session. Now, before I begin, I would like to say that we actually didn't have it in our schedule of training postgraduates and interns. There was a demand as well as a suggestion from the clinicians that they should be trained with respect to IPC practices because they would help in preventing AMR and HAI. So with this in mind, we developed this training program. Now, the study was carried out in the months from month of April to June, April, May, and June, 3 months, where the postgraduate residents had joined and interns were just joining by the Department of Microbiology and Community Medicine. First of all, they were given a pre-test audit questionnaire to assess their preliminary knowledge on IPC practices. And these participants were again given training regarding standard precautions, biomedical waste management, and hand hygiene practices for 1 hour by different faculties. Standardized materials were used for training. Following the training, the post-test questionnaire was given to assess the change in the performance. The audit questionnaires were they were standardized and validated and based on the guidelines of CDC and WHO. For all questions, a correct response was scored as 1, incorrect as 0, and they were evaluated for their pre and post training knowledge after submission of the questionnaires and divided into 3 categories based on the scores. 0 to 9 was deemed as poor, 10 to 15 as moderate, and 16 to 20 as good. At the end, a feedback form was also given to the participants. This is the questionnaire we had given to the participants, which dealt on standard precaution, hand hygiene, BMW. Now, this is the result of our study. We could train around 108 healthcare workers that included 82 postgraduates and 26 interns. And first of all, when there was a pre-test, these were the scores. Poor 33, moderate 60, and good 15. So we know that the pre-test score was 12 plus minus 3, and majority of the participants in the study had moderate knowledge in the pre-test, which was similar to the findings of other studies. And there was significant improvement after the training, and as we can see in all the subgroups like standard precautions, hand hygiene, biomedical waste management, there was a significant statistical change observed in pre-test and post-test, which tallied with other studies. Now, outcome of the study, we have actually got a feedback from clinicians that there was a good improvement in the practices, and we were encouraged to hold such trainings again more frequently. These are my references. Thank you.
Thank you. Questions from the jury?
Yeah, so an example of best practice, training is an integral part of any healthcare delivery system. So why you call it an innovation? What is your, why it will be an innovation? How do you describe it?
Sir, basically, we in KIMS, like I tell in KIMS, our training before this was restricted to nursing, housekeeping, but this was for us. We innovated in this in the sense that saw that there was a gap in knowledge in persons like the new generation who were joining. So although they knew it theoretically, they didn't know how to do it practically. So we devised a module after this, and this we will be continuing throughout, after this in future also, that this is actually innovation from our side, that we have taken not all the WCDC and WHO material, we have taken their their guidelines, modified it according to whatever gaps we found out, and made the study material.
Doctor, thank you for this presentation. Thank you for the presentation. In addition to the survey to see for the effectiveness, did you have any silent observers or anyone to observe the practice, or is it only survey based?
No, sir. No, madam. Actually, because we had got the feedback from clinicians, which was our, we took this initiative based on the feedback only. Because whenever we used to hold HICC meetings and we used to show that your IPC practices, BMW, are not good, they used to say that we have been telling the interns and the postgraduates, but it seems it's not working. So this was an effort on our part to give training to the doctors. I mean, the newly joined doctors. And then we got the feedback again from the clinicians that there was an improvement in the practices.
Thank you.
Feedback was of two types. No, this was batch wise. We have compiled all of them. We haven't taken batch wise because it was done, maybe 6 times it was done. Over a course of 3 months, we had 6 training sessions. Individual feedback, again, we have put it in an Excel sheet and taken compiled it, and then only we have done.
We'll let the audience engage with the speaker once the speaker is off stage. I would appreciate that very much, that they network and learn from you.
Yes.
Thank you, ma'am.
Thank you.
Any
Thanks.
other questions from the jury? Thank you, ma'am. Thank you for the presentation.
Can we restrict
Yeah.
questions to query only? Audience can engage with the presenter later on, because otherwise time will be a problem for everyone. So let's restrict the questions to the queries. If there are any questions, you can always ask the individual presenters after the session. No problem. Thank you.
So that was Kalinga Institute of Medical Sciences, our host for the day, today and tomorrow. And so can we have a big round of applause for them? And we see a lot of diagnostics related and lab related participants out here. Kaho Diagnosticon is happening. So we also invite you all for that. More details on our website. No problem. Topic of the hands-on workshop, madam? Okay. IPC surveillance tools, hands-on workshop. Where is it happening? LT4, Kim's Kalinga Institute of Medical Sciences. So those of you who are interested, what time, madam? Ongoing. So those of you who have finished the presentation would like to step in and encourage our host with this hands-on workshop, you're free to do so. Next up, we call upon St. Peter's Medical College Hospital and Research Institute in partnership with Medicine VR for your presentation on skill training in virtual reality and virtual reality simulation lab. Jury members, we have St. Peter's team and along with Medicine VR. St. Peter's Medical College Hospital and Research Institute in partnership with Medicine VR, all the way from Hosur.
So good morning to everyone present here. It's an honor to be on this such a big platform. Myself, Dr. Chaitanya, along with Dr. Dilip, who heads the VR Simulation Committee in St. Peter's, and we bring to you our innovation, skill training in virtual reality and virtual reality simulation lab. So effective care and patient safety is at the heart of everything we do. And empowering our healthcare professionals with adequate skilling opportunity is a major contributing factor to it. Traditional training methods are effective, but they still remain constrained with patient safety risk and high resource demands, as well as like inadequate hands-on practice. When you see on a scale, WHO projects a global deficit of healthcare workforce of 18 million by 2030, and a major factor is skill mix imbalance. So our core problem was clear. How can we train our healthcare professionals safely, effectively, at scale without relying heavily on physical resources? And that's why Virtual Reality Simulation Lab. So it was set up in 2023 and powered by Medicine VR software. It offers you virtual reality-based skill training. Currently, the lab, which is a patented technology, it offers training to 750 students. That's 450 medical and 300 nursing students. So this lab offers them a dedicated physical space where they can practice 60 plus essential skills virtually, n number of times till every student gains measurable competency. So about the software, I would just like to present to you this video. So now each student is given a login credential through which they can access this virtual reality skill training module. And as you can see, the skills are present in two modes, guided mode and evaluation mode. Now the guided mode will give the students step-by-step instructions on how to perform the procedure, along with theoretical concepts like say information about an instrument, equipment, or like in this ECG case, it could be about the interpretation of ECG. Once the students do it in guided mode, they go on to evaluation mode where they independently practice the skill and they get performance analytics, such as their overall scores, their missed out steps, and so on. Now that is also reflected on dashboards. That's student dashboard and an institution dashboard that is AI powered and gives them the complete details of their performance along with areas of strength and weakness, and that further supports competency assessment of every student. So moving on, we wanted to assess the impact of integrating virtual reality in enhancing the procedural knowledge and skill. And that is why we conducted a pre and a post-intervention study with our ECG VR module. So we did a baseline assessment of students for their ECG procedural knowledge and skill, and we subjected them to a one-time VR training mode. So the results were pretty interesting. We found that there was an improvement in their knowledge scores from 61% to 78% with a large size effect. And procedural skills showed a pronounced improvement from 49% to 82% for the group with a large effect size. And most importantly, we saw a significant decrease in the procedural errors from 51% pre-VR training to 18% post-VR training, particularly in the domains of patient communication and lead placement, and that too after a single VR exposure. So we also conducted semi-structured interviews so we could hear directly from students what was their overall experience with VR. And we did a thematic analysis that identified 4 major themes. Experience with VR, where students felt that it's very real and immersive and almost feels like being in an actual clinical environment and doing it on a patient. Learning process, where they said that, in VR we can do mistakes and correct them, but on a real patient we cannot do so. Engagement and motivation, where they said it's more interesting to learn and we don't feel pressured from it. Real world application, where all students that we interacted with said that they feel more confident performing ECG on a real patient now. What's interesting is that this is a completely scalable and a replicable model. The virtual reality system in itself can easily scale up from 60 skills today to 100 skills tomorrow. The VR lab that we saw can easily be leveraged to become center of excellence, where that training can reach up to 1 lakh healthcare professionals in that geography. And it can, say for example, with TOT programs, so it can also have an institutional level impact. Integration with Mannequin is what is going to be the game changer because it is going to combine the benefits of both modality. To summarize, VR is going to bridge the gap between theory and practice. Thank you everyone for your time. So it is St. Peter's Medical College in partnership with Medicine VR, and Medicine VR is the developer that is the patented technology.
I thought that this would be the end of Mannequin.
No, ma'am. Actually, I would not say that. But you see, technology is developing. As of now, the haptics is not that great, the technology that is available. So what we try to do is how, in conjugation with virtual reality, we can improve the entire learning scheme and ensure that the learning curve is shortened so that we can achieve the required competency in a shorter period of time. So in addition to the virtual reality, we are trying to teach the cognitive skills that are required to perform on the mannequin in virtual reality so that they can just go and perform it and the assessment will be much easier and the resource management will be much better.
So have the students who have gone for virtual, that they missed the haptics? Have they told you that they missed the haptics?
No, ma'am, actually that feedback didn't come. That is something like we are actually looking into because in medical profession, learning is one point because they use the controllers and everything, but actually holding the instrument in the right way and feeling the force and feedback is much more important. So we're not saying that like virtual reality can replace mannequins at this junction. There are virtual reality gloves which can mimic it, but for the cost and the impact that is at present is not matching up. When that actually matches the cost and impact, then we will definitely implement it.
And I think it's always that we believe in a hybrid approach more, that is virtual reality in conjunction with the traditional training methods. And research has also pointed out that that hybrid teaching method has given much more, greater impact on students' performance when compared to just traditional or just VR. So we believe in combining that approach.
Thank you, team from St. Peter's. Next up, we will call upon Trauma Center IMS BHU. Are you here, Trauma Center IMS BHU? Is it somebody who got up again? This is like second time in a row it has happened. Okay. Do we have Atulya Senior Care? Yeah. Chat Ops. Yeah. Chat Ops for Healthcare. Atulya Senior Care representing Mr. Prasanna. Go ahead, sir.
Hi. Good morning, everyone. Before I explain what is Chat Ops for Healthcare, let me start with what is a day in Atulya Senior Care. See, when you walk into a facility, there'll be 100 things happening, invisible things happening, like a nurse is refusing overtime, or caretaker missed to come, or fall incident, acute issue. So many things happening parallelly. The supervisor will be juggling between WhatsApp groups. So the operations never stop. Atulya Senior Care sizes 10 facilities, 1,200 staffs. So many operation touch points. It is not an easy business. It's a human intensive business, mix of hospital and hotel. Okay, they do palliative care, rehab care, everything. Now coming to the humans here, the people, it's a senior care, it's not senior living. They are almost 75 plus or 80 plus. They are usually from abroad, well educated. They have a very high expectations, served by Gen Z kids, 17 years, 18 years old, just out of school with 3 months of diploma. It is a really combination of two different worlds into one. Now the challenge, coming to the challenge, what is the challenge here? We have people, we have process, we have systems, but not everything in one line. That's a gap we are finding. Okay. See, the problem is we have to bridge this gap. Okay, that's where the chat apps for healthcare began. Instead of building a new app, we built a system, something called System on Action on WhatsApp. Because everybody's on WhatsApp, okay, why not pull the process? We want to make the process. I mean, today, process is there in the document. In HIS, it is not, it's static. There's no medium to carry the process. So we brought in the startup from healthcare. We brought in a medium to carry the process. What happens is, if assume instant discharge is initiated, immediately all the relevant stakeholders will get a time-bound, action-bound message. Okay, you have to complete this thing 30 minutes or 1 hour, and next person. So everybody has to do their work. If not, it gets escalated to the boss. So what is the innovation here? Innovation is time. If we want to implement the same thing in traditional systems, it takes months. You can see in others, they said 6 months, 1 year. Here we are doing it in weeks. Achieve the same process implementation just in weeks or days. Thing is, you all use WhatsApp for the messaging, but WhatsApp can be used to feed structured forms, action buttons. I mean, you can have time-bound, tickets you can raise. Within the WhatsApp, you can do whatever you can develop within a mobile app, custom mobile app, can be developed within the WhatsApp. Since ours a no-code platform, this workflow can be connected in a day and deployed. So mistakes can be corrected instantly, can be rolled out. So this is what we use WhatsApp to capture the whole thing. We have for every task, there's a owner, there's a time, there's escalation path. Everything is measured. End of the day, the COO gets all the bad news. The delay is here. He knows where's the problem. Because in Atulya, when their problem is, this is maybe a common thing everywhere. They lived the problem. But Atulya, the problem is they have to hit the IPO in 5 to 7 years. They have to hit the 1,000 crore turnovers in 5 to 7 years. They're growing at the breakneck speed. They cannot afford to have, the other, hospitals thing like, okay, we can. Last year they are 40 crores. This year they are 100 crores. Next year they are planning for 200 crores. Okay. So what has really happened out of this thing? We literally saved 9,800 man days by bridging all the gaps, connecting the people, process, and systems by extending HIS. We are not competing with HIS. We are complementing HIS. What cannot be done in HIS can be done in this platform. And we are extending the capability. And we are making use of HIS to maximum extent. Everything is digitized. So this thing can be, the point is, this is not only for Atulya. This can be extended across India for every healthcare organization. This is a first point towards AI. Once you have digitized data, agentic AI automatically comes into place. Without digitized data, we cannot build any AI. Thanks.
So the benefit of the recipients of care. So any particular focus or any data do you have?
Yes, the recipients is two sick people. One is the people staying there. One is their guardians, usually son and daughters. So they are usually from US, right? They want accurate, detailed reports every day, daily basis. It is impossible for the nurses to send everything, right? So what we did is digitization at the source. Earlier, how the 9,800 days saved because they're doing double work, rework. Digitization is not happening at the source. Here we apply the digitization at the source. Do it only once, do it right.
Yeah, so you mentioned this is senior living, right? So obviously, so you are not finding any challenges with the seniors using WhatsApp in terms of technology, raising complaints through WhatsApp and all.
Actually, they are 75 plus. They most can't use WhatsApp.
Okay.
It's mainly for the frontline staff.
Okay. Staff only centering here.
Staff, because 17 years old kid, they cannot use the HIS frequently. And there's a complaint. Nurse say, I'm always sitting in front of the system. Even boss says, why the nurse is always in the system? Why they're not working? But they have so many things to feed into the system. So that's what we cut. We digitize at the source.
And how the complaints get closed? How do you ensure that the complaints get closed on time?
Exactly. Task is linked to the time and escalation path is there.
Is there any OTP or something after the complaint gets closed?
No, it's automatic. If assume a discharge is initiated, a pharmacy will get a message, this so-and-so discharge, 30 minutes you have to close the task. Otherwise, the boss will get the message.
For the sake of information, pharmacy says that I've done it. How do you ensure that it is done?
In the WhatsApp itself, there's a button will be there. Plus one button, done. That's all. This is something very easy to implement, easy to adopt. That's why we're able to scale across 1,000 staffs across 10 locations.
Fantastic. Thank you.
Thank you.
Check. Thank you. Thank you very much, sir. Next up, we'll be calling upon TMU Hospitals. TMU Hospitals, are you here with us?
Sir, TMU Hospital is an online presentation.
TMU Hospital is an online
Yes, sir.
presentation?
Yes, sir.
Okay. Can we have them? Are they ready for the online presentation?
Yes, sir.
Okay. So the jury members is TMU Hospitals Training Compliance Card System for Corrective HR Training.
Yes, sir. Just give me a second. I'll just on this.
So in the meantime, I would just like to announce that Billy mystery has been resolved. It was Dr. Catherine who was participating online, so she couldn't come on stage, but she had just messaged saying that I was the participant. That again, we'll have to validate though, but she has sent the message that it is Dr. Catherine. Can we have a round of applause for Dr. Catherine? Okay.
You may start.
Yeah, very good morning, everyone. I would like to thank the organizer, the faculty innovators, the fellow innovators, all the members there available, and the CAHO to provide this opportunity to me. So my name is Dr. Swapnil. I'm working here as an hospital administrator, and this particular topic, this particular study, what I'm going to present today. Just a minute, it's got, just a minute, sir, it's got hang.
Check, Dr. Swapnil. Any assistance you require? You can, go to the stage side.
Yeah. Now my slides are working, sir? Yeah.
Yeah.
So my name is Dr. Swapnil. I'm presenting this topic. It's basically a very simple but very innovative and effective method of creating the accountability for the training. Basically, what happened in most of the training, the idea basically come from the need, what we are facing continuously in the hospital. Whenever we are going for the training, it has been believed by the staff that the training is the responsibility of the HR or the administration or the senior management. The staff doesn't own the ownership of the training. So this particular practice, what we are trying to do is shifting that ownership from the administration or the management side to the staff. So it is very simple. we are just using a simple paper-based trailing compliance card, but the effect, the emotional effect, the psychological effect of that, the shifting the accountability that training is your responsibility to get upgraded, to get innovated, to get skilled, will be shifting on a paper to the staff. So it has been said that whenever you are doing the training, the accountability of the trainer cannot train until the staff want to get trained, because most of the time what the problem what we are facing is the staff is on night duties, day duties, they don't have time. Whenever we are conducting any trainings, the person who actually committed the issues will not be coming for the training, the junior staff has been sent for the trainings. So these kind of issues are very common. That's why our training will not be that affected what we expect them to do. So that is what bringing the accountability through the innovations on the corrective training, sir. So the problem start, the often usually conduct a lot of trainings, but corrective incident-based training for the formal tracking and the closure mechanism has been a gap, which has to be identified. So whatever the training we are doing, it is not directly connected with the outcome and the performance of the staff. So that is the area we want to pitch in here. So we have found that there is no a link between the incident report and pre-training completions. Poor
2 minutes to
documentation.
go.
Yes, sir. So there's a no time-bound closures and validation by the supervisor. So I'll directly coming to the idea. What is my strategic goal? So we have established the structured corrective training system. So we are targeting 100% tracking of the referred staff within the 3 months, and HR improved compliance. So 95% of the closure of all the incident which has been reported through this card. And we want to shift the accountability that has been repeatedly I'm saying, and we want to reduce the non-conformities, because the same thing cannot be repeated again and again. It is to be put on a paper, and the same card has been issued for the same issues, then it has to be taken into the consideration. So when I talk about the methodology and system designs, it's very simple system. It is a trigger based. Any incident, non-audit compliance or any kind of misconduct triggers this training referrals. So the department in charge or any kind of supervisors, the person who feels that their staff need to be trained.
1
so
minute
they
to
have-
go.
Yes, sir. So they will issue this card to them, and it is having the basic details. What is the incidents? What are the things need to be done? And what is the mode of the training? And what is the timelines they have to? And important point is this acknowledgement by the staff. So a staff has to be acknowledged that I am going to complete this training within the period of time. So next is the trainer. The trainer also had the opportunity to acknowledge that the staff has seriously attended the training and completed all its requirements. Now the departments, after this, the staff has to come back to the department and close this particular training module for them. So this helped them to make a proper circle where it started with the issues, the trainer has been acknowledged, the staff has been accountable for this, and it has to be closed. So we have seen this for all the trainings what he conducted in 3-4 months. Our corrective training compliance basically improved from 62 to 97%. Repeated non-conformities has been reduced by 48%, and our audit documentation is
up.
also improved. Yes, sir.
You can close it, sir. Your closing statements.
Yes, sir. So,
Yeah.
so basically, this basically the training compliance card helped us to bring us into the same consensus where the training has been has accountability, the staff has an accountability, and also the who is conducting the training, organizing everything, has the accountability.
Thank you.
to
Thank
be-
you, sir.
yeah.
Thank you. Over to the jury, or if any questions, we'll move on. Yeah, next is
Thank you, Dr.
thank you, Dr. Swapnil.
Thank you, sir.
So the next presentation is from Christian Medical College, Pluto. And okay.
I think the online presentations, only 4 we have permitted. Those who could not get the visa, we have 1 from Pakistan and 3 from Sharjah, I think. Okay, only those 4 will need to be judged. Yeah, the other 2, I don't know how this has come in, so they will not be judged. You can allow them to make the presentation, but no judging.
So CMC coming, madam, for Pluto?
Yes,
Okay.
sir.
Team from CMC,
Sir, I'm in the online.
Okay, you're doing it online. Okay.
Yes.
So your time starts. You can open your presentation, madam.
Can you see, sir? Hello, sir. Can you see?
Yeah, okay. This is yeah, go ahead, madam. Your time starts now. 5 minutes you got.
Okay, sir. So Homer, it's a project related to robotic assisted home-based upper limb training in Sabakit Stoke in India. So every year, about 18 lakhs Indians suffer their first stroke with a chronic disability depending on severity. So mobility impairment, caregiver needs, and travel costs limit access. So beyond the first couple of weeks in inpatient stay. So home-based neuro rehabilitation offer better therapy delivery than hospital-based care, and high quality neuro rehabilitation services are available mostly in the tier 1 and the tier 2 cities. So paper based home therapy shows poor adherence and fail to provide adequate dosage and quality of optimal recovery, and there is a need of portable unintrusive and intuitive tools. So that's why we came up with the two robots called Pluto and Mars, so which used to monitor patient movements, provide regular feedback, assist a movement if required, and keep the clinician informed about the status of the patient. So such tool can improve the adherence and provide the clinician to assess the progress and tailor therapy. So our innovation is from CMC Vellore and IIT Madras have collaboratively developed a robotic tool, and the robot for hand and arm therapy. One is Pluto, the plug and train robot for hand neuro rehabilitation. Another one is Mars, motorized arm support. This was the first of its kind study to evaluate the robotic assisted therapy in Indian homes with the use of indigenous developed robotic device. The study evaluates the effectiveness of home-based robotic upper limb therapy compared with the standardized paper-based home therapy in Sabakit Stoke. So it is in a multi-central trial. So one is in CMC Vellore, another one is in CMC Ludhiana, another one is in Mahi, that is Manipal Udupi. So we have two robots. One is Pluto. So if you see, it works like a mixie jar. In same water, how we are changing different kinds of jars. So like that, we have to put different mechanisms. So in gross movement, we have flexion extension, radial ulnar deviation, and forearm supination, pronation, and hand open close. And in functional movements, we have different type of knobs. So just you have to remove the mechanism and put the next mechanism for the patient, which is very small and compact size. So next one is a Mars, which is a motorized arm support. So here we are going to train the shoulders and the elbow. So shoulder abduction, adduction, elbow flexion extension, and combination of shoulder and the elbow. So these three variations are there in the Mars robot. So overall, as it shows the upper limb rehabilitation as it together. So hypothesis, home-based robotic assisted upper limb therapy will result in significant better improvement in upper limb function compared to the standardized home-based upper limb therapy program in Sabakit Stoke. Our objective primary is the compare the effectiveness of robotic assisted versus standardized home-based upper limb therapy in reducing impairment. So our primary outcome is a Fugl-Meyer assessment in Sabakit Stoke, and the secondary objectives are compare the effect on upper limb function and quality of life and adherence rate between robotic
2 minutes
assisted and
to
the
go.
home-based therapy, and to develop a predictive recovery model using demographic baseline sensory motor status and therapy type and adherence. So this is our methodology. It's in Sabakit Stoke, and it is a randomized control trial, and it's happening in a multi-center trial, and the duration of the study is 4 weeks, and the primary assessing therapist will be blinded in this study. So this is our flow chart. So here one group will be a standardized group, another will be a robotic assisted group. So first day, 3 days only the therapist go and train the patient. Other So after 1 month post-intervention assessment, so these are our primary and the secondary outcomes. So this primary is a Fugl-Meyer assessment, and the other all are secondary measures. So
We've lost you over there, madam. And the time is also up. Thank you very much. So next we have, again, this is also just for the presentation. We are not marking. Next, we are having Dr. Rela Institute and Medical Center, revolutionizing OT management with AI-powered OT module.
Taken.
This is again a non-marked, non-jury marked presentation. This is just for the presentation.
Hi, may I begin?
Yeah, you can start.
Great. Thank you so much for the opportunity. I'm actually 36 weeks expecting, so couldn't travel. So it's very grand of you to allow us to present online. I'll just share my screen. Give me 1 second, please. I hope you can see it. So to begin, we have for you today something called as an OT module. So why a OT module is required is where I begin. Most of us working in hospitals will completely understand the importance in OT holds the efficiency and effectiveness with which an operation theater needs to work and the different issues that people face. So we've got some things like, surgeons unavailability. We have resources. Somebody needs a robot. Somebody needs a lab equipment. The patient's admissions change on time to time, the specific staff they require, or the specific OT actually that they require, or case overruns, emergency coming into the picture. There are many different complications that come into the when we're talking about OT, and you see most of the time the OT team sitting with a pen and paper or on an Excel, working like crazy, trying to do a lot of schedules, a lot of reschedules, calling doctors. So we wanted to come up with something where our entire OT runs on a module with different types of conveniences for each of the stakeholders per se. So what we've built is we've built a module where, it's everything all in one place with different dashboards. So we've got something like a calendar view where the doctor can see the different OTs and the timings that they're available and put a small block when they feel they would like to do the surgery. So it's as simple as when a patient walks into the OPD and says they require a knee replacement, and the doctor feels that you talk to the patient then and there, and with the patient's name and the unique hospital identification number, they block that slot for that patient and just put a small buffer over there. And that's blocked for that patient, for that doctor, for that time. Then somebody from the doctor's team, one of the junior doctors or one of the physician assistants or one of the team members goes in and fills out a longer form with all of their surgical requirements, whether they'll be requiring a robot, whether they would require implant assistance or a lab equipment, whatever it may be, that's added, blood requirements, all of that is added, which then gets pushed to the OT manager, and they are the ones who are doing the final approval of the slot, blocking of the slot. Apart from this, every request that the surgeon would have made hits the different departments, and then they know what they're supposed to be doing on that day. So we've got surgical booking that happens on the platform. We've got resource planning, the anesthesia workflow, the pre-anesthesia check, the post-surgical operative orders. The OT notes are also typed on the document on the software, and the access is only restricted to the consultant. And it can be printed and added to the patient file. We've got checklists, we've got documentation hubs where the entire documentation of that patient's available. So how it makes a difference is we have voice-guided documentation with speech-to-text for the OT notes. It's secure access. It's based on the token base. So only a surgeon is allowed to do the OT notes. Nobody else will be allowed to tamper with it, edit it. Data security, data integrity will be there. We'll have tamper-proof audit logs. There'll be departmental dashboards, so everybody knows where they are at that point of time. They're able to plan their day accordingly. So these would be the key innovations or features that we were looking at. We're still in the developing phase. We have made it. We're going to keep making it more different. But what we have achieved would be higher efficiencies. You see scheduling errors happen fewer when a surgeon sees that the robotic is booked, they will not book another case on the same day. They will look for a different time, or they'll talk to that surgeon. The communication between different departments, interdepartmental and intradepartmental, makes a lot of difference. The discharge process gets
1 minute to go.
Sure, sir. So the discharge process gets faster. There's better communication among everybody. Delays are lesser. This is what we've achieved, but what can be done? So since it's a modular design, it's small, it can fit into different hospitals. It can be based on premise or on cloud. It can be integrated with your HIS EMR. So scalability is really nice. And what we hope to achieve is we are going to keep making it better. Definitely, we're looking for integration, cross-device integration, and analytics into it as well. Thank you so much. If you have any questions, I'd be happy to take them now.
Thank you, Dr. Hema, and best wishes for your bundle of joy.
Thank you so
We
much.
move on. Next up, we're going to have a presentation by New Movasath Hospital, Patient Critical Results Communication Application. Yeah, New Movasath, online. They're presenting online this one. Yeah.
Yes, I am here. I'm just gonna share my screen. Give
So
me
you have representatives from New Movasath, right?
Yes, we have two
Okay, so you can come on
representatives
the
there.
stage while they're presenting. This is being marked because the representatives are present here. Due to visa issues for some of the international, we have approved some of the online presentations. Go ahead. Your time starts now. Go ahead, sir.
Hi, good morning. My name is Dr. Yunus, and I'm representing New Movasath Hospital, which is a 100-bedded private hospital located in Kuwait. Our project that I'm presenting is improving critical result communication in lab and radiology. So the project addresses one of the most time-sensitive patient safety risks. Allow me to explain how. So as we all know, one of the apart from all the leading causes of patient harm in healthcare, it's just not the lack of knowledge or resources that cause harm, but the main cause is communication gaps or communication breakdowns. And this can happen either during transitions of care, or it can happen because of a missed phone call, a delayed report, or a message that does not reach the provider at the right time. So what we noticed in our hospital was that there was unreliable and inconsistent manual communication of critical results in lab and radiology, which created confusion, delayed communication as well, ultimately affecting the clinical outcomes of the patient. So what we did was we run down to the root causes, and we noticed that at times staff sometimes misreporting the critical results to the physicians because of workload. At times, there was information was occasionally misinterpreted during the phone communication. And when this information was communicated, at times the physicians wouldn't be in front of their PCs, whether they are not in their OPD clinics or they're in inpatient during their rounds. So what used to happen was physicians, they often couldn't view the results directly and had to call again back to share the critical results, details of those critical results. Ultimately, if these critical results were communicated, there wasn't any tracking to track if there was any interventions on those critical results that were reported. So our hospital embarked on a journey to establish a framework of critical result communication, which would cover these communication gaps at micro, meso, and macro levels. And this framework that I'm talking about would be automated on all structured in our hospital information system. So using the SMART goals and PDCA methodology, we plan to have improve the critical result communication. That is, all 100% of the communication results would be communicated within 30 minutes of result validation by the lab and immediately by the radiology department. Part of it again was how do we automate it? So automation of the critical results and integration with the SMS and email alerts. Once the critical results are identified and reported, how do we track these interventions by the physicians? So again, 90% compliance by the physicians. That was the goal established. From time to information intervention. Again, since the entire project revolves around the patient safety, so one of the main goals was zero patient harm to the patients. One of the balancing measures, because we were innovating the entire structure of the HIS, we wanted a good uptake by the physician. So a physician satisfaction survey related to the use of critical results was also selected. So again, PDCA methodology was used. And one of the, again, important part of the PDCA was how the uptake of the system by the end users. So training was an important part of it. And our multidisciplinary approach was used, which just did not include the lab and radiology department, but across the board, various departments such as quality and IT, which is the core pillar of the project, was also involved. So the innovation that we did was using our current resources, which is the HIS, which is an Oracle-based system. We completely revamped our information system. As you can see that this is a lab information system where once the results are entered or they populate automatically, the user, that is the the lab department, would be able to identify the critical results and mark it over here as who's the person who identified, who's it informed by, and who's it informed to, and the readback would be taken. Once the critical result is identified, this is the physician module, how color-coded results will appear, segregating these normal results with the from the critical results. Again, we expanded our project towards the radiology department using the same methodology, and you can see once the critical result is identified, they can click to identify the critical results and also mention who they relate the critical result to. Now, once the critical results are clicked, automatically an email would go to the physicians, the requester, and an SMS will go both in the case of the radiology and lab results. At the physician's end, once they are in their OPD or in the inpatient and they have the complete HIS module, they would be able to see if there is any critical results pending. If there is, they would
Thank
be
you,
able
sir.
to
Your
click
time
on this
is
tab.
up. So this is a marked presentation due to visa issues. So questions from the jury?
No, he'll answer.
Can you hear me? Dr. Yunus, can you hear me?
Dr. Yunus,
No,
can you
I
hear us?
cannot hear. I
Sorry,
cannot
can you hear
hear.
me now?
I can hear you now.
Yeah, my question to you is, thank you for this presentation first. And how does your doctor get the notification if he's out of office?
So there are multiple layers that we've established. It's through a phone call first, and then we have other ways, which is SMS and an email that goes to the physician.
So how do you know, confirm that the doctor has read it? If it's an
So
SMS
correct.
and
When
out of
the
office?
phone call, correct. The phone calls is the one that ensures that the doctor has acknowledged and there will be an intervention on it.
Okay, thank you.
Questions from the jury? Thank you, Dr. Yunus and the New Mowassat team. Next, we move to NMC Royal Hospital, Sharjah. This is also a marked presentation. The jury can note NMC Royal Hospital, Sharjah. So we have a presentation on introducing transformational leadership in nursing, inspiring change and growth. Over to you, NMC Royal Hospital, Sharjah, to inspire us. In the meanwhile, while they are connecting, is TMU Hospital over here? Sorry, not TMU Hospital, sorry. Trauma Center, IMS, BHU. Trauma Center Hospital, IMS, BHU. AI-powered antimicrobial stewardship initiative at Trauma Center. Okay, we don't have. NMC Royal Hospital, Sharjah, are you sharing your presentation with us? Preeta, any issues, challenges?
No, sir, they're not yet connected. We sent a reminder message to them, but not yet connected, sir. Waiting for them.
Okay, there is one more presentation on OPP by New Mowassat. Are they connected? Yeah.
Yes.
Okay, we'll go with the New Mowassat. In the meanwhile, you can connect with. So one other presentation from New Mowassat. This is going to be on application development for doctors scorecard, supporting ongoing professional practice evaluation, OPPE.
Good day for everyone. I hope my voice is clear for you.
Yes.
Yeah, and my presentation is visible for you. I am Mohammed Hassan, Head of Patient Safety in New Mowassat Hospital in Kuwait. And today I am presenting for Doctor Scorecard supporting OBBE, ongoing professional practitioner practice evaluation. So what was our challenge in New Mossad? Our problem statement that our baseline and previous system was depending on manual and paper-based data collection for OBBE, which makes it very difficult for on-time tracking for performance evaluation of our physicians and our clinicians. So as we know that digital OBBE system will enhance our transparency among our physicians and support data-driven decision-making and improve our quality and patient safety. This initiative also is aligned with our hospital strategic plan for digital transformation and the clinical governance. So our goal was designed as smart, specific, measurable, achievable, relevant, and time-bound to be finished in only 3 months from project initiation, measurable to achieve 100% of timely completion of physician OBBE, and achievable, our methodologies that we used during our improvement project was designed as PDCA, Plan, Do, Check, Act. The remarkable steps in planning phase was we gathered our requirements and objective setting. We also collected our multidisciplinary team from quality, IT, human resource, medical director office, and other clinical departments. Our data requirements was very clear from the start, and we also added specialty specific KPIs and quality measures, especially clinical measures. Our do phase was through our pilot testing, and also our we already went for training for all process owners. We checked our results from pilot testing, and we standardized all our OBBE processes to be routine, and continuous improvement reviews were done. So what is the impact and outcome? It was achieved as 100% of timely, real-time data for OBBE evaluation, reflected by 80% reduction for the workload for data entry process owners, and our physician engagement satisfaction was 95% due to transparency and fairness. Our physicians felt that they are appraised very fairly for their performance tracking. Also, our system helped in early identification of performance concerns, which reflected to strong accountability and compliance with regulatory requirement, as we are accredited by JCI and Canadian accreditation, also Kuwait MOH requirements. So this is our screenshot from 2023 pre-implementation for our digital OBBE system. As we see here, most of the data collection was depending on manual data entry, and it was fragmented, it was inconsistent, which was really delaying our performance appraisal system, and in the same time make trust issues with our physicians and our clinical staff. However, this situation completely changed in this screenshot as example in 2025. All specialty group metrics and also utilization metrics were reflected automatically in our physician scorecard. This is only one example. Another example for 2025 for doctor scorecard, it was depending on certain quality measures from their clinical performance. So our project was scalable because it's really easily reproduced and replicable. Innovation and the creativity were considered because it was automated, it was reflecting in the real time. Adoption and sustainability, we made sure that we are sustaining our improvement project, our future plan to expand the OBBE tool to allied health professionals like clinical technicians and our nursing team. Thank you.
Thank you. Over to the jury for any question.
That was a good presentation. On the
Thank you.
Practice evaluation, my question is, how are you using this card to benchmark the performance of doctors with other peers in the department? And second, how are you implementing this also for the community doctors or visiting doctors in your organization?
First of all, benchmarking, we have a two-tier benchmarking system, internal with other peers from the same department, because every doctor has a specific data and they have a specific outcome measures, and it's going to be compared with his peers in the same specialty. This is internal benchmarking. We are also through a specific specialty-wise, specialty-related KPIs. For example, the OB-GYN, for example, doctors will have certain related KPIs and quality measures to OB-GYN practices, like, for example, in postpartum hemorrhage, in some complication, in infection rates. Also, external benchmarks, we are getting to have some external benchmarks from best practice. Number two, the community, we have external and visiting doctors who already coming and visit our hospital, and they are merged with our scorecard. It's very important also to have their numbers for their performance, because when visiting doctor is coming, we are keen to track how was the performance, not only for the utilization measures, but also for quality measures and benchmarks to compare with his peers during his stay in the hospital. So, for example, 1 month against 1 month, or 3 months against the average of the department performance physicians.
Shukran, Mr. Hassan. Shukran Jasilan.
You are welcome. Thank you, Ilaf.
Check. Preeta, do we have the team from NMC Sharjah?
Sir, we connected with them. I think she's in the traffic. She can't able to join now. She texted.
Fair enough. So with that, is there anybody else scheduled in the morning session who have not had a chance to present? Yeah. So we had presentations from Ruby General Hospital. We had presentation from CK Birla, BM Birla Heart Hospital. We had from CMC Vellore. We had from Basavatarakam. Kanchi Kamakoti Child Trust is not able to make it today. Medcare Hospitals has been scheduled for the afternoon. Apollo Hospitals, Greens Road, we had completed. Kinder Hospitals, we completed. Sri Kamachi Medical Center, we completed. Aster Sanad Hospital, Riyadh, we completed. Charnock Hospitals, we completed. St. Peter's, we completed. Medcare Orthopedics and Spine Hospital has been rescheduled in the afternoon. Rajgiri, we had completed. Peerless, we completed. Apollo, we completed. Apollo Bhubaneswar, we completed. Kalinga Institute of Medical Sciences, we completed. Apollo Sage Hospitals, we completed. Trauma Center, IMS, BHU, last call. Trauma Center, IMS, BHU, as in Bhubaneswar. Surprising, even not here. Okay, AJ Hospital and Research Center, we had completed. Atulya Senior Care, we had completed. TMU Hospitals online, which is a non-marked one, we completed. CMC Vellore online, which is a non-marked, we had completed. And we had completed revolutionizing OT management with AI-powered OT module online, which is non-marked, completed. We had patient critical Pneumosat 2 presentations, which has been completed online. NMC Royal Hospital Sharjah has also not turned up. We will connect with them and we'll see, and we'll try to have them scheduled in the afternoon. So the afternoon we have a set of interesting presentations of around about 20 plus presentations. So it's going to be really eventful day for all of us over here. Thank you for the patient audience. I would ask my fellow organizers to say a few words before we close the session for the morning.
So I think I've taken the mic for the first time. I am really excited, and in all listening and hearing modes, I think the jury is doing a wonderful job of asking very relevant questions, and the audience is being very compliant. And thank you for all the patient listening and the questions. It has been really nice session. For me, it is among the first gatherings in Kahotech where we are, looking at adoptions and innovations on ground, which are being competitively being judged. So what I'm looking at is a lot of learning opportunities. There are a lot of problem solving solutions that we are seeing at implementation level. So I would love to see everybody connect with the solution providers, with their colleagues, so that we can see to it that these solutions are then implemented pan India, and the solutions are then adopted easily, and we are able to, come up with better solutions for bigger problems than the base problems. Right now, the problems are still at the data collection levels, at awareness levels. I hope that by next year we are able to surpass these challenges and come at better analytics, better questions, and better solutions. And seeing the solutions today has been a really nice exposure and a very broadening of the vision, with the technologies coming from compilation to engaging models until decision assisting models, where we are able to see PTCA being assisted with AI, where we have been able to see AI-enabled PCIs, then CDS, clinical decision support systems, and OPPs. So I'm really appreciating all those inputs, and thank you for giving this opportunity to sit at the first row and see the all presentations without yawning. Thank you so much.
Well said, Dr. Ayush. May I request the jury members all to come up on the stage, because our teams, our participants have to see your face for one more time. And for the afternoon, we do have a fresh set of jury members joining us. So just I'll hand over the mic to each of you. You could just say a few words and about you. Start with.
I'm Dr. Rajni Ashok. This is my first experience with the Kaho Tech. Thank you for inviting me and allowing me to join this wonderful August gathering. I learned a lot today. I'm honored to be occupying the chair of the jury, but I learned more than what I thought I judged. Thank you very much. I work as a Senior Director Quality for the Zuleika Group. We have hospitals in Sharjah and Dubai and some clinics. Thank you very much. India is always a very dear country to worldwide, and it's a proud place to be in. And we have reasons to be proud, and that each one of you are. Thank you very much.
Good afternoon, and thank you very much, Kaho Tech team. I am Dr. Loknath Das from KR Hospital, Bhubaneswar. Thank you very much giving us this opportunity to present here and to be a jury. Thank you all.
Hello and very good afternoon. I am Ananya Mitro. I am the Unit Head Administration, Fortis Hospital, Kolkata. So in Kaho, we are associated with Kaho for a long time, and this is a very good opportunity to meet old friends also. So every time we go and participate in Kaho program, so we get to see our old friends, and it's very nice. We have been here since morning, and we have been seeing a lot of activities going on in the technology field and a lot of development with much more association of the AI. So what I was feeling that yes, truly technology and human going side by side, and we would be marching ahead, and we'll do, all the hospitals will do very well in near future. Thank you so much.
Good afternoon. This is Partho Sarathi Mukherjee. I'm a passionate public health researcher. So by affiliation, I'm the executive director of Indian Institute of Liver and Digestive Sciences, which is in Kolkata. And also I'm dean and associate director of a research institute that is known as John C. Martin Center for Liver Research and Innovation. So I'm a life member of Kaho. At the same time, unless you have innovations, you cannot move forward. So if it is not, you have to try for innovation, you have to think for innovations, then only you can move forward. Thank you very much.
Good afternoon. Myself, Saji Matthew. I'm the Group CTO for Baby Memorial Hospitals in Kerala. So until last year, I was participating as a contestant. This year, so I'm privileged to be part of the jury. So as everybody said, it's a learning opportunity, how the digital technology is being adopted in the hospitals, the learning experience. So it's an opportunity to learn from each other. So thank you once again, Kaho, for inviting me here.
Thank you. Good afternoon. I think it's time for lunch. I think people are waiting for that. So I'm Devanand. I am the co-founder and executive director of company Next10T. I was the regional CEO for Aster DM Healthcare for Telangana Andhra cluster before, and also the Telangana chair for Kaho. So this I think is the second time. Last year I was the jury for the Pitch Fest, and this time for the innovation. So I think a lot of founders should have been here. You know, this gives a lot of opportunity for them to develop a lot of things in the market where the industry is looking for. So wonderful opportunity to meet all of you. Very, very interesting, presentation. So looking forward to identify who will get the winner's prize this time. Yeah. Best of luck.
Hi, good afternoon. I'm Dr. Priyanka Behel. I come from Woodland Hospital, Calcutta. And this has been a wonderful, wonderful opportunity just to showcase that every problem has to have a solution. This is more of a student rather than a jury. And I would request the Kaho to be present in the west of the country also. I come from a long history in Ahmedabad. Kaho is not there. Yeah. Coming soon. Okay. Thanks a lot, everyone.
I'm Dr. Jyoti Clara Michael. I've been associated with Kaho ever since it was born. And always I never would miss such opportunity because every opportunity is a learning experience. So congratulations to all the presenters. It was a great learning experience. Every single aspect that you have brought down kindled our thought, our inspiration. I think participants are going to take back a lot of information with them. I am a founder of HealthBridge, expert consultant and strategic advisor in healthcare. And salam alaikum for international delegates who have been here. We look forward for more delegates in the future. And thank you and namaste to all the delegates who are present here. And a special thanks to all the chief juries and juries. It was wonderful being.
Good afternoon. Myself, Anupam from Peerless Hospital. I look after administration and group quality. And it's a wonderful session what we have since morning. I mean, all of us from different part of the country, and we are engaging with such a beautiful innovations what hospital has driven through multiple cities. And this is a pure cross-learning what Kaho has understood, that innovation is something which has to have some mileage in healthcare, because innovation in the future of healthcare. So in that context, Kaho has rightly took over as a Kaho Tech as a conference, apart from Kaho, what they do for their annual conference. This is an exciting moment for all of us as a jury for wonderful cross-learning. Thank you. Thank you so much.
Thank you. I head the operations at Ruby General Hospital and Ruby Cancer Center, Kolkata. Thank you, Kaho. Thank you, Bhubaneswar. And this has been a fantastic morning. Excited to see the presentations of the afternoon sessions. And it is really innovations. And now we have to do the rest of it, which is upgradation and adaptation. So thank you.
Good afternoon. I'm Shoma Chakraborty, owner and co-founder and managing director of Goodis Hospital, Keshtapur. Actually, last time I was with a Kaho as a participant, and now thank you so much for giving me this opportunity. I feel that Kaho is, prioritizing patient-centric approach, innovations, adoptions, and as well as I feel that all the health, leaders, they are sharing their knowledge, exchanging their expertise, everything. So I feel that Kaho is something like which we can, establish a new patient-centric approach and all the innovations, all the adoptions, which we can go ahead more and more. Thank you so much.
Hi, this is Dr. Vijayalakshmi. I'm the CEO of Valli Hospital in Salem. And it was an amazing experience with a great platform as a Kaho Tech for all the hospitals to come and pitch in. And we learn from each other, and I hope we go back and try to implement as much as what we have learned today. Thank you so much.
So may I request our international co-chair, Dr. Rahul, to come and share a few words. After that, I'll request Bobby Madam, who was a jury. So please, Bobby Madam, who was our jury committee co-chair, to talk.
Good afternoon, everyone. I know we are nearing lunchtime, so I won't be taking much time, but can we have a big round of applause for our jury? Literally, it took maybe one email, one phone call, or one SMS to all of these, and they were willing to come. Some of them have traveled international just for this, just to be jury member. This is fantastic. So all of them deserve a big round of applause. Thank you, all of them. To this side. Now, so far, we always used to have these Kahotech Innovation Awards, but the entries used to be quite limited. Dr. Ayush, Mr. Raj Rajan, Dr. Bobby have done a fantastic job. This year, as Dr. Lulu was saying, we have something like 120 entries, which is amazing again. So thank you. And of course, all of you, everyone, all the jury members have been so impressed by your presentations. So that is something that is really good to see that kind of innovation, to see that kind of passion to improve our healthcare. It's something that really takes the heart. It's fantastic. So can we have a round of applause for all of you as well? Thank you. Thank you.
Very good afternoon to all of you. Please bear with me. My throat is not okay today. I thank the CAHO team, the hospital innovation and the early adoption team for all the hard work they have put in. Because this time, as Dr. Deshmukh had mentioned, the number of participants were many. So unlike last time, wherein we had only 2 levels of screening and presentation, this time we had to make it 3 level. And then some of the presentations were very good that we had to bring it to the, we couldn't have that limited minimum numbers because of the marks which they have scored. So the final jury members are here, and I would like to thank all those jury members who took out their time for the level 1 screening and the level 2 online presentation as well, those who couldn't come today. And wonderful presentation by the hospitals who had participated, who will be participating for the afternoon session. I would request the jury members who are here, who would like to volunteer to participate for the afternoon session, can participate as well, so that we can note down your names. There's a slight change in the timings for the early adoption presentation, because it's just going to be 1 o'clock. So 1:30, as per the schedule, it is mentioned as 2, but we'll start at 1:30. 1 o'clock, we'll break for lunch. Lunch would be just outside this hall. Meanwhile, the audience, if you all want to ask any questions, if you have any questions to any of the jury members, you can ask them. Thank you so much for your wonderful participation.
Yeah, so again, as I said, the CAHO Diagnosticon is happening. Next big marquee event of CAHO, it's happening in the city that I come from, Chennai. That is going to be the CAHOCon at the Chennai Trade Center, April 10th, 11th, and 12th. I'm looking at all of you to come and participate in that as big numbers as well, and also spread the news about the CAHOCon, which is happening at Chennai in the month of April. So we look forward to have you all over there as well. CAHO Diagnosticon, CAHO Con at Chennai, at the Chennai Trade Center. So any queries to the jury members? Any doubts? Anything to the jury members? Yeah. Go ahead, sir. Cost implication. Would any of the jury member?
So there was an example of use of robots in home care that in case of stroke patients, right? So I thought that I will ask a question that what is the cost implication? Because cost effective aspect is very important, and using a robot in a home care country like India, how much it is possible. So of course, technology and innovation should be there, but cost effectiveness must be considered because India is a resource limiting country.
Thank you for that. I can ask somebody from the audience also to give input regarding this. Mr. Ananda Padmanabhan is sitting here. Sir, your views on this, you would be the apt person to answer this. Could you please introduce yourself also?
The first corporate hospital of India.
Thank you.
In the technical field. And he's somebody who many of us in technology field would always go back to. And I wouldn't say he has aged. He's been aging like the wine and still has his own startup, which is 10X Health, and many of the companies which had presented, including Apollo Hospitals, Sri Kamachi Medical Center, have been using his technology 10X Health. He is also supporting our Kaho Tech with a wonderful stall. You could go there to find out more about it. Over to you, sir.
Thank you, Rajan. Thank you, Bobby, for such a wonderful introduction about me. But I've been in this industry for about 35 years now. I started my career in 1983 in Apollo Hospital. I've been focusing on technology. And to answer the question about cost, believe me, now cost of implementing technology is not very high. So if you know what technology to implement and what applications you have to develop, it is very easy. In fact, we have developed some applications which are used in tier 2 cities. You will find about 3 or 4 people have come from Tanjavur, they have come from Coimbatore, they have come from Trichy, and they have done the implementation. We use IoTs. We don't use building management system, which costs about 1.5 crores or 2 crores. So I think we must be able to reach the appropriate technology. That is very important. And you must use frugal engineering. Frugal engineering is the word. If you look at Sridhar Vembu and all that, that's what they do. We can develop technologies for India, implement it in India, and implement it outside India. That's what we have done. And thank you, Rajarajan. Thanks for Kaho Tech for giving me this opportunity. Thank you very much.
Thank you, sir. Nice example you gave of Mr. Vembu. He started his zoo office in a very remote place in Tamil Nadu called Tenkasi or Mattalamparai. You cannot even, many of them from Tamil Nadu itself, they may not be knowing the places. So he's having his corporate office out there, and many rural employees, rural people he had given employment, and it's a big business model with frugal money. And the second person I'd like to ask would be Father Johnson. Father, regarding cost effectiveness, Father is the CEO of one of the most famous hospitals in Kerala,
It's
Rajagiri
the Hospital Forum of Kaho.
and lot of technology in his hospital. How cost effective it was, let us find out from him.
So Father Johnson, sir, also heads the hospital division of Kaho. So all of you out here, if you all want to, if your hospital is not already part of Kaho, so Johnson, sir, Father Johnson is the person you can get in touch with. You can become a member and be a part as an institutional member as well. Over to you, sir.
I don't have a one-point solution for the entire investment on the IT and technology. But one thing I can say from my experience that digitalization gave me peace of mind, and I sleep peacefully, because finally all these things end up with patient safety. I come from a state named Kerala, which is very conscious about patients and their rights, and they fight for that. So the technology makes you safe. That is the number one. And number two, again, as sir said, we should be very careful about what we go for. You can go for a lot of fancy things, which some people can afford, some will not be affordable. I come from a mission hospital background, and I pick and choose what is needed. That's my answer. Thank you.
Thank you, Father. I had the opportunity to visit Father Johnson Hospital. It is one of the best hospitals in terms of process complaints. One more person I'd like to ask would be Mr. Devanand, because he also had been managing a group of hospitals. So about cost effectiveness, I think you should also say a few words.
Yeah, I think the stalwarts are already spoken. So nothing much, but I would say that, we have piloted a lot of technology products in various hospitals. But yeah, Aster would not be a comparison when we compare that with the tier 2, tier 3 other, markets as well as the hospitals. So, but what we have seen is we have done a ROI also on various technology initiatives that we have done. It could be in terms of efficiency. It could be in terms of the staff satisfaction. It could be in terms of reducing the employee burnout. It could be, may not be in a tangible way, but you get the benefits. It can't be every time, you can't connect that with the money part. You have to also look at the employee satisfaction, your patient satisfaction. These are all not measurable in terms of cost. But there are technology products which also gives you definite cost benefits. And we have seen already a lot of products like that being presented today. So like the other two experts said, the basic thing is that what is that thing which can benefit either of the stakeholder. Either it has to be the patient, or it has to be the employee, or it has to be the organization. So you have to look at either of these three stakeholders. Getting benefited of any technology product is something which you can confidently invest on.
So thank you, Devanand sir, for that trifecta of technology selection. It literally came from the horse's mouth because he has just recently jumped ships from running hospitals to running a technology company, Next NT, a month back or 2 months back. He had announced and took us all by surprise. Thank you. It's a pleasure having you here, sir.
One thing of course, it's not related to just cost effectiveness. At our hospital in Zulekha, we are from the legacy system, we are going into digital transformation. And on that line, we have chosen our vendors to be Oracle Health, the previously known Cerner. And the main message that is being driven is basically change management. Is people being receptive to the change of digitalization, because people get used to the legacy system, and then we find that whatever system you use, the system is there. But then to drive the message of change management becomes the main challenge in the system. And then once the a lot of things come. Digitalization is taken over, AI is already there, and nothing changes as fast as technology happens. And then the benefits do come, and then no more the word cost. Implication is that it's cost effectiveness that we see in the long run. But what my message is that basically it's change management that has to be driven, and that has to be driven from the leadership and supported by the staff. That's the message that I have seen in when we go for digital transformation.
Saji sir is again a stalwart with respect to health technology. I have one-to-one sessions with him, what technology you're bringing in and stuff. He's been with HIMSS, he's been with Chime, and he's somebody in the industry. We always look at what they're doing and learning from them. Over to you, Saji sir.
Okay, good afternoon. Presented here, if you look at that WhatsApp-based interface for operational automation. So now we have a technology available. In the past, it was like you need to set up the entire IT infrastructure. You need to have expertise to run it and on premises. Now it is most of the technology, it's cloud-based. With your mobile devices, with the connectivity which is available, it is very cost effective. And we have a lot of products from India, made in India, for India. So it's cost effectively we can deploy it. It is the mindset, and as Madam said, it is the change management we wanted to adopt. I mean, we have been traditionally following paper-based workflows. Now we change it, so there is a change involved. It is difficult, especially with the medical fraternity, that we need to overcome. Once we see the benefit out of using systems in terms of patient safety, error reduction, and even ROI, it's possible. So with that, so we'll be able to see the benefit out of, even for small and medium scale hospitals. I'm part of the NABH driving the digital adoption among that one, part of that one. We are going, and a lot of major hospitals also now mentoring. There is an initial inhibition about adopting technology, but we are helping. NABH has taken an initiative, QCI. So this coming Saturday at our hospitals, we are calling all the nearby medium and small hospitals to mentor them, give the guidance, and NABH and QCI is also taking a lead on that. With the technology, Digital India, it is possible in cost-effective way with the adoption of appropriate technology. Change mindset, that is very much required.
Yeah, thank you all. So the jury members' felicitation is also the end of the day. Now I would like Dr. Ayush to, he's a chair of our session for the day. So to close and also have a photo up with all the jury members. I think you've already spoken. You want to just add something?
I'll just, as you requested, I'll add to the last point on the cost reduction. Was a good discussion. From my young experience in front of all the seniors, right? I'll just add that I have learned something, that the currencies have changed. Now, when we talk about cost, the money rupiah is not the only thing that is left. The first cost thing that we have to value is time. Time is the most important shared value. So man hours and time is important. Second value is again money, cost, consumables is there. And third, very important thing that has recently come up is data. Data is another currency that we have to value. And data has got a lot of value. Like you can have data in coins and you can data in larger denominations. So we need to value which denominations we are looking for. So that is my closing message, that the currencies have changed. Let us value something more than just money, time and manpower and your value and patient value. What value you add to the patient's life is another currency that is now being looked upon outcome as a doctor's output. That whether he's adding value to it or he only doing procedure, only providing treatment. So that would be my closing statement. Thank you very much. And let's have a photo up and then break for the lunch.
Yeah. Go ahead, man.
Couple of questions that I framed just now, listening to listening to you all. So my first question will be, do we think AI and tech, especially robotic, is a myth at present? Will 25-26 in healthcare, and how will it scale up? I want to know on affordability awareness in India, especially how middle class will be benefited in India. And I want to introduce myself as Rinki Palit. I'm with Goodis, associated as AVP, Associate Vice President in Goodis Hospital. I'm working with Shoma ma'am. Thank you.
Any jury member?
No, I just want to know anybody who can well answer
Yeah,
this
you can
question.
just, repeat the questions once again for the jury.
Yes. I want to know, do we think AI and the technology that we talked today is a myth at present? How will be, how it will scale up in 2526? And want to know on affordability of awareness and how middle class will be benefited and be aware about this.
I'll go to the last question, the middle class.
Thank you.
Actually, the awareness among the public for the quality care, and their focus is now on what is a return I get when I pay something to the hospital or healthcare. So they always see in terms of value for service. So what is the value we get? What is the value I pay for money and what do I get back? If you see, for example, you go to cinema theaters. Now we have all these sophisticated cinema theaters. They do spend. You spend for the ticket, but when you go in, you start spending for the snacks and
Popcorn.
stuff. Popcorn, yes. And it costs much more than visiting a doctor for consultation. But people's mind shift is changing, including middle class. They want quality.
Yeah, that is
and
what I'm
they
saying,
are
that who's-
approaching for quality. And they also understand when technology is incorporated, they are more transparent. They are in the middle of the treatment and the treatment processes because everything is known to them. They are participative and they are empowered. So this mindset I could see personally shifting from the previous mind shift to now. And the trust that they have started losing on healthcare, doctors and everyone, it will regain. This is what I'm seeing as a perspective coming forward, and technology will take it forward towards that. However, adaptation, customization.
Yes, that's
very
true,
important
because-
to the public we serve. So this is my point. Thank you.
Thank you so much.
Yeah, so the first two questions, the AI and technology, robotics. See, I'll club with what she mentioned. See, robotics now, if you look at it in India, when robotics was launched, it was such a big hype saying that, Da Vinci has come. Right now, every hospital has robotics. Every hospital. What does it mean? That Indian population can afford it. And because of this competition, the robotic machines have come at a low cost now. India, we are developing our own robotics. So what happened is that the care which was not available for a middle class is available at a lower cost with the technology spread. So that's one. And you should not be asking 25, 26.
Yeah,
Because the growth is in technology, the changes are happening in 90 days. Healthcare, less than that actually. It's very, very fast. Very fast means you can't, next 1 year, the kind of changes we can't predict now. That's a stage of growth that we are in, especially technology. The kind of products come every day. People are refining the platform. So it's very difficult to answer what will happen in 26. We don't even know what's going to happen in health.
about the healthcare goal, perspective from the health.
Yeah, definitely it's going to be beneficial. We can also always see the benefit in terms of, the clinical diagnosis getting better, the TAT getting improved, nurses' workload coming down. Some of the nurses may not agree because technology is not implemented at their hospital even now. No, I know that, there are technology products which can definitely help reduce the, rightly not implemented, yes, can reduce the workload of the nurses. So, effectively implemented, this all can be very, very beneficial for the society. So, we are not like he mentioned, maybe, I don't think if I look at my wallet, I may not have even a single rupee in my wallet now. It's become completely digital. That's what you wanted to say, right? So it has become digital. We don't go to bank now. We transact everything digital currency. So we have moved the digital way, the technology way already. Indian population has moved. My mother, who never used to, even know anything about digital things, she's always on Facebook, Instagram, and all now. So that's the situation. So India's changed. So we have to just adopt. We have to just move the change. But healthcare, having said that, is very, very resistant to change.
Yeah, that's
You will be facing the same thing. Sorry, my apologies to all doctors. Even now, a lot of hospitals are there which struggle to get the doctor under the documentation in the system. And we are talking about all this technology. So that's a reality, but times will push. If people don't align to this technology, they'll be removed. That's what's going to happen.
Thank you so much. And
Just
happy
to add-
to say India is growing and really happy to. Yeah. Thank you so much.
Just to add on to what Devanand said,
Yes, sir.
on the AI and robotics, if you look at, so it's been through, there is a very famous concept called hype cycle by Gartner. So for both for robotics and for AI, there was a hype cycle. 30 years back when I studied in the college, I did an AI paper, but nothing happened until 2022 November when OpenAI came up with the ChatGPT. So that
Yes,
was
yes.
a moment. So that's now that last 2 years, if you see what is happened. So now how many of us write a letter? We give the prompt to ChatGPT, it beautifully creates document for us.
Yes,
So we are seeing the results. In the medical care, I could see in the next maybe 1 year time, AMPI and DMR will be a big thing because it's doctors were blaming previously, like they were losing the contact with the patient. So they need to look at the screen and
Right,
type things.
right.
Now with an AMPN, from the conversation, details will be captured and it will be beautifully formatted with the kind of clinical decision support required, and the doctors will be, their augmented system will augment. I wouldn't say artificial, but augmented intelligence will come. The human natural intelligence will be there, but this will be augmented, which will save average 2 to 3 minutes from the doctor consultation time, because if somebody has to sit and type, so this will save. So that will be capacity building. Say the cost that you are investing will return back in terms of capacity. A doctor maybe in a typical day, 10 to 20% will be able to see more patients. So that's why immediately, but when it comes to hardware, robotics, because of the cost involved, so we may see a slow adoption. Where we can scale, it is a low cost adoption.
Right,
That's the
right.
key.
Thank you so much.
Technology, having more technology knowledge. The doctors are already facing
Yes, doctors are, they
My
are,
diagnosis now to
true,
doctor.
true, true.
My diagnosis is correct. Everything ChatGPT results have come. Please validate.
Yeah, you like to ask and we like to answer. This will go on forever and ever.
For the
So
yes.
we will continue this at the lunch and stuff, but
Sorry, I had to hijack you guys, but like I'm really satisfied with the answer.
Yeah.
I had question to ask at the last moment.
thank you.
Thank you.
Yeah,
We would request the audience also to join in for a group pic.
yeah, first we'll do this. Yeah. So as we are assembling for the group pic, the ladies first and the men and the second row, please. Yeah. Yeah. No, I don't think so, sir. That won't get covered. Maybe. I think for the jury and this thing, we can be here this way. So as we are taking this photo, before we close in, we all know what Edward Deming had said. What did he say? What cannot be measured? Cannot be managed. Okay. But do we also know that Deming, the same Deming, the father of quality, later in his life, also mentioned not everything can be measured. Okay. There is a concept. Today we all, healthcare as such missed out on industry 2.0, 3.0, 4.0. But Industry 5.0, we are already practicing in all our healthcare organizations. Because Industry 5.0 talks about how AI is going to get human-centric. How all our technology process. Yes, yes, yes. Yeah. Next week I'm there at Faridabad talking about that. Yeah, 5.0 is very interesting, and we are already following it in hospitals. So we didn't do it in others, but we did here in all the things. Thank you. Yeah, so we request the audience also to come in, whosoever will make some space, take a photograph, and then break for lunch. Those who are photo shy, or you can all, yeah, but the video cannot. Oh yeah, the photographer would come here. All of you can stand up. That's what it's called. The jury members can hand over the scoring key to any of us over here. Bobby, madam. campus to this. So volunteers are placed at the registration desk. They will be able to guide you how to go over there. So we look forward to having most of you over there. And the International Forum would have a meeting just after the dinner. And there are certain other CTO forum, technology forum meetings scheduled later in the day. And this session, which we are starting, we are looking to get it over around 5-ish. Yeah. Yeah. Yes, yes. So we have a couple of presentations of people who were not able to come in the morning and present it, especially NMC Sharjah, right? NMC Sharjah especially. Yeah. Two presentations from NMC Sharjah online and two presentations of Medcare we'll be having. We'll be starting with that. And after that, we'll be moving on with the early technology adoption related program. Come, Viresh. All the jury members request you to come forward. Yeah. He's the afternoon session jury member. Yeah, you can sit here. Afternoon session jury members also can come forward. Yeah. Sandeepan Karmakar sir from Woodland Hospital. Sandeepan Karmakar. Dr. Santosh Lora. Dr. Santosh Lora, Karya Hospital.
So welcome back, everyone. After post-lunch session, there will be a lot of sleep, a lot of yawns. So we'll try to keep it as interactively possible. And before we start with the early adoption session, we'll be having one session from the hospital innovation, and I would like to invite them on stage. We'll be having that session ready in few minutes. Can we have ma'am here? Can we have a round of applause? A warm round of applause, please. This is for your own. Keep your blood running. हाँ, अपनी तालियां बजाओ और खुद जागे रहो. Thank you. Please. One.
No, I'm just doing one presentation. Yeah.
Jury members who have joined late, kindly note that the early technology adoption presentations will start after this presentation. This is the last presentation of Hospital Innovation Awards, which other participants are presented in the morning. They have come all the way from Dubai and they reached now only. So they are given an opportunity to present post-lunch. So those judges who are having, the jury members having the evaluation form for hospital innovation, kindly mark the same. And those jury members who do not have work for the afternoon, you can please listen to the talk. Thank you. And the evaluation you all can start post this presentation. Thank you.
Can I start? So good afternoon, everyone, and good afternoon, jury. My name is Akanksha, and I'm a Group CNO for Medcare Hospital and Medical Center. And I'm going to take you through retaining talent, restoring balance, a take-driven nursing journey, and how this journey started, how this journey began. When one of my nurse, her name is Yara, her in February 2024, she has resigned. When she has resigned, and she was a high-performing nurse, so I thought as a Group CNO, let me interact with her. And when I've interacted with her, it was an eye-opener for me. Can you go to the next slide, please? Can I have my slides? Yeah. So it was, as I said, it was an eye-opener. Why it was an eye-opener? Because we were very content because our attrition rate was 23%. We are telling, globally it is 25 to 30%. Is an acceptable rate for nursing attrition. When it was 23%, we were thinking we are doing good. But this nurse has brought to us a lot of issues like burnout issues, especially the nurses when they do a lot of non-core activities, when they're involved in different activities, or when the duties have been not balanced, when the workload has been not balanced, or when they have not given the access for the training. Because we have in Dubai, we have a 12-hour shift. After 12-hour shift, when we were calling them, asking them to sit for the training, they were telling we were just sitting for the training. We are not gaining the knowledge. So all this was the issue. We thought, okay, fine, it's this not one Yara. I thought it might be many more Yaras. So I thought let's have the burnout assessment test for the nurses. And this was a evidence-based solutions or evidence-based documents, which we thought we will use it as a take-driven. So we had a nurses burnout assessment test. And then, especially the goal was there to reduce the nursing attrition rate from 23% to 21% or 20%, minimize non-core activities, optimize resource management, and enhance access for training. So what we have done is, as I said, we conducted a burnout digital survey, and 47 nurses have come out in burnout assessment. And then we thought, okay, let's have the focus group discussion because, and this burnout assessment test was not done by the nursing leaders. We thought, okay, let's a third party do it because they may not open to us what are the issues are. So when we did a focus group discussion, it was another eye opener for all of us. And then which help us to identify non-core activities, then limited training hours, their workload imbalance, so that let's see it easy. when somebody tells us that, okay, we have a less hours, we have burnout, increase the nursing staff, that's what staff feels. And all of us, we know it is not easy for us to increase the nursing staff because it's a global shortage. So we thought, let's adopt some technology which can help us to improve the nursing workflow. So we had a project chartered, we had a multidisciplinary team, because see, always we need to have a multidisciplinary team, because it's not the nursing, we feel, okay, it's a nursing issues, but there are a lot of other stakeholders are involved into. So we had IT, we had HR, we had service excellence, and we had our bedside nurses also into this project, even including our operation and finance, because finance is important. When we need any approval, we need a finance buy-in into this. So then we thought, okay, fine, let's have a tech-enabled solutions which is user-friendly, because we get a lot of technologies which are not user-friendly, and it fails later on because people are not able to use it. So we wanted somebody which a technology solution which is easily adapted by our nurses or other patients. So that's the reason we have come up with one app that is called as a Treatwell app. So major issues, what we identified when we did our burnout assessment and focus group discussion, it was major issue was nursing call bell. And nursing call bell is the major issue for the non-core activities. And when we have done the study, 36% of the nursing work was done by the nurses on the floor was a non-clinical. So we thought, let's have something where all these calls which are non-core in activities can go to the respective AI-powered solutions which can help us in automation of the calling. Then
Last 30 seconds, ma'am.
yeah, we had a traffic analysis, and based on the traffic peak analysis, we have developed our duty rostering. As well as we have thought, let's have the nurses for the training accessibility. So we have bought the Lippincott where nurses can have the access for their training anytime. So outcome, nurses retention has, we have increased the reduced the nursing attrition from 23 to 18%. Efficiency gain, 4,000 nursing hours was saved by us. And then our call bell response by the patient has rose from 94% to 95%. And even our nursing patient satisfaction also has increased. And then we have been actually awarded as a great place to work. And maximum survey when you do the hospital, it is nurses who take the part, and 87% of nurses have taken part, and this is what we have done it. And operational benefit is this is last, okay, no shows have reduced from 20% to 7%. Definitely this is a scalable. Anybody can I take just a second?
Ma'am, we are very strict with the timeline.
Okay, fine.
Ask the jury to take the.
Yeah, thank you so much. So it is quite scalable. We have scaled in all the hospitals. That's it. Thank you so much.
Thank you. We'll wait for the questions. Can we have any questions, please, from the jury?
Sorry?
Because in the context of how that all from the patients,
Yeah.
how are that?
So this One Touch app, where it is an app which is a QR code based. So patient or patient relatives can scan it, and the request can go to the respective stakeholders.
So how are patients prepared for this?
So when patients get admitted in the hospitals, on the admissions, when nurses do the orientation, they orient the patients on this also, and the patient's relatives also.
So that is an additional work for nurses.
So any nurses, they're orienting. Yes, nurses have to give the room orientation. So it's just one point which has added, which has helped us to reduce the nursing 36% of nursing workload, because that 1% can help us to reduce 36%. Adoption rate, I can tell you, it is from the patients, it was initially low by 30%, but now it has increased to 75%.
Ms. Akansha, good work. I just want to know about, you talked about some of the non-clinical works. What are some of the other than the one touch, which is redirecting the call bell? There are other things that they do related to insurance work.
Yes. So if for insurance, that's what. So we had one is automated calling because nurses were calling the patients for the this appointment confirmation. So we had this automated calling in the patient's. This AI powered understands the patient's nationality, and based on that the call goes to the patients in their own language, which nurses was not able to. And that's the reason we were able to reduce our no shows from 20% to 7%. That's one thing. Second thing, for the insurance, we created a dashboard where nurses were able to see which insurance, what is the eligibility, whether can we take the insurance approval, can we go ahead for the test. So it has decreased the nursing workload there also. Yes, for the insurance, it was in-house solution. Treatwell app, it is means One Touch is from Treatwell, and Exotel, AI powered calling was from the Exotel. Yes. Yes, because yes, because all these were the nursing workload, and nurses were burnout because they were not able to spend that much of time with the patient. But this workload, this workload actually, whenever there is a high workload, nurses get burnout because of the high workload. Because this limited, now see, we were able to save 4,000 nursing hours. That much time they were getting to have the direct nursing care with the patient. They were their breaks, they were able to take it. They were able to. Otherwise, nurses on floor sometimes they don't take any breaks, no biological breaks also. And I think nurses sitting, they will understand with me, because if there is a workload is high, they will not able to take the breaks. When they have their limited workload, they are also happy. If patient is happy, they are happy, and then definitely that burnout will reduce. 47 nurses. That 47, yes, that 40. See, usually we have seen that this burnout usually leads to the attrition, but this 47 nurses are still there with us because we have counseled them. We told them, let's see that you are, and what we have done it. In fact, all these 47 nurses were awarded in our Nurses Day because they have given us a solution, and they have they were the eye opener for us. So we wanted to have that culture in nursing where they can bring out their more and more issues to us, and they know that it's get felicitated.
Thank you, ma'am. And thank you for that amazing session. I think nursing nursing retention is a big challenge, and talking about burnout is a very major challenge. Thank you very much. Can we have a round of applause for ma'am?
Thank you. Thanks.
So now I think that is the last of the hospital innovation presentations. Anybody else who's here who would like to give any presentation whose name has not been announced? We have only one name left who is not present here. So we'll be closing that. And with the closure of the hospital innovation session, we'll be asking our jury also we'll be relieving our jury from their duties.
Thank you all the jury members who had been so patiently evaluating all the presentations since morning. And the jury felicitation is scheduled for evening at the end of the session. However, one of our jury member, Dr. Rajni Ashok, needs to leave now. So I would request Dr. Rajni Ashok to come up on stage. And may I request Dr. Ayush Gupta, the chairperson for Hospital Innovation Awards. All co-chair, Mr. Raj and Dr. Rahul Deshmukh, to come up on stage to give away the certificate to Dr. Rajni Ashok.
So now we'll be starting with the early adoption. I'd like to revise few rules. Every presentation will last for 5 minutes. After 5 minutes, the jury will get the right to ask 2 questions, maximum 3. and audience will interact with the speakers post their session when they would like to. There will not be any audience questions or any question rebuttals, and jury will be able to ask 2 questions. We'll try to keep it as crisp and more interactive as possible, right? And try to limit with the time limit. After 4 minutes, when 1 minute will be remaining, we will be giving one bell, and for the last 10 seconds, another bell, and that will be all of it. So we'll try to keep that, we'll ask you to cooperate with the time management. Thank you so much.
So as Dr. Ayush had mentioned, I would request the participants to adhere to the timelines of 5 minutes, and the jury members, as we had in the morning session, for the afternoon jury also, 2 questions per presentation for a maximum to 2 to 3 minutes only. And before we start with the early adoption presentations, I would like to make an announcement. I've been just told that there's an evening dinner by the founder of KIIT at Rose Garden in campus number 12 or near campus number 12. So all are welcome to attend the function, and all those who are, including the jury members, the audience, everybody are welcome to attend the dinner, networking dinner at 7 p.m. and all are requested to be seated there by 6:45 p.m. Thank you. Shall we start as per the schedule?
Okay, so the start of another entertaining session. The first of the early technology adoption finalists would be from New Moassad Hospital, Salmiya. So they will be presenting on Sopio Now real-time patient journey across all care pathways in ER. So Mr. Vivek is here, the CEO.
Good afternoon, everyone. My name is Vivek. I'm here to present the real-time patient journey, and I have my colleague, Mr. Abdul Salman. As you would have seen the presentation from my other colleagues in the morning through the remote session, our hospital is the first private hospital in Kuwait, started 60 years before, duly accredited from the JCIA and Canadian accreditation. The problem what we had to adopt to a new technology was waiting time in ER. So what was the issue we had is because of the waiting time, there were patient dissatisfaction and there were issues, complaints from the patients, which affected their patient care. So the context for why we are adapting to this new technology is because when we analyzed, we saw 30% of the complaints were linked to waiting times, and patient satisfaction in emergency department fell down by 70%, below 70%. The goal is to ensure that patient experience is delightful and they have a good journey. I'm sure when patient come to ER, nobody's going to enjoy, but at least to make it troublesome for them. The goals, what we have is smart to introduce a real-time dashboard for the management team, for the administrative team, for the supervisors, for the clinical team to ensure that what is happening in emergency department, we are able to see live as at one go. So it is measurable every 5 to 5 minutes. It is getting updated in the system. It is this system, Sopio Now, is from Singapore, as Raj was saying, to mention the vendor name. They are from a company called Sopio Now from Singapore. We're able to have all those data connected to the system. So the time what we have given was 3 months, and we are able to do it. And we have used PDCA technology. And the main decision we took based on this report was to have a first pediatric emergency department in Kuwait. No other hospitals in Kuwait have an emergency department. Because of the data, what we are seeing, the bottlenecks, we started a new pediatric department. The outcome, as we would have seen, the first one was reduction in patient waiting time. The overall registration to patient consultation was from 23 minutes last year. It came down to 11 minutes after we have adopted to this new technology. The patient positive feedback, again, as I said, it was 70% below. Now, from there, this year, it has moved up above 85%. And the last one is the patient cancellation. Again, this also was a concern to the management team that why we are seeing cancellation in patient after they do a registration. So that also has come down from 51 to 14. The outcome and the impacts, what we are able to see, we are able to have a real-time smart dashboard. We also are able to have a clear patient category based on the illness, red, yellow, and green. If it is really critical patient, they don't wait for the reception triage. They directly get to the patient ER bed. Otherwise, they go through the waiting system, and the instant alert to the supervisors and the managers wherever they need to allocate extra resource based on this was done. And as management team, we also have a remote monitoring on the patient movement. And we also get a constant daily, weekly, monthly report on all the parameters. I'll show you a few of the parameters. And yes, this is scalable. What we have done in emergency department, we also have replicated in radiology department. And we are also considering doing it in pharmacy and in outpatient clinics. And it is in the process. The team involved in getting this done from quality, medical service, IT, operational team, and nursing department. Some of the dashboard clips, what you can see, the triage, this will be the flow of patient from the time they get inside. You can see a sample of 84 patients have come inside the triage. And as per our benchmark, we are able to see 82 patients less than their scheduled benchmark time, which is 15 minutes. And other systems you can see from a consultation perspective, out of 82 patients, 79 patients were being served within 15 minutes. The other dashboard is, we also will get to see on other parameters of patients, like from their nationality, insurance and cash patients, male, female, and all those kind of categories. And also the peak load moments, we are able to see, from the time morning till night, when is the peak, accordingly the duty schedule has been made. It is endorsed by the leadership team. So now we are in the process of implementing it in other departments, as I said, in pharmacy and in outpatient. The waiting time, again, as I said, it also helped us to ensure that the clinical care to the patient was being taken care. So it's not only support us from an administrative perspective, but also to ensure that we are being able to manage them clinically as well. And we also have linked this to the performance appraisal of the clinicians to ensure that the doctors take extra time to ensure patients are being taken care. That's all. Thank you.
Technology part.
It is, as I said, it is a web-based solution which was provided by the third-party vendor, and it has been integrated with our HMIS, which is Oracle in-ground software, and it reads the data only. So it takes the data from there and present it in a format which we would like to see, and it is on a real time.
Layer on top of the HIS.
Yes. It's an integration which we have done during those 3 months, and it has been one-time integration. Now we are able to extend it to the other areas as well.
This is the early technology adoption panel. So in early technology adoption, we are looking at companies which have taken up some technology product and used in the first year and the outcomes of it. So that is what is spoken in the early technology. Morning, what we saw was all the hospitals where they've used some other application also, but also their own application, and they have expressed more number of years of data and stuff.
We have done this in 2023. Now we have almost 1.5 to 2 years of data. Yeah.
What's the threat to patient?
Threat?
Threat to the patients.
No, it is, you mean data confidentiality or?
No, I'm not talking about data. I'm talking about the patient. Patients are coming for life saving. It's emergency. It's not any other IPD, OPD services. It's emergency.
Yeah.
When you do this and you allow these patients to walk straight away to the red zone, yellow zone, green zone, don't you think that makes somewhere else?
No, it has been monitored and guided by the staff nurse and the receptionists who are there in the team. So if a patient comes under the red category or even yellow category, they don't go through this triage system.
The first point of contact is?
Directly to the bed, if they are under red category, under the patient resuscitation room, if they are critical. But otherwise, in Kuwait, you get a lot of primary cases as well in emergency department because of insurance and cash payment options. So they come to ER even for a common cold as well. So 80% of the patients come for a primary reason, and then 15 for semi-critical, and 5% was or very critical. Sure. Real-time entry. So it has been constantly monitored by the quality department, and the reports being validated on a regular basis, on a daily basis, to ensure that it is matching to the past history of the hospital. Thank you.
Yeah, give it up for team New Moasat. Great. So next up, we have the team from KPJ Specialized Hospital. So they would be doing on KPJ PMS, the Patient Management System.
And requesting all the juries to please put the questions on mic so that the audience can listen to your questions so that they can learn. And we'll
So
keep
yet
it.
another international team.
Can we have a round of applause for them, please? Thank you.
Good afternoon. Here present honorable jury, respected delegates. Myself, Jubair Mahmood, the manager pharmacy services on behalf of KPG Specialized Hospital. I welcome you all in my presentation about the patient management system. It's called the PMS. Our PMS, it is a comprehensive software solution. This PMS enhances the administrative, clinical, and operational process within the healthcare facilities. This patient management system provides a simple dispensing to the entire patient care life cycle. Why we need this PMS? Because this PMS is the engine for the organizational excellence. And this PMS provide the automatic prescription, billing, and inventory management. Pharmacists and pharmacy staffs can easily focus on the patient cares because of the time reducing. And this PMS allow the doctors to quickly monitor the patient's medical history because all of the information are integrated in there. Inventory management and financial calculation comes by the utilizing analytical data in the PMS. Sorry. Actually, what is the goal of our PMS? As we know, this PMS can provide the 100% automatic prescription that will provide us the zero error. And this goal is manual task reduction. We have achieved its 80%. And our goal to achieve the 0% error by ensuring the 100% implementation and training of the staffs. And directly it reduces the administrative burden, cut errors, and improve the patient satisfaction. And this full implementation and goal achieved within the 6 months. The methodology, I can say this. Previously, doctor prescribed by the handwritten. It is not clear what is the dose and the medication name, so error can happen. This our PMS ensure this the computer generated prescription, so you can easily and everyone can see the dose and the medicine names. And this is the 80% reduction of the manual tasks in different aspects. Here's the small portion of our PMS. You can see doctor can add the medicines and it automatically comes to the pharmacy departments, and pharmacist can see by the color changing. And when, as we know, the high-end medicine, doctor prescribes sometime for the ICU patients, so doctor can add the high alert option. And for the ICU and CCU patients, there is a lots of medicine required at the same time by the Shields pump, so they can use the quantity as usual. So by one click, medicine goes to the pharmacy panels. Some of the pediatric patients, there's a very small amount of dose required for the patients. So doctor can select the reuse item. So only one items they can use repeated times. And another option, doctor can add the tapering dose by just only one clicking is there. And when medicine starts from the pharmacy, the unique barcode is generated by the MRN and with the base number of that product. When the medicine dispensed from the pharmacy, it goes automatically to the nurse's panel, and nurse can receive this medicine, the patient unique ID, RFID scanning. And when the patient administered requires, so they can scan the barcode, the previously I showed, and they implement as per schedule order. And if any medicine not used, we can easily monitor from the pharmacy services, there's which item not used, we can return back, and automatically the real-time stock updated. Now it's coming to the scalability and replicability. It is the 100% scalable and replicable because it is the modular-based feature, and multi-location from the small pharmacy to the hospital can needs, and cloud-based flexibility, and this PMS is always the upgradable. Why it is replicable? Because of the standard the framework. And this PMS is collaborated with the teamwork by the doctors, IT teams, pharmacists, and the nurses. And our next step is to introduce the AI in the mitigation alarm system, because we are habituated to the forget anything. So sometimes the misdose, it will come the notification by over the mobile phone. And if we do these things, then outcomes will come the reverse, the data driven and high efficiency and enhance the patient care systems. And we can say that this is our KPJ patient management system is not just a software, it is a strategic commitment of the organizational excellence. Thank you.
Thank you. Can we have some questions, please?
How do you ensure that the medication is finally administered in time to the patient, to the system? So everything, inventory is managed, I saw that happening. But finally, how do you ensure through the system that the medicine has been administered on time or administered at all?
Because when medicine not administered for the patients, we can monitor, it's automatically come to the return medicines. Return medicines. So we can talk with the nurses, the medicine is not.
My question was, how do you capture that time?
Sir, actually, when the medicine is not administered, so that time one report is generated to the chief pharmacist, so he can identify which medicine is administered and which medicine is not administered.
Thank you.
Could you please tell any of the triggers that are being incorporated into it so that that gives an alert?
Thank you, ma'am. Madam, from the system, if the medicine is not administered, so
Not only for not administering, other triggers relevant to them, because you have said organizational excellence. So what are some of the triggers right from the prescription to patient receiving the medicine? What are some of the triggers that you have incorporated into that?
we have introduced that when the medicine is prescribed to the patient, so when the patient went to the pharmacy and want to take the medicine, so which medicine is taken and which is not taken from the system. So system is already sent one report to the patient portal that patient has taken this medicine, and which medication is not already taken from the system. So patient already have the pending list in the patient.
AI-driven, I just wanted to know if it is linked to the disease condition or contraindication, or maybe food-food interaction, food-drug interaction, allergy. So those are some of the triggers that would help, because AI is supporting human being to act.
Yes, ma'am. We have another option in the PMS. There is we can say the pharmacopoeia, like there is we already incorporate the therapeutic class, dose, interaction, like side effects. So when the patient comes to the admitted in the hospital, so nurses, they also take the patient history, like have any medication allergies have or not, like this. So when this information match, then it will comes to the automatically to the pharmacy.
Thank
So
you.
you can.
Thanks.
Thank you.
Thank you, KPJ Specialized. Now we have BM Birla Heart Hospital coming up with leveraging tele-ECG networks for rapid cardiac care in a tiered healthcare model. Can we have a round of applause for them, please? BM Birla Heart Hospital.
Good afternoon. I'm Dr. Samir. I'm from BM Birla Heart. And as you might understand that my hospital is totally cardiac hospital. So I'll be talking about cardiac emergencies also only. Now, the thing is like the problem which we did face was cardiac emergencies coming from rural areas, and what kind of problems do we have? Like, they don't have access to cardiologists. The late ECG interpretation, what happens is it leads to a lot of mortality and morbidity, and we needed something which could help them, which is scalable and scalable. Plus, I was the guy who asked about costs. So there are a lot of options present. What would actually help them, which is cost effective? So we thought having a tele-ECG is good. Good in the sense it's cost effective, plus it is easier with a cloud, this thing, it's easier to manage. Like the specific, the goals were smart. Specific, we had a hub and a scope, we spoke model, 25 spokes with one hub, central hub, measurable. We thought of more than 1,000 ECGs, this thing within a year, achievable using the existing ECG machines and trained staff. We used Tricog Healthcare for that. Relevant because it is aligned to a national digital mission priority, and time bound because we could do it in within 1 year, fully implemented within 1 year. Methodology was as usual, hub and spoke, 25 centers connected to one hub. ECG was captured and transmitted security through cloud. Specialists interpreted them on real time, and patients were triaged locally, referred, and emergencies if needed. Outcomes measurable was, we took a data, I took a data from October 2024 to April 2025, 36 like 1147 across 25 centers, 36% were normal, managed locally, 48% were abnormal, managed with early specialist input, and 16 out of this 48%, 16 came as critical, which received, they came back to our hospital. There was CAG, PTCA according to the needs, and 21 were referred for CTVS. Like if it's a single vessel or a double vessel, maybe CAG or PTCA, and then TVD, triple vessel is CTVS. Now the impact was diagnostic delays was reduced by 70%, improved outcomes and timely care. Specialists workload was less, strengthened our emergency cardiac services in underdeserved regions. Scalability and replicability, it is easily replicable with the existing machinery which we have, cost effective, cloud-based, and minimal hardware needed, can be adaptable in tele-X-ray, tele-echo, supports a tiered healthcare for a national setup. Teamwork, the teamwork was a very big part because we needed the cardiologists to be adhered to, like cardiologists had to adhere, IT specialists, we had to train a lot of technicians and primary care providers. Training for the staff was, for the ECG and transmission was done. A continuous feedback loop was taken, retraining was done if anywhere it was needed, and it demonstrates collaboration and capacity building across healthcare levels. Sorry. Innovation and creativity, we use it real-time integrated, real-time ECG integrated into rural cardiac workflows. Creativity, we call it digital triage, 24/7 digital triage, because we were doing most of the triage digitally. Adoption, we did 1147 in 1 year. Future vision, AI-based ECG analytics, cloud EMR, plus other workflows like H. Conclusion is, we just didn't connect machine, we connected heart, tele-ECG, timely diagnosis, expert access, and better outcomes, scalable, sustainable, and transformative. Thank you.
Jury questions, please.
First of all, Dr. Samir, it's a good presentation, but one thing what came to my mind about these spokes, hub is there, your hospital is there, that I know, but about the spokes,
yes,
how you establish the spokes?
Because I'll tell you what, they are basically semi-urban and rural areas.
Right.
We found out places where people do come, but they don't have regular, people are coming from there, and we are getting a lot of patients from there, and they don't have a place where they can triage that. They are coming, like they come just because they have any kind of ailment. So it was, what it was doing is, it was increasing the workload of my cardiologist. It was simple thing. Someone having a simple, you know, how in Bengali, sorry, like, you know, I'm from West Bengal, say, book dharpad coaching, there's palpitation. For anything, palpitation, they used to come. And what used to happen is nothing, simple thing which could be triaged out there only. So we found out places, hubs, spokes like that in different places. We had a little bit of data gathered, did a little bit of data gathering from.
That is, you identified
yes,
the areas.
We did identify by data.
The analysis of the data.
Yes, analysis of the data, yes.
Hello. Yeah. So the hub, the person who's will be taking the ECG at the hub.
Yes, sir.
This will be trained nurses.
They can be trained nurses. We do even technicians, because everywhere you don't get nurses. So we do technicians, whoever is, and we train them on regular, we train them again, retrain them if need be. So there is a continuous feedback.
And the centers all work 24/7.
Yes, sir.
Okay. So the technicians are also working
Yes,
around the clock.
yes, sir. Yes,
So is there any error in the results that have you done any analysis of the, say for example, when ECG is taken, it's not done properly, the lids are not.
Sometimes it does come, sir. That's how the training and the retraining comes.
Okay. So
that's
you're
how
analyzing that also? Yeah.
Yes, sir.
Okay. Thank you.
Well, high school. What is the average stat for the reporting of the ECG?
So the TAT is like the moment it's transferred, it's immediate, sir. Because
to us
we,
from the technology
it's the
perspective.
TRICOG, this thing, they have a cloud base, they have
Yes.
people sitting out there. They tell to us also, and our people also read it in this thing.
So who's reporting the ECGs? Is it their team?
No, it's their team, sir. TRICOG's team. TRICOG
Okay.
Healthcare's team, sir.
Okay,
And then it's told to our people. We have got 24/7 associates, associate consultants who are DMs. They also see it, and they accordingly they talk it out, and they tell, okay, fine, you need to send them immediately.
So
That's
what
how
is the average stat that turnaround time for the patients?
you know, it depends, sir. It can be 15 to 30 minutes.
15 to 30.
Yes, sir.
Right, sir. Thank you.
Ma'am, I'll tell you what, a cost is there, yes, but it is a lot, the cost is incurred by us because we are paying TRICOG. The patients are not paying that TRICOG. Patients are not, because it's just one sheet of so it increases, like as someone was telling it, it was nursing. It's not only nurses get burned down, even doctors get burned down. So my workload of my consultants are coming down. That's a big boon for me. No, sir. No, sir, I'll tell you what. I can't say that free of cost. Why? Because they come. But then we have a layered mechanism. If someone is really needy, we have some funds, like we do CSR activities. Plus, what we do is we help them to get funds from elsewhere. That's a thing in process. We can't help everyone, but we try and do whatever we can. Thank you. Thank you, everyone, for listening. Giving my patient listening. Thank you.
So, how will since this early technology adoption, companies which are hospitals which are coming forward can talk about which technology they have adopted so that it will benefit all the other members.
This entire section
Yes,
is technology adoption.
So next up, we have the team from Sarvodaya Hospital, Faridabad. We already have a team here on top, but some more. So they would be talking on improving staff training, tracking and compliance to OD implementation. So over to Sarvodaya.
Very good afternoon, ladies and gentlemen. And it's an honor to present over on such a big platform in front of you all. And I would like to thank Kaho for this opportunity. On behalf of Sarvodaya Healthcare, I would like to present early adoption, improving staff training, tracking, compliance through Bodhi implementation. So it's like, I just would like to summarize that from the bud to the bloom. It's like a journey. We have not reached till the destination. It's a journey. So would like to present in the category HR excellence. Next, please. Yeah. So first about the introduction, as we all know, for the better patient care, for continuous quality improvement, there is a part which is called as training. And in all the organizations, we are training all the healthcare workers, whether they are doctors, nurses, PCS team, or anyone. So for the improvement and to have the better patient satisfaction and better patient outcome, we are having trainings. And keeping that thought in our mind, we implemented Bodhi. And Bodhi is a software, and it's an application-based software which can be put it down in the mobile also and on the system also, where the staff can have real-time based trainings, presentations, and learning-based topics as per their training need assessment. So the methodology we adopted was there was not such a lacunae, but the work for the training which we were doing in our department was like the training we were all doing on manual mode. So the gap analysis was done. And when we are focusing on a particular staff, so that we can close the gap and we can really find out that what the actual need where we can go through and improve the staff as per their competencies, we found that gap because we were not able to correlate the data from the past data of that pre or post test. So as per that, we involved that and we had this application which we started from the 40 learning modules basic, and then now today we are actually doing all the training data related things on this app. So the objectives were smart, centralized and digitalized staff training, then automated tracking and increased compliance for the staff, use Bodhi platform for integration, align with regulatory and audit requirements. Then phased rollouts with continuous feedback loops. So we are having the every quarterly reviews, and based on the multidisciplinary feedbacks, we are having the scope of improvement in this. So the key results and measurable impact, which I would like to mention is basically on the parameters: training participation, course completion rate, knowledge skill improvement, accessibility and flexibility, monitoring and reporting, cost and time efficiency, and then staff engagement and satisfaction, impact on clinical practice. So it's actually a big challenge to involve all the people, whether there is any department to the training because of their busy duty schedules. We were able to take them because as per their convenience, wherever they would like to take on the training, they can just log in and they can have the training. But yes, we have mentioned some timelines also to complete that and to give the pre-post. And after that, if the result is non-satisfactory, they can give the retest also. So we can see here, so limited attendance, it was a challenge face to face, and 40 to 50% participation was there because of the workload. Some people were joining late for the class. They were not able to give the pre-test. So it was very difficult to compile it up. But now it is very easy. So if they are just coming from the area where they are staying, they can just give a pre-test, they can attend the class, and they can give the post-test. And particularly, I would like to knowledge retention. It was not tagged. So we were taking actually the evaluation after the training, but now we are able to do the basic quizzes and evaluation also, and then again re-evaluation as per the scoring of the staffs. Then manual attendance register, everything now we have closed. It's all automated and real time based. The main problem was venue availability and booking, staff time. It was all costing, but now there is 20 to 30% reduction in this total training cost. So its scalability we have applied in the nursing field, but yes, we have started with the doctors also. They have also started training, taking in the modules, and so many modules as per INC credit hours we have started up. So specialty modules also we have started now. So this is the innovation in learning and development with the collaboration with other departmental teams. So this is the progress which we have started from 2022 to 2025. Yeah. Thank you so much. I don't know.
Engagement model that you have used in this?
Ma'am, actually, it was an app which we started as per the training need analysis, ma'am. So as per the requirement, like we
What are
started
the
from
engagement modalities you have used in this? Like they will interact with the app or
it was the application only, ma'am. We are providing the training material to the app, and they were going through with that app, including some videos, then presentations, and then they.
contents are in the what level? Like level 1, 2, 3, 4?
Yes, ma'am, level 1, 2, 3, 4. So we had 40 modules of basic trainings. And then after, as per the specialty basis, like for BMT, we had a special module. For oncology, we had a special module, which we have produced here, so that the specialized staffs can have the training and accordingly, they can have the evaluation and improvement.
Limitations in it?
yeah, limitations is there, sir, because sometime the attendance, if the staff they are coming to attend the class and we have started the pre-test, so sometime because we have given some time periods, 10 to 15 minutes to just log into that, and we will share the password in that they can means misuse, they can put the attendance, and if they don't want to learn they can. So these are some limitations for that. But yes, we are there on the rounds also, so we are tracking on daily basis. So we are there to coordinate.
Just curious, the pre-recorded videos are they really effective?
Sir, they had actually started with just 40 modules on general procedures. So, which is actually just a procedure as per the means books, that is fine. But if it is combating with our policies and protocols, that we need to look into, and they also need to cross check with us so that we can edit also on that app. And still we are going through for some other, like for PCS also we have started on, we have just started our code fast training for all the employees of the hospital. So for the doctors also, they are also started with this app.
Thank you. Any more questions, please? Thank you, team. Thank you. Can we have a round of applause, please? And next, we would like to invite Basa Vatakaram, Indo-American Cancer Hospital and Research Institute, with their presentation on Hospital on Wheels, Community Cancer Screening Program. Can we have them on screen, on stage, please? Can we have a round of applause for the Indo-American Cancer Hospital? Thank you.
Good afternoon. So that is the medical screening unit. It's a cancer screening unit. How it is, early technology is in two ways. One, it is the first in South India to happen in 2003. Yeah, so you can actually clap for that. For the last 23 years, that bus is on the move. It has covered more than 2 lakh kilometers across the South India. It has screened more than 2 lakh people. Yeah. Second is, now we have incorporated teleradiology into the bus so that whatever the mammography and digital X-ray images that are there through PACS, we're able to read it back in the hospital and give the AI generated reports as early as possible to the people. The TAT right now is around 7 to 8 minutes. So now I'll quickly take you through the slides. So the bus, these are the dimensions. So ultrasound and sonography, we just have the mobile unit. We take it along with the radiologist. We put it in the camp area wherever the doctors are sitting. There'll be a separate cabin for that. And staffing, we have a dedicated team of radiologists, physicians, X-ray technician, mammography technician, nurses, even housekeeping staffs come along with us to ensure infection control protocols. It has power backup, air conditioning, digital reporting systems, and on-site results, like I already said. So why this has become this thing? First is the geographical barriers. When in 2003, even till today, these tests are not very easily available in the rural setting or semi-urban setting, and they're quite expensive. So we do it at free of cost. So again, low capacity, all these things are the reason. And what we do, like I mentioned previously, we do the risk triaging, who should get the tests, so that the resource utilization is 100%. So these are the reasons why we are started. So we want to screen as many people as possible early for cancer. We ensure that these camps keep happening regularly, and the referral patients should not miss out. So we follow them up and other things. And every day we screen around 200 to 250 people. And time bound, yeah, by this year end, we want to screen 15,000 people in this year. And by next year, we want to reach out to 50,000. Like that, we have some time bound targets. And the methodology that we follow is basically reporting is something that is very unique to us. We do on-the-spot reporting for all the tests that we do, including other than pap smear. Pap smear needs pathogenic this thing that anyways is not part of the bus. The female physicians do it. So the bus itself acts as an awareness tool as well. It has the branding of awareness messages of the signs and risk factors of cancer. So it has a TV attached to the body, So while the bus is stationed in the parking doing the test, the TV will generate the informative messages for people in the native languages to understand what they have to learn about cancer. So these are the outcomes that we have achieved. This is only in the last 2 years, previous one. So innovation, yeah. So digital mammography, ultrasound, X-ray, pap smear, basically they are all hospital grade diagnostics taken to common man at the rural spot. Thank you. So much. Any question?
I have one question.
Yes, please.
The radiology hospital. What on the radiation safety and the ultrasound?
Yes, sir.
Requested to refrain from asking
It is a
questions.
very good question. I just
The T, Krishna, please.
Okay.
T, the jury asking the questions.
Yes.
We have a networking session. We are going strict on timings here. So the jury can, yeah, we already did. So jury can ask a couple of questions and then we move. It's an AI driven.
Yeah.
The accuracy of the report.
Cross check the report.
So
Every
the
report.
real-time first you cross check.
Sir, for X-ray, we are taking 3.5 to 4 minutes now. For our mammography, it is taking around 10 to 12 minutes for because the image takes loading in the rural setting. And for ultrasound, immediately the report is being able to, the typist is there along with the radiologist. One more thing, sir. While these tests are being done, mammography and X-ray, the bus is layered with lead. So it is also having a lead separator for the technician and the, so the protection of both patient as well as the person is taken care of. Yes, madam. So the radiologist is very much aware of it and it's a cancer specific program. The organizer, the rural healthcare officials are all well informed. So there will not be any pregnancy testing, there will not be any this thing, and it is put as licenses are taken. We have spoken to, madam. We have taken the DMHO permission for that.
For this machine, for traveling,
You have the license, sir. Yes. No, sir. There is like if you are making a mixture and match of tech services, and
in this country, ultrasonography on wheels is.
sir, we are not doing on wheels, sir. Station along with the doctor.
For every.
Yes. Oh.
Space, location specific licenses.
And for one machine, it is not possible. One machine in different.
Programs are also done in association with NHR.
Yes.
So there are certain specific acts when you do it with the government agencies, you'd be able to bypass those.
Yes.
We will discuss it over chat.
Yes, sir. Sir, basically, I would like to thank you for the. Yes, sir. Thank you, sir. So like sir said, it is in collaboration with the Government of India and Government of Telangana and Andhra Pradesh all together. Yes. Thank you so much.
Thank you, sir. So next up, we have one headache which we all have in the hospitals, the discharge problem. So here comes a team which says that they are able to show us a real-time discharge dashboard and have solved the million-dollar question. Over to you, Sujit Garu, from Rajagiri Healthcare and Education Trust.
Yeah. Can I start? Good afternoon, everyone. So like you said, this problem is not only for the hospitals, but also for we as a patients at times, if, God forbid, if we are there. So what we have done here is, what are the challenges? I mean, no need to say, but the challenges here of discharge is that no visibility of the discharge status. No one knows when the patient will be discharged. And let's be honest, this is a fact and all hospitals are struggling with this. Then unpredictable discharge times. Bottleneck due to last minute billing. The challenge could be because of doctor came late and then he informed the nurse, or the billing was not informed, or it was the insurance patient. So I send the details to insurance. The delayed bed turnover, I mean, this leads to loss of revenue as well. No accountability. Yes, post facto, you will get reports of where the discharge delay was, but then what do you do? I mean, But all of this leading to revenue loss, patient experience, and of course, net promoter score, depending on which side you want to see. So what we have to solve this is we have married three people together. And first is the people, of course, the process and the technology. And I'll talk about this and I'll show you certain images also. So for people, the challenge is all the departments are working in silos. The F&B is working in silo, the operating theater is working in silo, billing is working in silo, so on and so forth. So what we did was we created a common dashboard for everyone. You look at your status vis-a-vis for that patient. The departmental coordination became easier because the moment the nursing gave a clearance, automatically it shoots an alert to the pharmacy also that now you can act. The process wise that we made the clearance process with specific timelines. This discharge starts now 1 day prior with the clinicians planning the discharge. And with the focus of this, we made that visibility to the patients, their respective family also, because that puts the employees accountable in front of them, and they also get an alert through WhatsApp as to what the status is. And then technology, of course. Technology is just building a tool, and then the relevant people act as a watchdog. They can look at this mobile display anywhere. So this is the actual photograph. If you see on the nursing station, we have put this where the display comes. What is the display? This is the display which comes. So this talks about what are the ongoing discharges. Of ongoing discharges, what are the planned discharges, what are the unplanned discharges. And the color here in the lower left-hand side actually tells you where is it stuck. And you can define as a hospital, and these are the patient details. And where is it stuck in terms of discharge, somebody not created or not signed, nursing clearance, not given pharmacy clearance, T clearance, so on and so forth. And all of these are configurable. Now, you see a few greens and few reds. This also is configurable in terms of you decide for cash, what time that you want to give to housekeeping, or how much time you want to give to billing, how much time you want to give. And for credit separate and cash separate. Cash also you define what is your green limit, what is your yellow limit, and what is the red limit. All of this comes as an automatic alert, but it also sends an alert to respective department heads. You better start acting. You can't do next day morning meeting saying, okay, I forgot, I did not see. You get an alert on the phone and you can look at this display automatically. This it can be sorted based on the type also. ICUs will be looking at only their patients. The two nursing station would be looking at only those their own specific patient. Pharmacy, for example, looks at the entire thing. This is the actual photograph of a nurse section you see on top. I mean, this is the best way that we make the people accountable. They become part of the process. They start owning it. And purposefully, we have put this on a display so that the patient relatives, though they're alerted, I mean, there's certain accountability that I as an employee also know that someone will come and ask. If you don't have a tool which is not displayed, then no one is accountable because everything happens on paper. And if you come, I can tell you, we have integrated with the insurance platform also so that credit alerts comes automatically on the system as well. Again, this is about what it does. I've spoken about. We have actually, this is the benefit from last one, which we are doing everything online. Yes, of course, that is a tool. But what is most important is that patient satisfaction has increased because of this. And this is all we have done in last 4 months. I'm done. Thank you. Cost is, again, it depends on to what level you want to do, because there we have given display. Also, there's a cost of the TV that you'll have to give. But I mean, that's not mandatory. You can do it on the nursing workstation. It can also run there. So cost is to what level you want to scale. The alert to the patients also, that's a configuration, whether you want to give a real-time alert that now your pharmacy clearance is given. Insurance companies are doing it, that we have received your claim, now we have processed, this is the amount. We have done the same thing for discharge thing as well. If you don't want to do it, you switch it off, you don't incur any cost.
What's the technology is being used in here? Because the session is technology adoption.
Yeah, we have used Power BI as a tool which pulls out data from the HIS and collates and sends it. And plus, it's integrated with WhatsApp and SMS and all.
Yeah. Apart from technology, a small question. How you are addressing that payment delays of the patient side? So that are you considering that into your greens and all?
Yeah, yeah.
Probably we can discuss about.
Now, just there are two aspects. When I, as a hospital, am ready, there is a flag which we say bill is ready. And then if there's a delay, and once bill is ready, it automatically sends an alert to the patient that your bill is ready, you come for the payment. So we are
not that.
Yes, yeah, yeah. But then the alerts are sent to nurses also, so they tell that. And for the hospital that we have done, the actually payment settlement happens on the same floor that the patient is. So unlike few hospitals where the delay happens, so.
Thank you, sir. I think this will be a nice topic for the tea break when we have that.
Of course. Thank you.
Thank you, sir. Thank you for the presentation.
Thank you. Thank you.
Thank you. Can we have a round of applause for him, sir?
Thank you. So next up, we have Basavatarakam Indo-American Cancer Hospital and Research Institute. Once again for the presentation on transforming radiation oncology through Varian Halcyon with Hypersight.
Good afternoon, everyone. Thank you very much for CAPO to give us the opportunity. We just installed this machine, part of our 25-year celebration in comprehensive cancer care. I'm Dr. Dilip Kumar Gudipudi, Senior Consultant and HOD Radiation Oncology at Basavatarakam. So this is the evolution of radiation, which has started from 2D to 3D before the 2000, and then proceeding with the invention of MLC, what we call, where the IMRT has come into picture, from which the radiation oncology has transformed, where you can minimize side effects to the normal structures and precisely target the radiation. Then came the invention of putting a small CT scan onto the machine, which is called cone beam CT. So you can image before the radiation is delivered, precisely verify it before the treatment is delivered. Then came the era of doing an adaptive radiotherapy, where you can do a CT scan and then modify according to the responses what the patient is having, because we see that over the period of 4 weeks or 5 weeks of radiation, you see there's some changes in the tumor as well as the normal structure. So you verify it, correct it, and then do the radiation. To fasten the process of adaptive, then the AI integration has come into the picture. So we have installed this machine, which is very unique, very simplistic in design, looks like a CT scan, which has a dual MLC. I'll play a small video where you can see the MLC is stacked up. So the stacked MLC would minimize the radiation through the leak which is happening in between the leaves. So there's further reduction in the radiation which is going to happen. And then automated workflow, because this is where we have planned the radiation for this tumor in esophageal cancer. You can precisely see whether it is target, and then you can see on the screen at the end of each fraction whether it is precisely seen or not. And it's everyday process for all 23 days or 30 days or 40 days if you're giving radiation. The treatment time is much faster because the radiation machine rotates 6 RPM and then the CT scan rotates even 6 RPM. So the treatment time is much faster for these patients. So because of that faster rotation, your motion artifact is taken out of the picture. So you have a better quality CT scan, which is called Hypersight, where there's a leap in clarity. With a single breath hold, you can take a good CT scan and then which is equal to the diagnostic quality. And then you have an enhanced image contrast and anatomical visualization, which helps you in adaptive radiotherapy, which is very important. And then there is a correction which can happen with some of the head and neck patients who have tooth filling, will have a lot of artifact in the mouth area. And you can see in this where the reduction has happened, and you can see the CT scan on the extreme left where it is clearly seen. And this helps in the adaptive radiotherapy. So video please. It has a sub-millimeter axis and the real-time imaging, which takes 6 seconds for it to and 30 seconds for reconstruction. You see the CT scan on the console area. And then once the treatment started, you can clearly visualize whatever your plan is delivered. You can see the color coding on the extreme left of that. So for this, because it's being so fast in delivery as well as taking imaging and treatment, per patient it takes around 6 to 8 minutes, versus for the regular linear accelerator, which takes around 15 to 20 minutes. So because of this, more patients can be put through the treatment. So the throughput is faster, and it's very comfort for the patient, because some of the patients have claustrophobia with the mask and everything. So the patients also have greater confidence, along with the clinician who have the greater confidence. You can see the clarity of the image, how good it is on the console area. So since we have installed this machine in July 2025, the regular Indian accelerator takes around 3 to 4 months for the commissioning and everything. This is plug and play where you can start your treatments within 2 months or sometimes 45 days. So we have started the treatment within 45 days. We've treated close to 400 patients. When I sent this presentation, it was 350. So it is easily scalable. The only thing, the cost is on the higher side because the hyperset imaging is expensive from the company. But still, because of the enhanced image, you can do all these things. This is one of the real patient we have. You can see the artifact and then you can see the clear reduction which has. So because of this, when the planning initiatives and everything, you can increase and then put in adaptive radiotherapy. But as of now, they've come with an offline adaptive, the online adaptive, the machine is more expensive, the softwares are very expensive. So we are trying to work out in such a way that can we bring the offline to the online adaptive process. So it's smoother flow because you can see a simplistic console area. It is consistent quality assurance which the physicist plans. They want to see whatever his plan is delivered or not. Every day you can see that for the patient when it is delivered. Faster sessions happen because of the machine which is faster and suitable for adaptive radiotherapy because we have a very good quality of imaging. And then finally, the future of radiotherapy is precision with speed. The comfort is for the patient, confidence is for the clinician as well as for the patient. So to expand the adaptive protocols, we need a good imaging online. So last point is always when you look at any therapy or anything, we want both precision and accurate to happen. If that happens, that's when you feel that you have achieved really good goals. Thank you very much. So I'm very sorry I have to be so fast because I have to take you 20 years of radiotherapy in 5 minutes.
Any questions from the jury? Thank you, sir. Thank you, Basant.
Thank you.
So next up, we have from Kaveri Hospitals. They would be presenting on automated card and UPI verification system.
Good afternoon to all. I am Devi. Along with Mr. Uday Kumar, we are representing a Kaveri group of hospital. Today, we are excited to present our innovation, the automated card and UPI verification system, a digital solution that ensure faster, accurate, and error-free financial reconciliation. First of all, let me explain our problem we faced. Our finance staff has to manually check and match the hundreds lines of transaction every day. This includes card and UPI payment made by the patient during advance discharge, medicine purchase like scan, etc. In this payment, we had to check a various platforms such as HMS, Merchant Portal, finally SAP. HMS for our hospital management system, it is a base document. Merchant Portal to match the HMS for bank reconciliation. Finally, SAP to match the SAP for financial reconciliation. Merchant Portal like Hitachi for our card transaction, then finally PhonePe for our UPI transaction. Each hospital handled around 200 to 300 line item every day with 12 operational units. So our entire team has to verify thousands of line item every day. It took approximately 3 hours per day per unit per person. Because of this high volume of transaction has to manual checking, our staff has to work extra hours during auditing and financial closing, which caused stress, human error, time consuming, and delay in reconciliation. In coming slide, I will explain detail to RPA process. After implementing RPA process, which is robotic process automation, we can able to reduce our daily verification time within a minute and share our data automatically in real time. After implementing RPA, the result is remarkable. We can able to reduce our daily verification time 3 hours to just 30 minutes, which is improvement in 80% of accuracy, efficiency, and reliability. Coming to tech flow of RPA, automation trigger. Bot automatically retrieve the data from ARIES portal. The automation process start without any human intervention. The reconciliation, it took reconcile 200 to 300 line items daily with zero manual effect and zero errors. Consolidated report, bot generate a consolidated verification and reconciliation summary report in Excel within a minutes. Then team review the bot generated report for accuracy, complaints and record validation. Finally, the report is ready for a finance governance. Then coming to finance governance, the RPA is not only improve our daily work, but also made our financial system stronger. In better accuracy, where no missing or mismatched transaction, reduce your workload. Due to reduction of manual work, our staff has to focus on high-value financial reconciliation in faster financial closure, where month-end reports are done quicker, then clear and transparent process across all units. When reduction of manual work, our staff has to work us very happier. Then coming to impact with RPA, before automation, it took 3 hours. After automation, just 30 minutes. So totally in 7 unit monthly saving of 525 hours. It is a 65 days of saving our working hours. Then coming to expansion plan, since the 7 unit were successful, based on our report, CFO feedback, we can able to focus on 5 more additional hospital units. The outcome of this impact is consistent and uniform reconciliation process across all units, improve our efficiency, accuracy, then reduce the manual workload and turnaround time. This is the evidence. The card and UPI verification summary, how received our bot and shared our mail automatically. This report is not a standard report, it's a customized report based on our finance staff requirement. Thank you.
Thank you, ma'am, for the amazing presentation. Please, any questions from the jury?
Technology partner, this automation.
So we are used to UiPath. It's an RPA tool. RPA is a robotic process automation. We have developed a completely in-house from scratch itself. Sorry, ma'am. Limitations in the sense? No, as of now, we haven't find anything because it is developed, deployed in our own server itself. So as of now, we haven't seen those.
Okay,
Thank you.
Thank
you, Team Kaveri.
Thank you so much.
Can we have a round of applause for the presentation, please? Thank you.
So next up, we're going to have Control Emergency Alert System from Parul Sevashram Hospital, Vadodara. Parul Sevashram.
Can we have a round of applause for them, please? एक बार आप सब अपने लिए भी तालियां बजा लीजिए, सुबह से सुन रहे हैं.
No, clapping increases energy for us as well. And if you're not able to clap, tap the next person who's sleeping next to you.
Yes. Good afternoon, everyone. Myself, Pratik Ashok Kamble. I come from Vadodara, Parul Sevashram Hospital. The question is like this. The problem statement goes like Parul Sevashram Hospital is an 850-bedded hospital. Now, to be corrected, we are affiliated as 1100-bedded hospital yesterday. So we have a big number of beds and various people, both patients, staffs, and other people coming up to our facilities. Now it becomes a little bit hectic task for us to develop a control system in which a buzzer can directly go and it creates a haphazard or a chaos in people because because Parul Sevashram Hospital is located in such a spot where Rajasthan is very near, Madhya Pradesh is very near, coming towards Maharashtra is very near. So we have n number of locality coming towards us as we are trust-based hospital. So having a very chaotic environment can lead up to a mass casualty. That is understood. So later on, we studied that rather than having a traditional emergency system, why won't we use a cell phone as an emergency system? Because nowadays everyone is using cell phones. Even a peon has an Android phone. So it was very easy for us to understand that using a cell phone that we can create an emergency system. Later on, I'll explain you the scalability. I'll go with the product review first. Yes. So Terotem, we are dealing with Terotem from so long. Terotem is a basic management app in which we look after the assets. So the innovation here is Terotem itself was not aware that they could do such things as making a chat option. Chat options in which we can launch a alert, whether it be for a fire safety, child abduction, code blue, anything. So now you don't have to manually call, you can directly raise an alert, and that alert is scalable to a very larger population because so we have around 1700 staff. Every one of them is being availed with Terotem. So we have multiple entries on CUGs, personal phones, and the hospital phones as well. So everyone is alerted when an app is generated with a link for chats. So if you see that I have given a specifications for administrators, I can create a chat with summarizing the people which in case I want to let them know. The next one is, if in case I want to raise a fire alarm. So fire alarm, I don't want to notify to the second floor because it might create a haphazard. So what I do is I have created a fire group for every floor. So the developer has made it. So if in case a fire has erupted and second floor, the nursing in charge or the supervisor, the floor supervisor, floor coordinators, they come to know about it. Later, just with few clicks on Terotem app, they will start a notification and that will be just scalable to people who are from maintenance team, fire team, and other than that, nursing and the in charges on the floor. That will help people to evacuate on that floor itself. And secondly, the management team alongside with the maintenance team will be on the floor very quick. So the turnaround time for that is very scalable, very manageable. It is just around 2 to 3 minutes because there is no lag in such a process. Later on, coming to the fact that we have 5 different ways in which we have raised a chat option, whether it be code purple, yellow, pink, orange, or red. So if in case, if you are taking out a, if in case you are taking out a channel, then you can easily take out a channel, arranging it, and later on coming to a group member. Only super admins can deduct a chat and start a chat. So these are the panelists here over. So you can create a chat, you can turn around, you can schedule a turnaround time for that. You can just start with the volume notifications. We have 4 volume notifications. Every single step has been done in further process. Thank you. Yes.
Thank you. Jury, any questions, please?
Sorry? No, ma'am. What happens is, if in case we had a recent incident in Vadodara, there was a hospital who had announced a course and in which people were from different locality. So they were not able to understand because that was announced in Gujarati. So people from different locality were in a chaos. Alarm. Yes. Yes. For
Rest of the departments?
no, ma'am. Only the floor will be evacuated and sorry. Yes, only the floor will be evacuated and the team will be already there on the floor. Simultaneously, one alarm will be gone to the government for the fire station and they will also be responsive towards us. Depending on the scale, ma'am. So if in case there is a smaller scale fire, yes.
Sir, we have a question here. Ma'am, please.
Yes.
Is it NABH compliant? I mean, NABH allows this because
Yes, ma'am. Yes, ma'am. We have empaneled with them. We have talked it out with them. It is done with them. Yes.
Is
So we are in.
acceptable.
Yes, it is acceptable.
Acceptable. Actually, we are thinking about what what objective that you have discarded the announcement system and gone to this app? Because then everybody, whoever is working, they will have to on the app and always
No,
be
sir.
looking after the app.
No, sir.
In
that is-
practical
yes,
situation,
yes,
right?
that is where the change comes in.
Hmm.
You don't have to turn your phone on, or you don't have to be on networks. Your phone should not just be switched off. If in case it is switched off, you will not be receiving
But
any.
the person will have
notification.
to see the app, na?
No, no, they will have a
Otherwise-
buzzer. They will have a buzzer. We have 4 different buzzers for various acts. So if in case there is a buzzer for fire alarm, it has a different tone. So that person comes to know that there is a fire alarm. He just looks at the phone. There is a pop-up on his phone. That second floor, this way is the fire going on, and with the final pick of that. So if in case, if it is a very large scale fire, that person directly reaches on spot. If it is a small case fire, then he reaches with a smaller team. That is how we have planned it out. Yes.
Anyway.
Yes. Yes. If I can just go back.
Large scale statement with the emergency.
Yes. Yes. So this is the problem statement. So it is a 850 bedded hospital. So if in case there is a fire or natural disaster coming up, so it will be very in this critical moment. Yes. Yes, sir. Yes, that is a part that.
Create chaos, confusion, and fear. Voting system is only for that, because general people are not they will not know what is code red.
Yes, sir.
The hospital will know. So that is the objective, was that there will not be any chaos, confusion, and fear.
Yes, for that. Yes, for that only. Yes. So for that only, sir, only the maintenance team or the team which we select will get the notification. Rest all team will be there for, removing the patients out of the hospital.
Sure. So let's take the discussion ahead for the next part. Thank you.
Thank you so much.
Can we have a round of applause for Parul Shivaram Hospital? And now we have Medcare Orthopedic and Spine Hospital. Can we have a round of applause for them? And they are going to present One Touch. Jury members, Medcare Orthopedic and Spine Hospital.
Good evening, everyone. My name is Mini. I'm representing Medcare Orthopedic and Spinal Hospital. I'm the Chief Nursing Officer. So imagine when the patient presses the call bell and nobody is attending and waiting for 5 minutes, 10 minutes, and the frustration starts. When the nurse comes and she checks and she tells that this request belongs to some other stakeholder. So she's again diverting the request to some other stakeholder. Again, the waiting is starting. With that, we thought one touch to the right request to the right team. This my presentation all about One Touch, the technology adaptation. So why we chose this project? So when with our patients' feedback, we got the major feedback from the patients where the call bell delays and the time response. So when we deep dive into that, we understood like many number of non-clinical call bells were diverted to nurses, so which was affecting our nursing efficiency and the patient experience. So with that, Medcare Orthopedic and Spinal Hospital, we developed a digital solution, data-driven digital solution to enhance the operational efficiency, communication, and the patient experience. Next slide, please. Okay, so our goal was to implement One Touch digital solution to streamline the non-clinical compliance to improve the clinical efficiency. So where we are, we reduced our nursing-related call bell delays. Initially, it was from 34, and which we reduced to, our target was to reduce to fewer than 10. And to improve the response time, which was earlier 12 minutes closed, our target was to reduce 5 minutes, which we achieved as well. And one of our other goal was to reduce our nurses' time spent on the non-clinical activities from 20% to 25% to 20%. So with this, we focused also on operational efficiency, empower the clinical teams and the staff's morale, and enhancing patient and staff experience. So we started this project and we implemented within 6 months. And our methodology we focused was, we did the time motion study with each request, and we had also kept extended benchmarking with other players and with the focus PDCA cycle. The outcome which we got it from this project is reduction of patient complaints related to call bell delays and faster response time also. And with this we have enhanced our patient experience and the patient safety as well, and strengthened the patient the nursing morale and burnout. And this helped us to reduce the clinical interruptions from the non-clinical activities. So, which also helped us to improve the organizational impact by enhancing our operational efficiency and overall and uplifting our overall brand value, and as well as the inpatient nursing patient NPS, net promoting system, and as well as which helped us to continue our brand value of we will treat you well. And this helped us to enhance this accountability with other stakeholders like housekeeping and non-clinical members. Scalability, we initially started with Medcare Orthopedic Hospital only. We have another 5 hospitals, so which we started with all other hospitals, and the reliability was because of this reliability, we started with a few non-clinical activities, housekeeping and laundry kitchen, which we enhanced with other stakeholders. So the same platform, we will be also looking forward to do the discharge automation process. There was a collaboration with multidisciplinary teams. Without that, we didn't have achieved this. So multidisciplinary collaboration was there, and this innovation helped us to bring a lot of hospitals organizational process, which we integrated to the AI, and helped us to enhance the transparency across departments and with the patients, and which helped us to increase the staff morale and reduce the burnout. And initially we started with English and Arabic, and then initially we started with actually tablets, and which because of the patient feedback, we started with the QR code for the patients and staff convenience, which helped us to increase the patients follow-up a lot. And this was the sustainability of the patient and nurse feedback helped us to continue this. And the future way forward plan is to bilingual instructions on the QR code standee. Now it is English. We will enhance that to Arabic as well. Thank you.
Thank you for.
Initially, we had a challenge to drive this because we had to give awareness to the staff nurses, like they have to orient the patients as soon as the patient touch points. We have to orient the patient. So initially, to give that, we had a challenge. Then we have incorporated in our training program. So as soon as the nurse go to their general nursing orientation, we incorporated with that.
Thank you, ma'am. Thank you, Judy, for the questions. Thank you. We'll come to the next presentation. Can we have a round of applause for One Touch? Saving patients. Next, we have Dr. Jivraj Mehta Hospital. Can we have them on stage? They will be presenting an integrated HR solution comprising of all the modules from hire to retire. Can we have a round of applause for the team, please?
Namaste and a very good afternoon to everyone, respected jury members, all the healthcare professionals present over here. Myself Sulagna, representing HR from Dr. Jivraj Mehta Hospital. Dr. Jivraj Mehta Hospital is a trust hospital established since 1989. Started with a single OPD having 23 employees only. Now it has been reached to 205-bedded multi-speciality hospital having a strength of 750 employees. We have been accredited by NABH, whole hospital, NABL, NABH ER, Nursing Excellence, Research, Blood Bank. Last but not the least, NABH Digital with the Platinum. So as the organization grows, any functions cannot work in silos. The same applies to HR too. So the manual processes was resulting to delay in deliverables. Ultimately, it was resulting to the dissatisfaction of the HR team members as well as employees as a whole. Understanding this situation, we thought of implementing a thorough HRIS platform where we can engage all the modules of HR starting from hire to retire. Before going into the execution phase, we can understand the objective where it was very clear and specific of implementing one single platform of HRIS where we can manage from hire to retire, having a measurable and achievable target. And considering the challenges we faced, we found it to be the best suitable solution, best relevant that fit to, and with a defined timeline within which we tried to put it in place. In terms of execution, we planned for a phase-wise execution, aiming for the highest user adoption. Initially, we explored many HRIS platforms where we found Adrenaline Max to be the best suit that for our organization. In the second phase, along with the HR team, IT team, and our delivery partners worked together, and we put all the organizational policies and protocols in the application. Third one, the most important phase, that is the testing and training, where thorough training, collaboration with all the team members, two-way communication, feedback mechanism we implemented, and we moved to the second phase, the last phase, that is the deployment one, and we went live. And the optimization is still going on. After implementation, when we put the results into figures, the figures are somehow like this. The 75% error reductions with faster payroll processing. Like for an example, previously we used to disburse salary by 10th of every month. Now it has been reduced to 2nd or 3rd. The same with average training man hours, which has been increased by 34%. We have saved time by 33% by reducing 1 month manpower from HR department itself. The overall satisfaction of employees has been increased from 78% to 88%. The last but not the least, that is the 100% digital HR, which really helped us to contribute in a Go Green Planet initiative. Adrenaline as a platform, the HRIS one, its cost effectiveness, its compatibility, the customization, and modular, that is the web-based application, and the employee experience. Like every employee can get their basic details, whether it is a pay slip or a leave balance update from a single touch only from their mobile application. They need not to knock the HR door every now and then for the basic things. Ultimately, it is an integrated solution where from an application till the experience later, everything is managed from one platform only. To achieve such success, there is a strong team behind it, without which it would not have been possible. The first one is our executive sponsor, that is the respected board of trustees. After going through the project where we got a very welcoming approach from them, it really motivated us to implement so. And after that, along with the HR leads, IT leads, and the delivering partner, we make the product perfectly okay as per the requirement of the organization. Lastly, that is the cross-functional collaboration. Everywhere, whenever there is a small change in HR, it touches every person of the hospital, whether it is a HKPCA or a clinicians. So that collaborative approach we received from all the functions of the hospital, where we could easily achieve it, and we could put it in place in a timely manner. So we always believe like the employees are the asset of the organization, and when it gets merged with technology, we get the best result. So our going forward next objective is to implementation of AI into this technology. So whether it is a screening of a CV from the data bank or for a reimbursement of any fuel during payroll, AI will help us in put it correctly and quickly. So the future of HR is all about AI, automation, and continuous improvement. Thank you.
Thank you, Team Jeevraj Mehta. Any questions from the jury?
In terms of yes, PMS.
Is there, and how will you evaluate that?
It's a KRA based basically. we put all the KRAs of the new joinees based on our joining cutoff date. And once the KRA PMS is initiated, so employees along with the reporting manager, functional manager will get a mail notification. Employee will do the self-assessment. The same form will go to the reporting manager. Then again, same will go to the functional manager. After the sign up from the functional manager, it will come to HR.
It's the Adrenal platform, right?
Adrenaline Max.
Yeah, thanks team.
Thank you so much.
So next up, we're going to have Ruben Memorial Hospital. So Ruben Memorial Hospital would be presenting on patient care assistant and lead conversion AI agent. So teams can talk about their technology partner, and if they're around, they can come.
Okay.
We had the co-presenter also come in.
I think my technology partner is not around.
Okay.
So I can-
Yeah, carry on. I met him before, so I just thought it.
No, he was here.
Yeah.
I think
Fair
he
enough.
has
You can start, sir.
disappeared. Honorable jury member, respected audience, greetings from the land that gave world its first hospital concept and hospital 2,300 years back. I'm talking about Ruben Memorial Hospital, Bihar. So why do we need a digital front door? What is the issue here? Any door always shut out people on the other side when people keep knocking. In hospital, patient knock, your door is closed, you never get to know them. So as a result, we lose out on 98% of the patient who are knocking us through the website. People who are trying to call us with a wait time of 30 minutes, the door is not opening, they also drop off. There are people who knows the door, who have managed to get into one, but do not know the further doors and all. They also lose out. So as a result, per year, we have calculated a revenue loss of around 2 crores. This is a problem most of you would be facing, and especially in tier 2 and tier 3 cities. So we have missed patient, we have missed revenue, we have missed experience. For a old hospital like Ruben, 30 years old hospital, this is also a brand erosion. But it's not just the hospital that loses out. It's the patient also who loses out because it is deprived of the good doctors that are around. They are not, they are bereft of those treatment or the doctors. So we came up with a solution with our technology partner to use something which all of you are using. That's a WhatsApp in a mobile, which we combined to give a solution. So I'll come to that slide later. So what impact it did was there was a conversion rate of 15% increase. And this data is old when I had prepared the slide. Now it is 20%. So from every 15 patients who got converted or who are waiting for their appointment after our AI, at least 14 of them are taking the appointment. So that's a 90% conversion. So AI managed to handle around 4,000 messages. This was old one. Now they're handling 10,000 messages. The conversion has increased far more. After 8 p.m. and before 8 a.m., while the rest of the world sleep and we have only 1 or 2 people to respond to the phone. So we have only, it was 0%, now it is 20% of patients getting converted at night. And people using the local languages, there are so many dialects. Because this AI tool takes care of that dialects, 12% conversion takes place because of that. 80 hours of hour per month is saved, and there is a reduction in the call drop by 320 more people or patients got connected to us because of this. So the scalability within my own hospital is that wanted to take it to 2,500 qualified leads. That has going to change further because now I'm going to give the target more. So there will be more than 2 lakh messages with 10,000 patients we will be interacting with. I have already reached the target of 10,000 patients in a 1.5 months time. Right. So this can be scaled across, plug and play, scalable model, and it's a safe for the infrastructure. 5x we can kind of improve. 50,000 patient can be reached. So it is also helpful 24/7. This is there for us to open the gate for the patients. You all can actually use this particular WhatsApp number, or you can log into our website and see for yourself, book it in any languages you would like to ask. Whatever you want to ask, it will help you out, give you a particular solution, whom to go to, what to do, and that's how it has helped us. Sorry. So, any questions?
Talia first for the great presentation. And over to the jury for questions.
Now it is 2.5 months. So when I prepared that, the data was for 30 to 40 days.
The patient care is all about touch based.
Yes.
What is the risk benefit ratio of your this initiation?
It is touch based, yes. Human being brings in a better factor, but human being also brings the biasness. So you cannot expect all the call center person or all the front office to know at par with what the doctors know and all. So when the patient calls, patient expect each of the front office to be like me, who knows everything of or most of the thing about the healthcare. So if I'm having a tingling sensation, they expect मैं कौन से doctor के पास जाऊँ, क्यों जाऊँ. So most of the call centers or most of the front office, as you know, they do not know. Many of them do not know. Even if you give them training, there is a churning there. So this is where it helps the patients is guided. Okay, you need to go to Dr. X or Dr. Y and also give you. They come up with second, third, fourth question, which they cannot ask to a human being. So that's how I said that if we are now having 4,000 messages, that increased to 10,000, the conversion increased because per patient, around 40-45 messages are exchanging with the AI and them. So they are kind of now getting more interactive. This is going to go further up. They will feel more at home that, okay, this is the right choice.
Please to have some satisfactory measurement of satisfaction level of those patients too.
I have started, we do have, but not specific for this patient. But there is something my MS has been doing that. So people who are coming at night, there is one slide that I missed out. There were 3 patients, I had put them because that were a thing. An old gentleman who could speak Bhojpuri very fluently, and who is he's 65, 70 years old. So he could handle the website, the WhatsApp, ask in Bhojpuri, in that dialect, and they guided him, and that gentleman was able to come here. Number 2 was another gentleman who had a neuro problem at night, 10 o'clock, 10:30. That gentleman also was guided, and the next day he booked the booking. There is a third one which came through the website, and he was guided for a physiotherapy and all. So there are many more. So it is still, you can say, the patient satisfaction, we are still measuring it.
The cost application?
It's costing us, or if you look at
I don't think we should be answering that. We're on a pilot phase. So we've got a discount at the moment because we're running a pilot. We still haven't negotiated the pilot. I don't think we're in a
What are some of the limitations that you are facing?
Some of the limitation is patients are yet to understand. There is a gap between your asking it. Okay, by the way, this particular tool also can pick up what you are speaking and they try to tell. When some of these patients are doing that, some of the slangs and all, the AI is not catching them up properly. But when they type and all, it's okay. And when they say that, no, I do not understand, you tell me in Telugu, tell me in Bengali, tell me in Uriya, it's able to do that. But then again, if you are using slang, sometimes there is still a niche in that.
Thank you, Ruben Memorial Hospital and Tulu Health for that. Next, we'll be having Royal Care Super Specialty Hospital. They'll be coming and presenting on magnetic resonance guided focused ultrasound in a different field that I know of.
Greetings from Royal Care Super Specialty Hospital, Coimbatore. I'm Dr. Munawar, the President Medical Affairs. And I have with me Mr. Kundaraj, Vice President, MRGFS, and Dr. Sindel, Consultant Radiologist and a vital member of the MRGFS team. We are the first hospital to bring in MRGFS technology for the treatment of Parkinson's and essential tremor in India, Southeast Asia, Middle East, and MENA region. Without much thing, I would now like to hand over to Dr. Sendil to just.
Good evening, everyone. Thank you, Manoj sir, and thank you, Team CAHO, for the invitation. And can you have the first line? Magnetic resonance guided focused ultrasound is a non-invasive treatment option for patients with essential tremors or Parkinson's disease who haven't responded to medications and who are not willing to have an invasive surgery. The procedure uses focused beams of ultrasonic energy guided by MRI to target deep areas in the brain with no anesthesia, no radiation, no incisions or permanent implants. And this chairman, Dr. K. Madheshwaran, a practicing neurosurgeon who conceived and decided that we have to bring the system to India when he visited Japan in 2020. And the FDA approval for treating advanced Parkinson's disease happened in 2021. And we had our first system in the Indian subcontinent in 2022, and we started treating patients. And this is our team with the neurologists and the neurosurgeons. It's a single session, incisionless transcranial ablation in the region of interest, delivering ultrasound waves across select points under real-time thermal monitoring. The targets in the thalamus includes ventralis intermedius nucleus for tremors, and the other target is pallidothalamic tract for treating bradykinesia, rigidity, and dystonia. We use a research-capable 3 Tesla Signa Architect 120-channel system along with the Insightec Exablate Neuro. That's our technology partner, who is an Israeli-based company who was the discoverers for the Insightec system, which we earlier used for HIFU fibroids, treating fibroids. The patient is always awake during the entire procedure, and it takes between 2.5 hours to 3 hours. The initial temporary sonications are done as test sonication to evaluate on-table clinical outcome, and followed by sonications with a mean temperature of 52 degrees to 54 degrees, which produces a permanent lesion. And this is the treatment process. The patient is prepared, the planning is done, target verification is done, and treatment and the final assessment happens. On the system, you can see the 3 Tesla MR gantry with the Insightec system, which the helmet-shaped transducer is mounted on the table with 1024 phased array piezoelectric elements, which operates at a frequency of 650 kilohertz, and the advanced focusing algorithms target the beams to target precisely to form a 2 to 5 mm focal points. And baseline CT and an MR is taken for calculating skull density ratio and the target points in the MR. And this is how the patient head is shaven first at the day of procedure, and the stereotactic frame is fixed over the head using 4 screws, 2 in the front and 2 in the back, with the help of a local anesthesia. And this is how the patient is positioned in the MR gantry site. And skull plays an important barrier for ultrasound traversing the brain. And we did a study of 200 patients. The Indian mean skull density ratio is 0.56, where the normal range is between 0.4 to 0.7. Anything beyond 0.5 is a very favorable outcome for the procedure. And this is one patient, 48-year-old from Dubai, and who had a tremor-dominant Parkinson's disease. He was suffering for 8 years. He couldn't do. And you can see the severe drug-induced dyskinesias Can you play the second video, please? And you can see the tremors in the hand as well as the jaw tremors. Can you play the third one video? And immediately after the post procedure that night, he had a chapati in the room. And then the fourth image. Yeah, he started jogging and the very next day. And this is the photograph taken during our first patient immediately after it on 8/8/2022. He couldn't do his day-to-day activities. He was under the help of one helper throughout his last 10 years. And he immediately started writing, and you can read it on that. And these are the post-procedure and in-procedure outcome you can see. And in conclusion, so far we have completed around 200 plus treatments at Royal Care. 20% were essential tremor patients and 80% were Parkinson's. And we have a follow-up of 3 to 36 months. There are no major complications. Few minor complications like transient ataxia, dysarthria, weakness and somnolence and headache are very transient, and it resolves by 2 weeks to 2 months. The take-home message, it's a very effective and safe procedure. And future of MRGFUS doesn't lie with motion disorders alone. It is now approved for obsessive compulsive disorder, and there is trials going on for the blood-brain barrier breakage for treating tumors and everything. And this is the selfie which we have taken before the first thing, and that's with the team where we have done 200 cases. Thank you so much for the patient listening.
So far, how many patients have been treated?
207 patients precisely.
Thank you.
From 2022, later part of 2022 till 2080. We have a team of doctors, the neurologists, the neurosurgeon, the anesthetist, the technology, radio, MRI technician, the nurses, and of course, the radiologists.
15 lakhs for per
So
side.
how, means comparing with the DBS, what is the better outcome of this one?
Sir, it's a real time first, non-invasive procedure, one at a time. And it's a very effective procedure. For in DBS, you have to put an electrode and you have to keep tuning it. And every time the patient has to visit it. And this is real time.
Now there is a scope of remotely sensing the DBS also.
But
So
it-
the cost implication is in both the cases are same, more or less.
More or less the same, but worldwide DBS things are coming down, and this has taken over the world by storm. And it's almost 25,000 cases has been done using an Insightec Exablate neurosystem.
Last year data, world over, number of DBS performed was around 1,750 for the year. Whereas during the same period, number of MRGFUS performed exceeded 6,700. So there is a huge difference. Acceptance for the technology, we have crossed that stage. We have also crossed the stage where the product was purely innovative, research-based. Now it is a clinically proven more than 10 years for essential tremor, more than 5 years for Parkinson, complete Parkinson.
Have you done any here? Have you done any quality of living assessments for patients after this procedure?
Yeah, there is a unified scoring system is there before the procedure and after the procedure. You can see the drastic difference in between.
Last
Patient.
week, the first patient was put.
Almost 3 years.
They've been assessed.
And
They've been assessed and there are.
what is the reoccurrence of the thing it may be?
10% chances of reoccurrence is there, but out of 200, we had only 2 to 3 patients.
As of now, 2 to 3
Two-
patients.
Again, calibration has to be done.
We did twice. Not the calibration, we did the procedure again, redo procedure
Redid
again,
it.
and they're completely well off now. Insurance is covered, and we have done 3 to 4 patients with complete insurance.
Unfortunately,
Well,
in India, the system of insurance purely works on the basis of sum assured. So therefore, the extent of insurance that the patient receives is related and subjective to what he has.
Not everyone has a coverage of 25 lakhs or something. That was.
Yes, you placed.
That's
comes into play.
it's all. It took for us almost 45 crores.
Because it includes basically a combination of 2 devices. One, of course, you need an MRI. On the other side, the MRGFUS.
3 Tesla MRI,
And
very important.
Preferably a 3 Tesla, though you can do with 1.5 as well. 3 Tesla is definitely desired.
And we have installed the second machine in Delhi also.
Sir, Gangaram Hospital, we have our second machine as a pure process.
Successfully. They have almost completed 10 procedures as of now. Our mission, we are in collaboration with Gangaram, we have put our second mission in Gangaram.
Sir, I think you will have a lot of questions from
Yeah.
the audience also. They're waiting for you to get off the stage and,
Anyway.
grab you by your arms. Ki, sir, tell us.
Pleasure to help out everyone.
Because epilepsy and these syndromes, they require a lot of, and the non-invasive solution that you have prepared is something that is miraculous.
For epilepsy also, it's coming up. All the trials are going on for small tumors.
So, right, sir. Great.
But OCD and some of the other disorders are already
Approved.
Sir,
And
I
we
would
have
just
done
like to
India's first obsessive compulsive disorder patient.
Sir, are there any documented
OCD
side
patient.
effects or any complications that we have seen?
It's all transient dysarthrias and weaknesses are there. And it gets resolved by 2 weeks
Okay.
to 2 months at the max.
Okay, amazing.
No major complications.
If OCD you're talking next, you should be also having something for de-addiction.
De-addiction.
So, there is a plethora of things you can do. Thank you, Royal Care, and my good friends from Insight Tech. Very proud of you because I was an early user of in 2012 as well of Insight Tech technology, MRG FUS. Thank you very much, Royal
Thank you.
Care and Insight Tech. Thank you.
The next participant is from CMC Vellore, would be presenting on asset tracking system.
CMC Vellore, Rani Pet Campus.
Can we have a round of applause, please?
Very good evening, all of you. Today, I'm here to present the asset tracking system, what we have introduced in our Ranipet campus. And this has changed the way we are managing our wheelchairs and stretchers in our hospital. So before implementation of asset tracking system, managing resources was very difficult. Our hospital is a quaternary care center spread across 17 lakh square feet. And every single day, over 10% of our patients coming to hospital, visiting the outpatient department or coming in for dialysis or for chemotherapy will be requiring wheelchairs and stretchers for safe movement. That's more than 700 patients using this wheelchairs and stretchers every day. We have more than 400 wheelchairs in the OPD area and 300 plus wheelchair stretchers and over tops and bottoms in the inpatient area. And tracking them was entirely manual till March 2024. Inventory checks at the end of the day were really time consuming for us, and our staff spent significant amount of time to trace all these wheelchairs and stretchers at the end of the day. So the challenges were very clear for us. There was no real-time updates, no automated system, and on top of that, we lost 2 wheelchairs. The patient had taken it. So it became very obvious for us to identify a smarter technology-driven solution to overcome this issue. In March 2024, we launched this asset tracking system. It's a smart solution that combines Bluetooth low energy technology with our hospital's existing Wi-Fi network, developed in collaboration with the hospital information team. Now each wheelchair and stretcher carries a BLE tag, transmitting its location every few seconds through Wi-Fi. These tags are lightweight, energy efficient, and require minimal maintenance. The system leverages our existing Wi-Fi infrastructure, so there is no need for new cabling, no extra hardware is required. Today, our supervisors can monitor every asset in real time from the desktop or mobile phone from anywhere. Now let's talk about the results. We are able to achieve 100% inventory every day right now. The technology supports us very well that when an asset reaches the storage area, the system clusters all inventory in the storage and highlights any items that are missing. This allows the porter to go directly to the right location and fetch the wheelchair efficiently. There has been zero asset loss after implementation. There were 3 attempts to take away the wheelchairs by the patient, which were prevented with instant alerts, saving us 33,000 rupees. This implementation has also saved 3 manpower with the asset tracking system in the inpatient area, we were able to centralize all the assets and identify the idle inventory which were not utilized to good effect worth 15 lakhs, which is now ready to be used in the other campuses. On the whole, over a period of 18 months with an investment of 7 lakhs, we were able to save 28 lakhs. So the success of our asset tracking system lies in its simplicity. As you can see, there are three interfaces. One is for the supervisor, one is for the security, and the other is for the porter. Through custom alerts and geofencing, the system proactively safeguards our resources. On the security portal, all asset movements are continuously monitored. If an item leaves its predefined boundary, an instant alarm is triggered and real-time notifications are sent to the supervisors. So behind every successful innovation stands a great team. This project is a collaborative effort between two key departments. The general services, which takes care of the operational management where we had the issue, and the hospital information system came in picture, which took care of the system integration, BLE tagging, and the required technical support. Together, we brought the best of operations and technology to the table, proving that when teams unite, innovation becomes unstoppable. So encouraged by its success, we have extended the platform beyond asset tracking. It also now monitors food delivery time to our patients who are on hospital diet and the laundry delivery times as well in the ward areas. We are also preparing to roll it out to the CSSD and soon for the biomedical equipment tracking as well. What started as a department level idea has become a hospital-wide innovation right now. To conclude, this implementation of asset tracking system has eliminated losses, optimized manpower, achieved 100% accuracy, and saved over 28 lakhs rupees in 18 months. At CMC Vellore, we believe innovation doesn't always mean something big. Sometimes small, smart steps make the biggest impact. Thank you very much. Yes.
Any other questions? Jury members? If no question, we'll go to the next.
Yeah, thank you, CMC Vellore Ranipet campus team. So next is going to be AI-based nursing care plan. We'll be having the team from Rajagiri Healthcare and Education Trust to present on this.
I promise you're seeing me for the last time today. But
More.
But at the same time, I'll also tell you that this is one innovation I'm really very passionate about because it's niche. So I'm going to talk about AI-based nursing care plan. The challenges, and I'm sure this is again a common problem for everyone. The challenges is in the nursing care plan is time consuming and manual documentation. Inconsistent care plan across the nurses. So what I call you tell me the person, I'll tell you the care plan. Because it depends on the kind of nurse who's documenting the plan. It's not updated regularly because the hospital, everything is documented in the system with a timestamp, and when the audit happens with JCI and NABH, first thing that they see is time. And when there's a closed file audit, they looked at the timestamp of all the documentation. So this becomes very important. I mean, again, this is one of the challenges everyone faces, the difficulty training new and junior nurses. And if the documentation is not right, it opens up medical legal cases. All of this leading to incomplete documentation, risk of loss of repute, and of course, the nursing fatigue. What is the solution? The solution is this: people, process, technology. People is it. I mean, again, reduces nursing workload and burnout, improves clinical confidence and capability. Process-wise, let's standardize the care plan because now it doesn't depend on a person because the system is generating. And
it enhances safety and compliance. The technology bit is perhaps the most important in this, because now once you're looking at the care plan, the system automatically looks at the complete EMR of the patient, whether lab results, whether the previous assessments, the initial assessment, the vitals, the previous diagnosis on a previous episode, allergies, everything, and then it creates the care plan, and then it enables predictive insights and decision support. And I'll try to show you a real video of this if this works. How do I run the video for this, please? Yeah, it has to be. I can't even go back. It only takes me front, maybe. No, it doesn't. I've stopped, yeah. I hope this would be timeout, right? Not part of those 5 minutes. No, I'm just kidding. So the initial assessment, the problems I identified, the goals, the intervention, the implementation, the outcome, all of that, this system will generate. Can you please play the video, please? No. Video, it's the video. If you take the mouse there, you'd be able to run it. Slideshow हटा के चला दीजिए, please. The previous one. Yeah, please take the mouse there. Take the mouse on the video. This slide, you can see. Slide number 4. Go here and on the video. This is the video. Yeah, please. Yeah. So this is what I wanted to show you guys. So if you see here, again, this is, I know this one of the questions that would be asked, that AI generated, how do you ensure that it is accurate? What happens if it gives something? So again, it's only generating. If you see they're saying it is, you can edit someone who's creating, but someone would go and verify this as well. So there are 2 levels of it. It's not that system is creating and it's saving. It's just, if you want, you can go from the drop down and edit those as well. So all of those can be edited, and then that is first level of check. Second level check, it has to be verified as well. There's also an option to mark an error in case something is drastically wrong. You can still mark that as an error. Yeah, can you run it on? Yeah, please. So this is what it does. It does an auto generation of the nursing care plan, whether nursing assessment, problem identified, goals. One of the challenge that we have is, what if you forget? Because we're using AI, it also alerts the respective nurse of saying that this was done on X time, that's the outcome was supposed to be measured in this time. You please go for reassessment for this. So this is how it looks like. I mean, yeah, these are the challenges that we circumvent by using this. Post using, and again, we started doing it as a pilot in a couple of workstations. Now we have done it across the hospital, and we have automated all of these advantages. Of course, accelerates care planning, enhance accuracy, drive standardization. This is perhaps one of the most important aspect. Now, and MRDA said this is not what I'm saying. MRDA said this post implementation, this quality of documentation has come. It has actually significantly increased, and there's a consistency in how it has been documented. And of course, it reduces the nursing burden. Earlier, it used to take around 20 minutes to do that documentation. Now it takes less than 2 minutes. And the last slide, most important one, the outcomes, of course. Sorry. Yeah, it's okay. That's it. Thank you.
Thank you, sir. Jury questions, please.
Yeah, this is the AI based that we can understand, but the things that already is typed there, this is coming through some clinical inputs by the nurses, or how it is coming. Okay. Or there is some stock already there that is coming there. That can be editable, that I can understand.
Okay. Yeah. So once, I mean,
the clinical input.
Yeah, I'm coming to that. So clinical nursing care plan is just one of the document that nursing does. But the entire clinical documentation of nursing, whether it's vitals, whether it's lab, whether it is clinical documentation, diagnosis, allergies, pre-operative note, post-operative note, everything is actually put by the respective stakeholders in the system. Based on, and also the patient EMR, based on that system automatically generates the care plan based on that. If the nursing has maybe post-surgical care, the operative note says that there are chances of infection, or this thing system will automatically generate a care plan for the nurses that you have to. It's a 60-plus-year-old diabetic patient, and you have to measure this as well.
Thank you. Any other question, please? Thank you.
Thank
Thank
you.
you, sir, for the amazing presentation. We hope to see you more, sir. No problem. We'll bring him to the next presentation. We'll welcome JK Hospital with Ward IQ, Inpatient Quality Intelligence System. Can we have a round of applause, please?
Good evening, respected jury members and dear colleagues. I am Dr. Nitin John Thomas, Medical Director at JK Hospital, Kerala. First of all, thank you for this opportunity to present Ward IQ, the Inpatient Quality Intelligence System. As we all know, inpatient care is resource heavy and risk prone. It is where our patients spend the longest part of their care journey, and even small process gaps can increase cost and risk for both the patient and for the hospital. Over the years, with robust quality standards, we were able to close most of these gaps quite effectively. But as clinicians, we wish for something more, a real-time intelligence layer to see how efficiently our patients are progressing through their care journey day by day. Most often, we get these insights only during audits and review meetings, which makes it difficult to act on efficiency gaps in time. So as an attempt to curb this gap and build a live actionable system, we tried to find out a single unifying metric that could reflect overall efficiency. And we found that the average length of stay could be such an umbrella metric because it brings together the effect of multiple quality processes in the background. But average length of stay is still a raw metric, we know. So we refined it with two concepts, the diagnosis related groups and machine learning. Diagnosis related groups is a concept practiced internationally where each diagnosis has an expected or benchmark average length of stay. When we combine this with concepts of machine learning, the system learns real patient patterns, adapts continuously, and predicts expected average length of stay better for Indian conditions. And as we track this ML-driven model in real time, we found that many other quality processes like infection control, discharge readiness, etc. all began aligning naturally around it. This was our attempt to close the real-time intelligence gap in quality, and that's how Ward IQ was born. We designed Ward IQ around 6 core modules that define inpatient quality. The ML-based ALOS, as we discussed, is the core module. Other modules, the discharge planner, hospital acquired infection checklist, high-risk tracker, SOP hub, feedback detector, all support this central metric in the form of checklist and brief entries. We can add or edit checklists as needed, as you can see in the second image. In the first image, for each patient, you can see there are 2 sliders. The first slider is the ALOS monitor. They are color coded. Below 95% it is green. From 95 to 105% it turns to yellow, and more than 105 it changes to red. The second slider shows the checklist completion. So when the ALOS keeps increasing and the checklist is stagnant, it clearly indicates a process gap and we can act on it. Ward IQ was implemented at JK Hospital. It's a 30-bedded hospital. The ML component runs on AWS Amazon Web Services at an instance called SageMaker. The front end is built on Vue. We use the advanced XGBoost decision tree model for higher accuracy. Currently, the model uses 21 parameters like age, gender, comorbidities, etc. The retraining of model is done once per month. Data is fed on it via JSON, via a lightweight Python API service. It's all designed keeping the entire architecture scalable and modular. This is a single unified daily performance dashboard which can be seen by doctors, nurses, quality team, operational managers, etc., which shows the ALOS trends, hospital record infection compliance, discharge readiness, utilization bands, and open alerts all in real time. The entire inpatient flow becomes visible at a glance here. It turns hidden delays like infections, pending reviews, etc., into early signals that can be acted upon immediately. This scatter plot shows our ALOS efficiency trend over the last few months. The dotted line at the center is the ideal benchmark at an efficiency score of 100. In the initial months, the points are widely scattered, but as the system settled, you can see a clear clustering around the ideal line. This means the teams were making more consistent and timely decisions. There are definitely outliers, as you can see, and there should be outliers because we should never restrict clinical care based on mathematical models. And the clinical decision always stays with the doctor. Alongside this, we saw encouraging results like positive feedback from patients, better insurance claims due to discharge delays are reduced. And in short, WARD IQ created clarity, consistency, and measurable improvements across the ward. WARD IQ is built from the ground up to be sustainable, scalable, and fully aligned with modern ESG expectations. It works for any hospital size, and hospitals can add their own KPIs checklist according to their needs. The running cost also is extremely low at less than 10 rupees per patient. And our long-term vision is to make the core platform open source so that even small hospitals can adopt it without much overhead, and we shall build it together and improve the model for everyone for the ultimate betterment and spread of healthcare quality. Thank you.
Thank you, Dr. Nitin. That was an amazing presentation. Can we have some questions from the jury, please? Anything? All right. Thank you, sir. Thank you for your presentation. Can we have a round of applause? Thank you. Now I would like to invite Holy Family Hospital and Medical Research Center with a presentation on VIP early, visual infusion phlebitis, early assessment, reporting, and line inspection Excel tool. Ma'am, your time starts now.
Starts now? Yeah. So namaskar to everyone, and thank you, Kaho Tech, for having this wonderful opportunity for us all, and the wonderful jury who have been up for without a tea break. I truly appreciate you all. And I'm Madhvi Chikle, and I represent Holy Family Hospital. A little about the hospital, I have not put it in the slide, but I would like to tell you all, Holy Family Hospital, Bandra, is one of the hospital where Indian Postal has released a stamp for their 4 decades of compassionate care. It is run by UMI Sisters since 1978. So I really feel humbled to listen to your innovation since morning. And this is such a small thing. So really, it's a baby step for a 4 decades old hospital, but it's an amazing one. So this is VIP early. This is acronym you can see. It's Visual Infusion Phlebitis, Early Assessment, Reporting, and Line Inspection Excel tool. Okay, so the project phase. In this, what we saw was the problem statement, which actually was what we realized, which we all saw, was that there was a patient feedback. It was not like that all of a sudden that we came to it. It was one day when our executive director called me into the room and said, this is the feedback, Madhvi. There is 40% decrease in the first insertion rate. There is a feedback where patients are complaining of the increase of due to the infusion therapy practices, there is a gap. And again, there was, so these all problems. And then he said, come up with something. So there, what we did is PDCA, and we found out from our nurses what was going wrong. So we actually did a TOT. That is, first we evaluated our 300 plus nurses, where we found out their understanding of VIP score, visual infusion phlebitis score, was not there. There was a lack of understanding. So we did a TOT model. And then also the part where the reporting, when they saw it, but the reporting was not improved. So there is where we created an Excel tool, a tool with a drop down with all the parameters into it, where they put into the insertion date, they put into the site where the cannula was, and also the infusion that was going on, the cannula size. So all these was taken consideration into the Excel tool. And then we put it on the nursing desktop. Microsoft is inbuilt. We just had to use the Excel. And as we said, we are a mission hospital. So for us, cost is, it's a question that we have to think over. And then in the third phase, we actually implemented it in the third phase of it from 8th or 15th of August, and we started using it. So this is the same thing, the training. This is the patient safety matrix. So in this, I will tell you at the end of it, where did we actually reach out? We created a small Excel tool to capture the early reporting and assessment. But later, just 2-3 days back, when I was going through one of the accreditation, when the auditor called me, it is an Infuse accreditation which standardizes the infusion practices. And many of the renowned hospitals are accredited for it. I realized when the auditor questioned me, don't you have any other quality data or matrix capturing for your infusion practices? I just said this, but when she saw through it later on, we realized that we are capturing many more. We are capturing the indwelling time of the catheter. We are capturing the infusion practices. So lot many after this. And this is how we actually digitalize. You know, the paper taking and writing, we cancel that part. And actually there are drop downs. So my nurse doesn't need to type. She just has to select. And this is the impact you can see. So the reporting was 0 before that. We went to 211. And when I submitted this, it was almost 300. So when you see VIP scoring report, and on average day went from 7 per day to 10 per day. And the patient satisfaction, so patients improved. So from 20, it went down to 4 per month. And I would like to tell Kavo, thank you. We did use Premier. So this is the impact. So enhance patient safety, improve compliance, data-driven quality improvement, and reduce healthcare-associated infection. Also, it was a cost saving because we use the inbuilt Microsoft for it. And this is the scalability. So we started only with the ward. We have it now in all our nursing stations, ICUs, everyone captures it. And the best part, it is not only data capturing, it is also training my nurse. You know why? Because she understands the anatomical science. Initially, she used to say back of the hand. Now she knows right metacarpal. Like she's forced to study because she's selecting that and she's searching it in Google or looking into something to actually find out the set. So that's about it. And thank you so much.
Jury would like to ask some questions, please.
Are you planning to automate it?
We have just started it. So we'd like to explore it now. As I told you, it's a baby steps towards technology adoption, and would like to tell the audience as well as the juries, it is the first time ever Holy Family Bandra is taking part in Kahotech. So it's a very big thing for us. And this is with this, we will surely go ahead, ma'am. Thank you for
So
that.
this is based on the recent INS standards?
Yes, so many of the measures are based on the Infuse standards and the INS standards. They are connected with it.
Thank you.
Any other question? Thank you.
Thank you, ma'am, for the amazing presentation. So as you can see, we are among the last of the bests that are left, right? So we'd like you to be seated and keep clapping as hard as you can for the next presentation. Yeah. So we'll welcome Narayan Health. Can we have a warm round of applause, please? Can you all warm up your hands? Very good. On automated incident management, enhancing patient safety.
Good evening, all. Thank you, Kaho, for giving this opportunity. Today, I'm going to talk about a module which should not be there in the hospital on the first place, incident management system, where, can go to the next slide, where we don't want any incident to happen, but we are forced to measure it. We can't measure it, but because nobody want to just explicitly come and say, I did something. So that's the whole problem what we tried solving. So our journey started when we started our organization. Okay, sorry. When we started our organization itself. So till 2019, we were on the complete paper-based incident management system. And you know the problems. I don't want to go into that. And when we were starting to go for an organizational JCI kind of structure, we wanted to have a digital, completely digital tool. We started a form-based one. And again, I think most of you know what are the problems that we face with the complete form-based one. Although the incident reporting is increased, we are not able to see the complete potential of it, and we know that is tip of the iceberg. We know that is very less that we are seeing in it. Then slowly we created an ecosystem where all the applications, all the screens that are being used by the users, doctor from doctor app, nursing from nursing app, every screen, lab from their reporting worklist, everybody having a small icon click there, just put the information, whatever you want to put, upload any document if it is as a proof, it will create it as an incident. Now what happened? Suddenly the increase of numbers what we saw, it become 3x. Now the quality team started saying we can't raise these many numbers. And again, the whole structure goes to drain because you have to go for your, investigators to do it faster, not happening. So we used our small ML technology where it auto triages most of your incident. So previously with 8 steps, whatever, we are able to reduce it to 2 steps. So whole triaging tag reduced to 2 hours. Now that is fine. We have gone for organizational JCI. It is completed. We got the JCI. But one of the doctor told incident is just a metric for you, but it is a major disability for one of the patient. So that's where our whole thought process again changed. We created a complete automated one from HIS, from your nursing app, from doctor app. Everything is being automatically collected. If you say patient is coming within 72 hours after your discharge, it is collected at the source. So you don't need to do anything. So when we started this process, initially we started with one hospital. Suddenly it went on to all the 17 hospitals within 3 months. Now this is being even used in some of the other than Arena hospitals as well. So these are the numbers. So sudden surge of incidents what you will see in your hospital, slowly your CAPA also will go accordingly and the incidents will come to the closure. So we are seeing a future, may not be 100%, but somewhere at least 95% of the incidents should not be reported. It should be automatically captured at the source, will be triaged automatically, and the relevant people at the same time will be reported. So incident is happening and going, and now we are going ahead with the near misses also. You don't need to wait that to happen before even that. Maybe a half an hour before itself, you will be able to trigger that respective resources. And this is what we want to see. An incident, if it is going to happen or happened, the user whomsoever is raising and the CEO of the company will be able to see at the same point of time. And one thing that actually helped in this is it changed the whole ecosystem. Previously, it is more of hiding that incidents what are happening. Currently, it is like highlighting what improvements that they are doing. This is what our clinical director keep on saying. We came from hiding to highlighting process. And it is very easy. I think everybody in your HIS you can do, or any application that can just latch upon to your process and take these instead. That would be a best application what we are seeing. Thank you.
Can we have some questions, please?
Time is a major measurable element. I think I completed before my session.
Absolutely. Very nice.
Currently 128 according to JCI we have the incidents one. 76 when I'm talking 76 and again it is very interesting. When we went to emergency department, they themselves said, why I already doing everything in EMR. Why should I want to again write one incident? Can't you pick it up? So that's how it started. So the workflow diagram, what you are doing, what you saw is generated or just drawn by that particular department. We have given that option at the automation layer. So they can define their own steps, automatically that will create an incident. So
Those parameters which are not included in your HMS. So any plans to integrate it?
that is again, now your digitalization process will be accelerated because as a departmental head, you will say, hey, I'm not capturing this unnecessarily or making me do manual work. You incorporate it in the application. So this is again, that's what I said, right? The whole ecosystem thought process will change. You
Thank you.
want to digitalize
Thank
so
you.
that you don't need to do extra work.
Thank you. I have a question. As similar to what ma'am was saying and adding on, there are a lot of processes that when delayed or not can be called as incidents, but there are a lot of incidents which are physically happening and clinically and physically happening, like falls, needle stick injuries. Hmm.
All sensor will give you fall or a fall near miss.
Right, right.
But still that is not included in the 73, still in the pilot case. So you can, but 100% you may not be that 5%.
Like contributory factors. For example, if somebody is intubated, again, if you're indenting an intubation kit, it automatically says why. So
Usually don't ever
No, there that is re-intubation. So do you have such contributory factors incorporated as a trigger into the system?
Ma'am, I think with that thought, with the reintubation and all, I think we can discuss those answers because billing plays a very crucial role. And whenever any reindent or anything happens, me also, yes, me also trying to do that. With the fall, because of the remote monitoring, we can do the fall sensing because there are accelerometers in remote sensors now. Yes.
Billing, what you're saying, billing now completely incorporated into the workflow. So no billing person will capture anything. When you are doing a insertion of line, automatically nurse will say this is inserted and bill will be generated.
All the incidences can be captured at the source. So what? Yeah, so
still,
yeah.
yeah. So our first layer itself, we have democratized the incident reporting. Anybody can just report. Yeah. So what we saw, most of the doctors previously, if you say 1x is the incident reporting, after giving it to their mobile app, it increased to 4x. So that is first is democratizing that any application can do, or as a independent module you can latch upon. If you want to really change the whole workflow, then automation. Probably we need another complete session with you one-on-one.
Yeah, is this name to the solution? Yeah, or is it an in-house build or?
But now we power multiple other organizations.
So you're independent now. Datma has come out of Narayana into the system. Thank you so much. Thank you. Really nice presentation. Thank you. Can we have a round of applause for them, please? And in continuity, we have Dr. Jivraj Mehta Hospital coming up with CMIS, Clinical Management Information System, and CMIS for Nursing Clinical Management Information System. Can we have a round of applause for them, please? Thank you.
I'm Dr. Agarwal, CMS at Dr. Jivraj Mehta Hospital. Our hospital is 205-bedded hospital established in 1989, registered under Competitors Act. We are accredited by NABH Division, NABH ER, Nursing, Blood Bank, and NABH Digital Platinum. How this project matters? Why this need arose? Documentation. The need arose from fragmented documentation, manual documentation, risks, critical challenges, and decision making, manual documentation, and compliance gaps. Challenges which turn into opportunity for transformation. We followed a structured milestone-based approach. Our goal was to standardize the workflow across the department. So we identified a super user, and with phase-wise implementation, we achieved 80% of digital documentation within 6 months, and our goal was to complete adoption within 12 months with complete user feedback and real-time improvement. We started with a detailed baseline assessment in highly impacted area. Based on this, we selected CIMS in compliance with NABH and with multiple meeting of clinical team with IT. We started comprehensive training program for clinical master and user. After we started project in phase-wise implementation to know the workflow and identifying the challenges before scaling up. Weekly review meeting was held to gather the feedback. Once the pilot project succeeded, we moved on hospital-wide adoption supported by performance dashboard and real-time monitoring of key metrics. This is our outcome. We achieved 100% digitalization in lab, radiology, pharmacy, billing, admission. We implemented the project in OPD. Although you all know it was very challenging to convey and train our clinician. Then we implemented the project in IPD. We started with initial assessment of clinician, nursing, dietitian, vital chart, intake, output, handover. You can see snapshot of our real-time patient dashboard, which is admitted in ICU. Here, this is a comprehensive dashboard display, demographic detail, allergy, recent vital. Green panel features of multiple tabs. Below, through this tab, you can assess the detailed clinical information of the patient. After successfully implementing the system in our hospital through modular HIMS design, system integration, proven framework, it can be easily replicable to any other hospital because one-time effort, long-term gain. Success always comes from teamwork. Our board of trustees and higher management ensure timely motivation and resource allocation. Multidisciplinary team of clinician, nursing, quality, IT work collaboratively. We selected department-wise champion, master user, super user, and user. Continuous training and feedback loop and rollout plan ensure timely execution. Collaboration between technology and clinical expertise make this transformation sustainable. We used creatives, we use a user-centered approach, gamified training tool via Kahoot and Sildo, peer mentoring, real-time clinical dashboard, make our employees driven engagement. Moving forward, our goal was to integrate AI power in analytics in clinical prediction, module expansion across department, 100% paperless future. Our journey from fragmented paper-based system to unified digital excellence, the future of healthcare is here. Thank you, Kahoot 2025, to giving us opportunity to presenting our journey where technology is not replacing care, it's enhancing it. Thank you.
Thank you, ma'am, for the presentation. Jury, may you please ask your questions? Any question from the audience if they would like to ask? Sure. Thank you, ma'am. Thank you so much. All right. So we are 30 minutes ahead of time. We are keeping very good value of time and of yours also. And thank you, Raja sir. Yes. Yes. So we have a little small announcement that all the finalists who have come today to present from across the city and the states and nations and internationally will be receiving their finalist certificates today on the stage itself. And we also have, apart from the winners, we will be selecting 8 members, 8 presentations, which we will be presenting tomorrow in Kahotech in the second session, post lunch session. We'll be having the first session post lunch for an hour in which we'll be having 8 presentations which are presented today uniquely. They may not be the winners, but they are special presentations which from the jury may or may not be the winners, right? But I mean to say that they are apart from the jury selection, and we'll be taking them as a nice learning opportunity for the people to know, right? So coming to the next presentation, I'd like to invite AIG Hospitals. Are they here? Thank you. For high-level disinfection of transvaginal and transrectal probes in high-volume centers. Can we have a round of applause for them, please? Thank you.
Good evening, everyone. I'm Dr. Akshita, Clinical Administrator from AIG Hospitals. Today, I'm presenting on the topic effective disinfection of transvaginal and transrectal probes in busy healthcare settings. This initiative was collaboratively implemented by the radiology team and the infection control team and co-authored by my colleagues mentioned here. And our major goal is for patient safety, operational efficiency, and compliance with international standards. So to begin with, during our JCI reaccreditation in November 2024, there were several gaps identified with regards to high-level disinfection. At that time, we were using glutaraldehyde as a high-level disinfectant for vaginal ultrasounds. So there were other challenges too with regards to this process. Probes could not be disconnected for reprocessing due to heavy patient volumes, and ultrasound rooms lacked enough ventilation, raising safety concerns for the patients and staff. And overall problems in this were the documentation gaps because we weren't able to track each and every disinfection cycle. So we have formulated SMART goals. To be specific, we have implemented chlorine dioxide wipe-based high-level disinfection with traceability system. So to measure with, we want to achieve 100% compliance and less than 5 minutes of disinfection time. And to achieve this, we have trained all the stakeholders, that is the housekeeping staff in radiology department, and to align with all the international standards and to achieve all the goals in 3 months. Methodology, we started this process by procuring crystal chlorine dioxide wipes. As mentioned previously, we have trained all the radiology housekeeping staff, and we have integrated with the 3T mobile app for tracking. It's very easy. The housekeeping staff will be guided in the mobile phone itself how to perform the disinfection process with each and every time, with each and every cycle, with the time mentioning over there, as you can see in the picture. And the physical and the digital, like the integration made the process easy, and also accountability for the one who is performing the process. And these are the dashboards. So like the first dashboard is the which person has performed which disinfection cycle and at what time and at what location and with which device. And the next dashboard is the admins and whomever can actually access it and just have a look what's happening around and who are the end users. So this process, we were taking continuous feedbacks from the end users, and we made the process more smoother, and we have made some changes too. And continuous monitoring was done by infection control and the quality teams. And the outcomes were very encouraging. If you can see in the slide, we have decreased the time. Like previously with glutaraldehyde, we were like doing the disinfection process for about 20 minutes. But with this new technology, what we have adopted, like the time has been decreased to 2 minutes 10 seconds, and the traceability and documentation is via 3T app. And the total number of TVS and TRS cases from September 29 to November 8th is around 514. And we have achieved 100% compliance with regards to documentation and staff training by adopting this process. And the environmental impact, as we have eliminated glutaraldehyde, there was a minimal hazardous chemical waste for patients and staff. And this is very easily scalable. It can be used for all non-limited medical devices and can be used in other departments too, such as ophthalmic and NAS endoscopes, such as for ENT. And there is no dependency on central processing rooms. And it can be replicable in high volume centers. And the technology is validated in US and Europe. And it's going to set a new national benchmark in infection control practices. Teamwork. So there are 4 teams involved in this: radiology, infection control, CSSD, and quality. And there are continuous regular review meetings by the Infection Control Committee. And the innovation, it's India's first hospital to use chlorine dioxide wipes and 3T digital traceability. We have moved from manual logs to real-time digital monitoring. Our focus is on patient safety, compliance, and speed. Thank you.
Thank you, team. Over to the jury for questions.
Do you use the probe straight into the vagina and rectum,
No,
or do you
we
use
have probe covers.
Okay.
Yes.
Just want to clarify that. Thank you.
Yeah, any other jury queries? So that was the 45th presentation of the day. So next up, thank you, AIG Hospitals team. Next up, we have the 46th presentation and the last presentation of the day, which is going to be from Master Whitefield Hospital on surface guided radiation therapy, SGRT.
Firstly, thank you, Kahotech, for recognizing and giving us an opportunity to present here.
And last but not the least, the audience is also here for you.
Thank you. So I will be, as you know, I'm a radiation oncologist from Master Whitefield. We have the surface guided radiation therapy system that we have incorporated. I will not go too much into the tech. I will go directly into how we incorporated that into our system. It is about minimalizing our procedures and efforts. So the issue that we have, radiation goes over 6 weeks, daily patient has to be in the same position. We work on sub-millimeter accuracy. We want the patient in the same position every day. We do a lot of radiation imaging to make sure that the patient is in the same place. Even then, real-time positioning, we don't know. Patients can move during treatment and the whole process goes aware. So we needed a real-time positioning accuracy method, and that is for during the procedure of treatment as well as between different fractions. So SGRT allows us to monitor the patient's surface through both phases, the setup as well as the treatment, with exceptional accuracy, and allows us to gives us comfort in boosting this. It utilizes tracking. We use a structured light process which is used on the patient's body, and that is used for positioning the patient. And it uses 3 camera units, gives around 2.6 million nodal points, which can be used accurately to position the patient. Now, benefits, I'll just go to one, the video running down. You can see that is being tagged along with the breathing of the patient. When the patient takes a deep breath, the room light changes to green. So he or she holds their breath at that level. And there's a photograph on the top right where the patient's hand is not in position. So you can see the red light coming up. So we have corrected immediately, and we have been able to correct the patient's position on the table itself. So it's non-invasive, time efficient, very less radiation exposure, eliminates traditional immobilization like tight masks and vac locks. It supports something known as the breath hold technique, which is used for many cancers. So there is a smart method here. The specific goal was to real-time position accuracy. The measurable progress was we verified that with the X-rays and the CBCTs that we were doing conventionally. We achieved the clinical flow by accomplishing all for breast cancer patients first, and then we converted it to all cancers in the next 6 months. The relevant outcomes that we achieved was accuracy of daily positioning and follow it, reproducing the same over the entire therapy period. And the time needed to incorporate, within a year, we were able to push it to all our patients, which was not usually done in our 20-year period of where the Linacs came over. Outcomes achieved all across the board. So you can see patient-related discomfort is reduced, no tattoos where pricks were used, and tattoo-less treatment, so emotional well-being. For the doctor, the treatment delivered is accurate, real-time monitoring is possible. You are confident about the kind of treatments you're giving, and it reduced the imaging, so it was a helpful thing. For the hospital, there was cost reduction because of not using immobilization devices. You are using, for more number of patients could be treated, the throughput was more. As well as for the environment, because we're using less plastic because of not using the immobilization devices. So it became a good tool for environmental help also. So collaboration was an important component. There are lots of different specialists in our own department, physicists, the physician, the technologists, and the radiologists. So we needed collaboration across the board. There was daily interdisciplinary meetings that were held to align these goals. And each member brought unique expertise, and that helped in integrating the SGRT into our workflow. And additionally, we collaborated with external stakeholders. Because of the third-party unit, we had to get others to help us to collaborate and set this up in our system. So challenges were always going to be there. Because it was new, the challenges were inevitable. Integrating it into an existing system required ingenuity. We faced hurdles in training staff due to the understanding complexity of the system. And even educating patients was difficult. Our adaptability was key. Training programs were refined based on feedback. Efforts from both staff and patients embraced the SGRT confidently. And the project embodied our core values of excellence, innovation, patient. So through SGRT, we have not only advanced technology, but also prioritized the well-being of our patients, redefining the care standards in oncology. Thank you.
We come to the end of the session, the final presentation, Q&A by jury.
So you said you're not using any immobilization devices to immobilize patient. What was the time duration in positioning patient between using an immobilization and using this one?
Ma'am, we have found that there is an improvement almost 4 minutes per patient. Turnaround time for without the use of the regular conventional imaging that we do. So there's an improvement of about 4 to 5 minutes.
Any other questions?
Since you're not using the immobilization, what is the cost savings? Have you done that kind of?
So we have not yet come to that. That's usually an annual affair. So we need to find out what's the cost saving happening there. But let me be clear, this is not like we can get away with doing only this. because there are limitations for this system. It looks at the surface. It does not look at the back of the patient. So any tumors which are more posteriorly placed, we cannot use a surface guided and get away with it. So we need imaging also. But for cancers which are more anteriorly placed, we can get away with doing the surface guided.
Cost benefit would bring some smile with Shrikant as well.
Yes, I think you know him too. He's very happy about it.
Thank you so much, Aster
Thank you,
Whitefield
thank you.
Hospital. We come to the end of the second session. I'd like to thank all the jury members for keeping up the timelines, and some of the jury members who have stayed back for the afternoon session. Also, thank you so much for your patient judging the event. A big round of applause, please, for all the jury members. Thank you so much, Dr. Ayush Gupta and Mr. Rajarajan. Mr. Raj was the best timekeeper I think I've ever seen. Both of them were very strict about the timing, and Raj was monitoring the time. A big round of applause for them. And thank you, audience, for your patient listening in spite of not having a tea break. Most of you all were there here inside the hall. Thank you so much for that. Now, may I give over to Ms. Lalu Joseph, Dr. Lalu.
Hi, good evening, and thank you all. This is so nice to see the entire audience here. Let me just give you some perspective about how we started this hospital innovations. So this is the first time in person. Every year we do it. For the past 7 years we've been doing, but always virtual event. So this time we thought it's important because this is so much of learning for everybody that, a lot of best practices we can straight away go and implement in our own setting. There are several challenges that we face. We have the hesitancy to start something. So when we see our peers doing it, then it gives us the encouragement and motivation to start in our own setting. So I have a lot of people to thank. I have been single-handedly running the show for several years. Now there is a huge workforce and it is done in style. I must really thank and appreciate the efforts of Dr. Ayush. Let's give him a big round of applause for taking on the lead. Please come. Yeah. And ably assisted by Dr. Rajaraj, who took on for the national participation. And Dr. Rahul Deshmukh for the international participation. For the first time, we had 21 participants from other countries, including one from Pakistan who couldn't join and 3 others from Bangladesh. I think they've joined, isn't it? I heard that the visa. Yes. And Madam Bobby Ramesh for the brilliant support for putting this event together today. So to summarize to you, we had 120 applications. And out of the 120, the first round of shortlisting was done by about 40 jury that we had handpicked. So we brought it down to 80 submissions. And the 80 submissions had 2 rounds virtually. And then we brought it down to about 30 first. Then we said, let's give more opportunity to everybody. Then we brought it to 50. So those are the 50 submissions that are here. Great learning experience for all of us. So we thought we must give the finalist certificate to all the 50 hospitals that have participated today. So let me take this opportunity. It's certainly not easy. You've all taken your time and efforts to be here with us today. So KAHO, as you all know, is not an organization belonging to a couple of us. It is your organization. It is a stakeholder-based organization. It's a not-for-profit society established to promote quality patient safety and accreditation. So by virtue of doing this, you're all our stakeholders. You are the main people. And to be very frank, it is your organization, not our organization. So welcome you all to KAHO. How many of you are life members of KAHO? Great. So the rest of you, please join KAHO. How many of your hospitals are members of KAHO? Wonderful. Great to hear that. The first time we ran, it was only one hospital that put up, and that was my hospital. So thank you so much. So let's invite the finalists one by one and hand over the certificates. I request Dr. Deepak Mitra to kindly come on stage and join us. Dr. Deepak Mitra is part of the organizing committee from Orissa, and he's promised to give us some wonderful prawns today. And Dr. Soumyakanta Satpathy to please join. We have to give Dr. Soumyakanta a big round of applause for opening the gates of this beautiful organization. And I also would like to request Dr. Vishwajit, yeah. Sir, please come and join us, sir. Ruben Memorial Hospital. Sir is our Bihar State Chairperson. He's also here. Satyajit, sir, please join us. So let's invite the finalists one by one and hand over the certificates to them. Rajaraj, you're going to do it?
Yeah, starting with Apollo Hospitals, Greaves Road, Chennai. Christian Medical College, Vellore. Sri Kamachi Medical Center. New Mowassat Hospital, Kuwait. Ruby General Hospital. Ruby General Hospital. Next up, AJ Hospital and Research Center. AJ Hospital and Research Center. Team AJ, that's you? Yeah, okay. Yeah, no, yeah, like, no, okay, fine. Yeah, that's the third time today. So KPJ Specialized Hospital, another international participant. Next up, Kaveri Hospitals. Give it up for KPJ. Kaveri Hospitals next. Ruben Memorial Hospital partner. Narayana Health. Ruben Hospital partner. Next, Narayana Health. Basavatarakam Indo-American Cancer Hospital and Research Institute. Next, we will have Royal Care Super Specialty Hospital, Coimbatore. That's Basavatarakam team for you. JK Hospital, Kottayam, Kerala. Next up. This is Royal Care team for you with Insightech. Dr. Jeevraj Mehta Hospital Clinical Excellence. That's JK Hospital, Kottayam. Jeevraj Mehta Hospital all the way from Gujarat, please. Yeah, of course. Once again, New Mowassat Hospital. Next. BM Birla Heart Institute. That's New Mowassat all the way from Kuwait. BM Birla Heart Hospital. BM Birla Heart Hospital. Next up would be Dr. Jeevraj Mehta Hospital for HR Excellence. Dr. Jeevraj Mehta Hospital for HR Excellence. We'll have now, after Jeevraj, we'll have Medcare hospitals and medical centers for HR Excellence.
The audience also clap.
Yeah. Once again, I call upon Basavatarakam Indo-American Cancer Hospital and Research Center. Next up, we'll have BM Birla Heart Hospital, CK Birla Hospitals. Next, can I have Medcare Orthopedics and Spine Hospital? All the way from the Middle East. Next up, we'll have Peerless Hospitex Hospital and Research Center Limited. Followed by Rajagiri Healthcare and Education Trust. I think Sujit and Father not here. Trauma Center, IMS, BHU were also not here. Atulya Senior Care. Rajagiri is okay. Yeah, sorry. Yeah. Yeah. Father and Sujit left. Sorry, I didn't see you. Yeah. Atulya Senior Care for the chat, WhatsApp chat ops. Once again, Basavatarakam Indo-American Cancer Hospital and Research Institute. My friend, my friend Sunil Tandon would also be very happy. Yeah. Yeah. Next up, Parul Sevashram Hospital, Vadodara. We'll be there next week. Next, we'll have CMC Vellore Ranipet campus. Madam, one more, you can. AIG Hospitals, Hyderabad. Medcare Orthopedic and Spine Hospital for Clinical Excellence. Rajagiri Healthcare and Education Trust once again. Holy Family Hospital and Medical Research Center, Bandra. Yeah. They had 3 applications. Yeah. Next time I'll not call, I'll give it. Astor Whitefield, followed by the Holy Family Hospital and Medical Research Center, Bandra. Astor Whitefield for their surface guided radiation therapy. Apollo Sage Hospitals for Learn with Apollo. Charnock Hospitals. Next up would be Charnock Hospitals Private Limited for Clinical Excellence. Rajagiri, I have the next certificate. We'll hand it over separately to you. New Moasat once again. Oh, you want to come. New Moasat for HR Excellence from all the way from Kuwait. Aster Sanad Hospital, Riyadh. Okay, you can connect it, yeah, the team. TMU Hospital was online. Kinder Hospital for HR Excellence. Madam. Give it to me. Another round for CMC Vellore. We'll directly give it off. The host, the Kalinga Institute of Medical Sciences. A big round of applause to them. And I think they were in the session over there. So, yeah, but Satpathy sir can connect it in behalf. Yeah. Apologies. From the complex system of Apollo Hospitals, Bhubaneswar. Next up, St. Peter's Medical College Hospital and Research Institute in partnership with Medicine VR. Next and last is Sarvodaya Healthcare Faridabad. Your team. All of you should go. Yes. Rajagiri, you can come and collect one more certificate of yours. Sorry. Yeah. The last of Rajagiri. Thank you all. Thank you to the we would call in the jury members to join us for a photo opportunity. Yeah, then we also have the dinner start at around 6:45. We request you all to be seated at Rose Garden, which is next by. We would share the link if anybody wants to get to that place. It's just next door. It's at the next campus. So jury members, please come on the stage. So you can share a few bites of how you felt being a jury. Yeah, we'll take a photo, but let them first, the jury members, let them talk and tell how did they feel about. Clara, madam, you have spoken in the morning. You want to add something more? Yeah. Dr. Smita? Yeah. You can introduce your name, your organization, designation, and then give your bites. Yeah. The entire, for whole, yeah. Should I time this also? Yeah.
Good evening, sir. Good evening, all. Thank you for having me as a jury. It's a great opportunity for me to be present. I'm Dr. Smita. I'm the Chief Operating Officer of HCG Hospitals in Bhubaneswar. Like Rajarajan sir, I have known Rajarajan sir since a long time, and he have always been mentioning about Kaho, and this is the first time I have joined this. I would like to congratulate everybody who have participated. It was an amazing learning experience for me and for everybody present here. Keep up the good work, sir. Thank you again.
Good afternoon, everybody. I am Dr. Sumit Kumar Khan. Right now, I am the Associate Director in Netaji Subhash Cancer Research Institute at Kolkata. Though I am a life member of Kaho from long time, But this is the first time I am coming to Kahotech, and also what Lalu Madam said, this early adoption, this is the first time on stage and I am the jury. So I am a lucky one. Thank you, ma'am. Thank you for this opportunity. And again, thank you to everybody.
I'm Deepak Mitra. I'm from Cuttack, Sun Hospital. It was a wonderful opportunity to come and be here. So many things to learn. Thank you.
Hi, I am Dr. Suchanda, medical head from Fortis Hospital, Anandpur. I have been associated with KAHO in the antimicrobial stewardship program. This is the first time I was a jury in the technological part of the KAHO, and it was very, very interesting, very difficult, and very exhaustive also, because the judgment was really very difficult. Thank you so much. And thank you, KAHO, for giving us this opportunity. Thank you so much.
Good evening, everyone. My name is Viresh. I am the IT head for Ashram Educational Society. First of all, I want to thank Mr. Rajarajan for introducing me to KAHO. I was not in India for so long. I was out of India for 9 years about. And this is the first time I'm on any kind of public stage or any forum. And he made me to sit directly into the jury. Hardest job, as she said, to do, because everyone was wonderful. Everyone was putting their effort in there to bring up, bring in the, quality to their each and every aspect of the work. So it is injustice from our side if we say that someone is first, someone is second. But yeah, but there is a scoring mechanism. There are parameters given, so we had to stuck to that. So yes, I think we have done our job well. Thank you very much for the opportunity for KAHO.
Good evening. Good evening to all. Myself, Dr. Mahalingam Vengadeshan. I'm from AIMS Bhubaneswar. I was doing similar kind of work, little experience in Skill India Government of India projects, and really thanks to the organizers who brought me into the KAHO. At the same time, yes, of course, we do so much about compact places, compact hospitals. It's a great things to see. At the same time, maybe let me see future that we will move towards to the periphery areas, tertiary care hospitals, where we can make small things and big changes. Thank you all.
Hello, good evening. I am Anurna, admin head, Fortis Hospital, Sanandapur. So the second session also went off so excitingly well. And yes, lot of learning for us also, new ideas we have seen. And definitely we would be able to implement the things. Thank you all. Thank you, KAHO.
So thank you all. Let's give a good round of applause once again to all the jury, the organizing committee. So you will get to hear from our team this evening, maybe at around 8 o'clock or beyond that, as to which are the teams that are going to be presenting on stage. We are proposing to have about 8 teams, but exactly 5 minutes only, then we'll be able to do justice to 8 presentations. And of course, the prize winners as well. I'm sure all of you are going to stay back. It's a beautiful city, enjoy, go shopping, but join us for dinner before you do that. The curtain raiser is from 7:15 to about 8 o'clock. It's a very short program, followed by dinner. Networking is very important. Collaboration is the norm, without which it's very difficult as an industry for us to come together. So please be part of it. Welcome once again to KAHO. Best wishes. Have a great evening. Thank you.
Thanks also to Sandeep for the wonderful AV thing and all the team behind. Thanks to you also, Madam, from Sarvodaya, from the nursing leadership team. Thank you. Thank you for the volunteer. Come forward. Ladies on the first line and men on the second line.
Oh my God, what respect.
We'll have one photo with the participants. First with the
Come, son, please, let everybody come.
Yeah, okay. Please, flank us, join us.
Sir, you be here. Brother.
You should be the center of attraction.
I'm a hot.
Sana. No. Stand over.
Vinod sir, you can come here. For the photo.
Danya.
Come, Danya, come.
Adil, come.
Ranjit sir. Tuluel. Ajit sir from Tuluel, come. I'm doing enough branding for you.
Come, Adil, sir. Please come. Not taken with me.
Yeah, all the participants, delegates, jury members, everybody, please come on stage, please. Amita, we don't mind if they have AI camera, let's take you there. Camera. Priyanka is not joining us.